from within the country, and more than 900 delegates from 24 countries participated online. This year, we are doing it as a physical activity, but at the same time, we have opened the attendance for online joining also. And I'm happy to inform that till I last checked, 695 delegates from more than 30 countries had already registered online. Today, we are starting with two special lectures, which are of general interest, and that is why I requested the academic in charge of our institution to allow us to hold this as the weekly clinical combined round of the institute, which is held on Friday 9 to 10, so that our faculty and students can also benefit from this. And I thank the academic department for that. And without further delay, I would request Dr. Anand to start the scientific proceedings of the JSF. I think Anand is outside, so I would request Dr. Sandeep Nijhawan to come and moderate the first session. Dr. Vikram Kate. Dr. Nijhawan is one of the senior gastroenterologists of Jaipur. He is the president of the Indian Society of Gastroenterology. Dr. Kate is the chief of surgery at Jaipur, Pondicherry. And besides his surgical skills, he is known all over the country for his scientific temper and his keen interest in scientific communication. I would request Dr. Kate to please start the first special lecture.
Good evening, everyone. Starting a scientific conference with different topics which are important not only for surgeons, for physicians, for every super specialty of medicine. And to deliver the lecture, we have Dr. Vikram Kate. He is professor of general surgery and gastroenterology surgery at Pondicherry. And over 175 publications, he has written 2 books, and he has as many as 45 chapters to his credit. He is a member of Surgical Specialty Board of Royal College of Surgeons, Edinburgh, and a member of the Research Committee of the Society of Surgery of the Alimentary Tract, USA. He is a past president of ISG and is the editor-in-chief of International Journal of Advanced Medical and Health Research, the official publication of JIPMER. He is the recipient of Distinguished Teacher of Excellence Award of the year 2018. So I request Dr. Vikram to deliver his lecture. No, I think that would be the second one. Yes. Dr. Vikram speaking on systemic review of meta-analysis of the research. Research is done, but ultimately the end should practice, and that will be system and meta-analysis should follow and see where we right and where we wrong. And for that, we can cut with us. Please.
Thank you very much, Chairperson, sir, for the kind words and the introduction. And at the outset, I would like to thank Professor V.K. Kapoor and his whole team for inviting me for this prestigious JSF festival. I'm very happy to be here in person and coming in person after 2.5 years. It's a great experience. And I'll be discussing something, it's not that I will call myself an expert on systematic review and meta-analysis, although we have published many randomized controlled trials, but some systematic reviews we have written and little bit experience we have on meta-analysis. So I'll try to share some of our experience through this lecture on systematic review and meta-analysis. So my talk will cover why there is a need for systematic review and meta-analysis, what is a systematic review, how we did one systematic review through which I will share our experience, then what is a meta-analysis, brief outline of the steps of a meta-analysis, how to interpret and analyze a forest plot in detail. And this is a little bit interesting for the trainees, for the people who are not familiar with the meta-analysis, because it's not a question of writing a meta-analysis, it's a question of first understanding and reading meta-analysis, and briefly a little bit about publication bias. So as you all know, levels of evidence when we talk about it, so these are the few figures which we come across in literature, online, and this usually shows us that when we look at these two things, the meta-analysis and the systematic review of randomized controlled trials, they sit right at the top. They provide, when we're doing any systematic evidence for a particular condition, for the management of certain disorders, and if you are a particular person who practices evidence-based medicine, we'd like to have the best possible evidence from the literature for the management of the patient. And these are the two types of publication, systematic review and meta-analysis, that provide very good evidence. Now, these are some of the recently published randomized controlled trials. If you see the first one, it is adapted ERAS pathway versus standard care in patients with perforated duodenal ulcer. Here, what we have seen is that adapted pathway can work in emergency setting, and as you can see, it has been included into an SSAT plenary presentation of Digestive Disease Week. It's one of the largest GI conferences in the world, and published in a good journal, Journal of Gastrointestinal Surgery. The next one is we wanted to see the perioperative high oxygen concentration, whether it works in reducing the surgical site infections after elective colorectal surgery. Again, it was a randomized control trial. Again, it was presented in that conference in a plenary presentation. These two, we saw that the efficacy of pregabalin antioxidants combination, whether it reduces pain in patients with chronic pancreatitis, hunger-based versus conventional oral feeding, whether we can, the patient is hungry in patients with acute pancreatitis, severe acute pancreatitis, can we straightway start feeding? So all the randomized controlled trials published in fairly good journals, does it provide evidence? Some more here, again, ERAS pathway in emergency small bowel surgery or perforation peritonitis. Now, what is the problem with this? The problem is these are all published in good journals. These are all presented at the highest level in the meetings. These have been selected in plenary presentations. But these are all investigator-initiated trials done in a center, in one country, in one place. So can they be called as a final evidence, a good randomized controlled trial? If I say A is better than B, does it become a documented evidence? There could be somebody who has said that B is better than A. Have we looked at it? Has somebody found B is better than A, but because it becomes a negative study, they have not published. So is there a publication bias? This is what leads to publication bias. When you do not get the result, the desired result, there is a possibility that because it is a negative study, you may not publish it, what we call it as a file bar problem. And then if you just look at the evidence based on randomized control trials, you will miss this part of the evidence. And this is that's why required. If you see in the first part of the figure here, this one, you can see the left side figure. You have a symmetrical normal distributions of the published studies. You have some say that treatment does not work, some say treatment works. On the right-hand side, you have treatment works, practically only one study which says treatment does not work. So if you have to take evidence from these two types of plots, the left one is more documentary as compared to the right. So this is what is called as publication bias. So that's why we need to do a meta-analysis and systematic review to gain proper evidence. So how systematic review and meta-analysis is more helpful as compared to individual studies? It answers questions more effectively than individual studies, identifies problems in primary research corrected in future studies, future research priority it can identify. Of course, it is of benefit to the authors and journals, as it's a higher place evidence. It will always be considered better compared to individual publications. And as I said, that is why it generates higher level of evidence. When we look at the literature for evidence and when we look at review articles, broadly speaking, we can classify in three types. One is a narrative review, then one is a systematic review, and one is meta-analysis. Now, narrative review is like a chapter in a book. It is like a review on a particular topic, and you have the publications in last few years on that. That is how you will have evidence. You look at it, but it doesn't have a pinpoint focus. It doesn't have a particular research question which it answers. When it is a research question focused review, that is what is a systematic review. And when we do an statistical analysis on the published studies only have statistical analysis, we do additional analysis and then provide evidence. That is why it is called as meta-analysis. That is what is the quantitative type of review. So how do you define systematic review? A comprehensive search for relevant studies on a specific topic, and those identified are then appraised and synthesized according to the predetermined and explicit method. So what does this mean? On the right-hand side, we have published a systematic review sometime back in a good journal, Drugs, which has got an impact factor close to 9 now. Through this, I will just share our experience. These are the elements of a systematic review, how we carry it out. The first and most important thing, first of all, on what topic? What is the research question or review question you had in mind? Write a protocol. It's always better to, even if you are doing systematic review and meta-analysis, better to get clearance from scientific committee as well as the ethical committee. You can always ask for a waiver there. Search for and include primary studies, assess study quality, extract and analyze the data. This was systematic review. Then interpret the results and write a report. Now, through this article, I will just take you through like what we did when we wrote this systematic review. Now, this is the objective or the research question we wanted to answer. Two drug agents, sequential therapy and standard triple therapy, are used for the eradication of H. pylori infection. We wanted to see which has got a better eradication rates, and the second outcomes like adverse effects, cost, and etc. So what do? We go to the literature and look for the standard databases and retrieve all the information, all the studies which are published on this particular area. It is very necessary that you should try to get all the published studies as far as possible in a predetermined period, whatever. It can be 5 years, 7 years, 10 years, whatever you want. By using all the possible databases and all the possible keywords. You can see right hand side, if you put the keywords properly, you can go up to 586 articles. If you don't put the keywords properly, you may miss the articles. If you miss the articles, then the evidence what you are collecting may not be satisfactory. So once we did that, once we did that, then we had, this is a typical Prismarch flow chart which is used for systematic review and meta-analysis. We identified 160 studies, 163, then added 14 by manual identification, 177 studies overall, and this is 60 studies for various reasons were excluded from the analysis. When you look at any Prisma chart, you'll find like that. You'll find many studies are included, then most of the studies which do not fit properly, they are excluded, and then you have a core group of studies which you are going to use for the analysis. So here we had 17 studies. So doing the studies, what was selected, and you can look at the top. These are the two regimes, and this is what we were. This is the primary outcome: eradication rate, adverse effects, compliance. All these things were the primary features which you wanted to look in those particular studies. The data has been extracted. Once you extract it, you analyze. That's why I said you cannot have 40, 50, 60 articles. First of all, there will be a lot of variation and you will not have the proper focus. So we have selected 17, you can have 15, you can have 2. It all depends on the type of publication on that particular topic. And then you write the report. So this is the report based on those particular. And then discuss on it. So that is how a systematic review is written. And this is the final answer. The objective of the systematic review was to find the evidence of efficacy of these regimes, adverse effects and cost. And you can see the reply, the conclusion what we have got based on the 17 RCDs. The 12 actually reported better eradication rates, 4 did not find, and 1 had the standard triple therapy better than the sequential therapy. So what we found here was sequential was cheaper alternative, no increase in adverse effects. Although 2 said good efficacy, most of these studies came from Asia and Italy. Italy, the Zula is the person who actually identified and described this regime. So what we suggested as a conclusion, unless and until we have more studies from all across the world, we may not be able to give a definite conclusion. So that is how we have given, and that is how the systematic review is written. That is how it is presented. Now, this is systematic review, no analysis, no statistics used. If you want a higher level of evidence, as I said, 1A, that is meta-analysis. What is a meta-analysis? It's a statistical combination of at least 2 studies to produce a single estimate of the effect of the healthcare intervention under consideration. Even if 2 are there, use statistics, then that is something that is also called as pooled analysis, which is not very commonly carried out. It has to be registered, systematic review or meta-analysis in this Prospero. They will give approval. These are the elements, around 40 are there. Then you have to enter all these things, and then you get the approval. Once you get the approval, it is a registered trial. As we register randomized control trials in consort, this is registered in Prospero. Once you've got, you side by side start writing the meta-analysis. Establish summary data, graph data, convert into graph, check for heterogeneity, perform a meta-analysis if there is not major concern about heterogeneity. If there is heterogeneity found which is a little higher, can we explain? Evaluate the impact of study curriculum results, and then explore the potential of publication bias, as I said earlier. So this is an example of one particular study. These are the elements which are the parameters, the information that is collected. This is how you tabulate. And then graph summary you represent in the form of a very commonly used plot in meta-analysis, which is called as forest plot. So I will go through it. Forest plot is used for finding out what I showed earlier, the publication bias. So this is what is important for the people who are sitting in this room or online and who are not familiar with forest plot. I will go a little bit in detail how to interpret a forest plot based on one of our publications, which is used in recently published meta-analysis on the role of emergency RAS in abdominal surgery, emergency abdominal surgery. Now, this is one of the articles that has been selected. So based on this, I will show the forest plot. Now, this is the forest plot for 2 parameters. There are 2 forest plots, one is in the top, one is below, A and B, length of hospital stay and total postoperative complications in patients who are undergoing ERAS versus patients who are not undergoing, who are not on ERAS protocol. So there are basically 3 zones. You can look at it. The study details, they are here. This is what is the graph. And this is below is what is we call it as summary statistics. So how do we interpret and analyze and understand a forest plot? Now, this is the study, our study which is included. So the horizontal line of the first part, the study details, indicates everything about the study. The mean, the eras, non-eras, numbers, and all those things. So accordingly, in this particular first plot, 3 and 5 are included at the top, and there also 5 are included. The second part of the axis, which is on the right. So what is the axis? When it's a mean that you are comparing, when it's the length of hospital, say it will be continuous variable, it's a mean. That is the time the line of no effect, the vertical line what is seen there is called the line of no effect, that will be 0. Whereas when you see odds ratio and relative risk, it is 1. This is what is the point estimate. The point estimate what we are seeing here is for the study for post-operative complications is 0.11, which is visible here. So this is what is 0.11. That means there is a 89% reduction in the post-op complications, and this is the what you have on the side is the confidence interval. Then you have 3 components here. The weight of the study. Now this is what is the pointer is not working. This is the weight of the study. What you can see here that the fifth study here has got a bigger box, the square, the green color square. We can see 73% weight. That will actually dominate and tell about the final result, the diamond what we are seeing below D, what is visible there in the second part of the forest plot. So that diamond actually relies heavily upon one of those studies which have got higher weights. Higher weights is principally dependent on usually the sample size, but not always the sample size. So here we are saying for post-operative complications 0.50. That means there is 50% reduction in complications. So that is what is the interpretation. Then favors eras, does not favor, the left side favors eras, right side does not favor eras. And then you have below test for overall effect. That means the diamond. If the diamond is clearly on one side of the line and it is not touching the line, it will indicate that it is a significant difference. So that is what you can see there. Look here. So this is what is there. This is significant difference. This is significant. Whenever the diamond is there, it does not touch this line. If it crosses the line, if you just look at the graph, you can actually interpret the meta-analysis very well. Anywhere if the diamond touches the line, this will be not significant. So here it is both the diamond, this diamond, as well that diamond is very much on the left, so there is no problem at all. And lastly, let's look for the heterogeneity that I will tell in the next few slides. This indicates if there is heterogeneity in the meta-analysis, indicates the studies what we included have got lots of variations. If there have got lots of variations, if you look here, I will tell in the next slide, you have the photograph. So if you have got lots of variations, a common summary measure is hard to interpret. What are the causes of these variations? Could be anything. The patient population you are studying, they are not uniform. Intervention uses are not uniform. Co-interventions, outcome measures. Now somebody might think that if there are so many variations, why you are included the studies? Many times there is a problem because when you are including studies for a particular research question, you may not have studies. Sometimes you would like to do with the help of only RCTs, but there might not be adequate RCTs. So you have to do a mix of RCTs and cohort studies, mix of RCTs and case control studies. So that is what becomes a problem. So how to look for heterogeneity in the plot? There are 3 places we look for it. One is the visual. If the confidence intervals of all the studies overlap with each other and the sum of effect. So you see here, this is where the nice overlap is there, and it is also overlapping the diamond. So there is a possibility that this particular parameter for the analysis, the heterogeneity is very less. Here you see it is very wide variations there. Number 2, we look at the p-value. The p-value should not be significant. If it is significant, that indicates that the variation. And then the third is the I-squared value. This is the I-squared value, 25%, 50%, 75%, low, moderate, and high heterogeneity. So less than 50 is considered okay. More than that is not good. So here you see it's 14%, very good. Here you see it is 69%, very bad. So when we say the final interpretation will be that ERAS protocol definitely reduces the length of hospital stay by 3 days on average. We can take this as good evidence. But when it comes to complications, This you have to take with a pinch of salt that it reduces the complications by 50%. So that's the problem in this particular meta-analysis, that second one has got high heterogeneity. Publication bias. As I said, mentioned earlier, these are reasons where many studies might not be published, and when you do the thing, you can have, this is what very, you see, this is what very few studies. So this particular data and evidence from this particular forest plot, you will not be able to rely. We should always publish negative studies. Just one slide I put for that. Now this, as I said, we did not find that perioperative high oxygen helps in reducing the infection. So not only that included into the SSAT plenary presentation, it has got published in Journal of Gastrointestinal Surgery. So my suggestion to all the young people who are doing research, whether it is positive or negative, please publish it. If you publish a negative study, somebody else will not do that again, and it will help the literature. Lastly, meta-analysis. Nowadays, people are using network meta-analysis. So there is a direct randomized control trial between A and B, A and C. If you combine this, you can get indirect evidence in the form of B and C. And you can see this is a complex picture of network mirror. I always tell my students that the software use, the statistics use, everything you can rely upon your colleagues from PSM, pharmacy, or statistics department. You don't have to learn everything about it, but you should know the principles of statistics so that you can talk to them and discuss with them properly. So the key points of my lecture are: systematic review and meta-analysis provides the highest level of evidence, answers questions that otherwise could not be addressed by individual studies. Systematic review does not require statistics backup, as I mentioned. SR and ME use PRISMA checklists, preferred reporting items of systematic review and meta-analysis. They have a standard embedded pattern, what we use for original articles. And it is very important to learn how to interpret and analyze a forest plot. Otherwise, you cannot read the meta-analysis, you cannot understand meta-analysis, which is an important bottom line for any evidence, because it's the 1A level evidence. These are the books that we written on publication and thesis writing, and thank you very much for your kind attention.
Thank you, Dr. Vikram, for a very, very nice and excellent presentation. Actually, very difficult subject, which has been made easy to understand. And in my webinar, actually, somebody who is doing research in various fields, and also taking into consideration the negative points which happen when you do meta-analysis. So are there any questions from the floor?
I think, thank you, Dr. Javan. This is Dr. Usha here.
Yeah.
It was an excellent lecture. Thank you, Dr. Vikram. It was wonderful to hear you explain the key components of forest plot. I think this is...
Just wait for a minute. Audio-visual team, can you please stream Dr. Usha's? She's joined online. Dr. Usha Datta is the editor of Indian Journal of Gastroenterology. She's a head of the Department of Gastroenterology at PGI Chandigarh. She has joined online. Yes, Usha, please carry on.
Yes, sir. Thank you. It was wonderful, Dr. Vikram, to see you explain the components of a forest plot so clearly for this, for all the audience. Many people just keep seeing the forest plot without realizing the key components and the role of the diamond and the square and the central line. And you explained that very beautifully. So I would suggest that the audience should familiarize themselves with forest plot, which is now going to be a very important tool for anybody to assess the benefit versus harm of every intervention. And it is also important to analyze that these meta-analysis is useful only when there are sufficient number of patients in all the arms. And just, those meta-analysis with 2 studies and 3 studies are of limited importance. The main aim of meta-analysis is to have a larger power to see to it that you have addressed the question effectively. So I would urge all the participants to understand the forest plot, and there is also a risk of bias. When you see all these forest plots, people do not see the risk of bias. Sometimes if the risk of bias of the randomized controlled trials included is poor, is very high in that sense, it is going to be creating a skewed result. So you have to be very careful to analyze the forest plot in the background of the risk of bias chart. If the risk of bias chart shows a lot of reds, that means the data is not reliable for us to make our suggestions. Thank you.
Thank you, madam.
Yeah, thank you, Usha, for your critical comments. And Dr. you have some question?
No, I think Dr. Rai can
Yeah.
start the next presentation.
Thank you, Dr. Vikram. Thank you.
Thank you very much. Thank you for this kind invitation once again.
After an excellent talk by Dr. Vikram, really has enlightened us so much that we have started understanding better the forest plot and the importance of heterogeneity in the studies. When a conference begins with a very good talk, it really speaks that how standards are going to be of the conference. And this morning, we are welcoming yet another down in the field of gastrointestinal surgery, Dr. S.K. Mathur, who is a teacher of teachers and a great human being. He has lived his life from day one and always been thinking about how liver transplant in India could go on a big platform, and with his dream coming true. And it is the aim of his life to see that organ donation becomes an important part. He is the president, the Transplant Coordination Center, Mumbai, and he is member of so many of these organizations that to narrate them, but he is member of all those organizations which matter. He is the past chairman of the committee of the drawing guidelines for distribution of liver and other abdominal organs, ROTO and SOTO. He had been formerly the professor in GI surgery at St. G.S. Medical College and TM Medical College later on. His major achievements have been that many of his students are now the teachers and they are propagating his ideas in the GI surgery. He is the recipient of the French government postdoc fellowship in 1989 and 90 at Paul Brussels Hospital, Paris, France, in those years. He is the past president of the IHPBA India. And he has rightly chosen the subject that is the ignorance, from ignorance to wisdom. And nobody else can be more wiser and with wisdom than Dr. S.K. Mathur. Let us hear from him.
Thank you, Professor Rai, for that kind introduction. We have been colleagues as far as the conferences are concerned. We have not been colleagues in the institutions, but we have been colleagues in the conferences. I think way back to 1982, it goes here. Professor Niravan, Professor Katu, ladies and gentlemen. At the outset, I'm thankful to Professor Kapoor and his organizing team for inviting me for this prestigious meeting and giving me this honor. When I decided to become a doctor, I thought that medical profession is a unique God gift to the human beings. What Sister said, in nothing man more to approach the God than in giving the help to the man. And that's why, perhaps mythologically, it was always thought that it is a God who practices the medicine. And that's why, please don't control from there. I will control the. So the aspirin is considered the God of medicine, while Lord Dhanvantri is considered the Hindu God of medicine as per our Puranas. But to me, the ignorance is the inbuilt part of the wisdom. And that's why the Greek philosopher Socrates said, I am the wisest man because I know nothing. And that's what one has to remember, that it is important to know that you are all ignorant people. And then we can think of there is some wisdom in that. And I'd like to draw a parallel with how the COVID pandemic managed in this recent past. We all know that has a disastrous effect on the whole world. We lost millions of people across the world. It crippled the economy of the whole world. And the wisest people, being the WHO, being the CDC, being the other country, were at loss how to manage it, particularly in the initial part. And this is quite evident from this recent review. You can look out that the drugs which were thought to be effective initially were found to be not effective at all. And there were drugs which have now found to be, yes, they have established that they did work to treat the patient. So we were ignorant initially, and over the period we developed the wisdom. What worked was the individual wisdom of prevention. And that is the basic things, that is hand hygiene, social distancing, using the face mask, and when the vaccine was developed, the vaccination. Now, I know that the WHO as well as CDC was very reluctant to recommend the universal use of the face mask in the beginning of this pandemic, while it was made mandatory in this country. And this is evidence. This is an article which was published just last month in NGM in the Boston area, when the mask mandate was lifted in the school. There was a rising incidence of within 15 weeks of the COVID cases amongst the students as well amongst the teachers. So this gives evidence that yes, masks did work and have been working. Now, before this pandemic, what was our wisdom for the work? We all thought the physical attendance at workplace, meetings, conferences, patient consultations, everything was must. But we were ignorant about the power of the internet and the web connectivity. But this COVID taught us how, using the internet connectivity, we can work from home, do the virtual attendance at the workplace, do the meetings, the conferences, use the telemedicine for patient consultation. So whatever that traditional wisdom became actually was the ignorance, and what we were ignorant about became wise people. Regarding the wisdom, I would like to quote Father of the Nation, Mahatma Gandhi, who once said, it is unwise to be sure of one's own wisdom, because wisest men can err. And here again, I would like to draw the parallel between the freedom fight, the freedom movement of this country, and the fight against the corona. To me, both taught us to be self-discipline. Now, when we give the call for the people to come in the street and hold a peaceful protest, the work to maintain the peaceful protest requires self-discipline. We know that today when the protests are started with a peaceful protest, we end up with the violent protests. So it requires self-discipline. The same thing, when the Janta Curfew call was given, and subsequently, 21 days lockdown was imposed in this country, a lot of wise people in this country and abroad questioned that wisdom whether really will work to control the corona pandemic. We all know we were praised for that effort, and we know in China when the research was currently going on, they are using the lockdown method. The dictionary meaning of the wisdom is ability to use your knowledge and experience to make a good decision. decision and judgment. And here's an example of that article published very recently regarding the outbreak of virus in developed countries like US and United Kingdom. And what is the reason? Under vaccination. We know in this country we have eradicated the virus because of vaccination. It is a classical example where the wisdom being ignored. It is not ignorance. It is known fact. Everything is. But the wisdom leads to the problem. According to Chinese philosopher, you can acquire the wisdom by two methods, that is reflection, imitation, and by experience. And I would like to draw a parallel about learning of the clinical medicine. It's a very basic piece. We all do, we all learn, and I think we are still in the process. If we learn from our teachers, seniors, we learn from the expert. You just know the excellent lecture given by Professor Kati, and that's imitation. When we read and teach others, that's a reflection, and I always consider the students are our best teachers. And finally, the most important is learning from our patient, and that's where the experience comes into picture. Because we all know each patient is a challenge by itself. Not everything very given the books is found and we find the answer. Okay. Now, this article, when I read, I was a little amused. When we do the conclusion, first is the title, The Science of Post-Traumatic Hypovolemia and Obesity, and allowing the regular is to allow the treating physician to possible pending hypervolemic shock. I always thought that it is shock itself diagnosed clinically and then the patient is sent to the further investigation after taking care of the resuscitation. To me, it looks like placing the cart before the horse. And that brings us, what is the science and art of the clinical medicine? To me, being a physician is a science. Winning the patient trust and confidence is the art. And we all know, being a competent physician, it involves just the 5 steps. We all learn as undergraduate, as a postgraduate, and perhaps try to practice throughout our life. And that is the thorough clinical evaluation, asking for the relevant investigations, not the investigations as are given by some people. Reviewing the investigations, arriving at a diagnosis, planning the management, and executing the appropriate treatment. And here I will give a classical example of what happens when you don't follow those steps. We have a young lady, 36-year-old female, who had some weak symptoms, underwent imaging, and was diagnosed on the basis of the CT scan and ultrasound and the PET scan, was suspected to have cholangiocarcinoma. FNAC was asked for, FNAC was reported confirming the cholangiocarcinoma. She was given course of chemotherapy, no improvement, then the advanced chemotherapy. And that is the time the patient landed with me for a second opinion. Now, this is a classical example what was ignored. This patient didn't have any evidence or any symptomatology or signs suggestive of the biliary obstruction. The liver function tests were almost normal. Tumor markers were negative. She had splenomegaly. And when we removed the CT scan, actually it's case of extrahepatic portovenous thrombosis with total cavernoma, which was misinterpreted as a hilar mass. And we had to get the FNAC review by the top pathologists of the city who reported there were no malignant cells in that FNAC, which were reported as the malignant cells. So this is what happens when you don't go through the proper steps. So to me, science of clinical medicine is analysis and synthesis, not missing important points and not making major mistakes. While art of winning patients' confidence starts with the art of communication, which starts with the introduction of the self and the patients and the family members to understand what is the background, because developing a rapport with the patient and the family is the first step in winning the patient faith. The second step is the explanation of what you think about the clinical diagnosis. You can't take it for granted because you written the paper, the patient will understand. Abnormal results of investigation has to be explained, and if there is need for further investigation, why they are required, and finally the provisional and final plan of management. And when it comes to a treatment, we cannot today say that this is the treatment. No. If there are treatment options, they have to be given. And if it comes to surgery, the possible complication, real life-threatening, or which can prolong the hospital stay and risk of mortality. Often it is said that if we talk all these things to the patients and explain that you can die, you can have these complications, you can explode them, patient will run away and go to some other one. I strongly feel it is not true, and I will prove it by an example. Because transparency in communication with the patient related is most important in gaining the confidence. And with the example of this, the patient feedback, many patients who have the pancreatic cancer had mass involving the portal vein, underwent complex visual surgery with vascular reconstruction, had a stormy post-op period, was in the hospital for 2 months. But after recovery, what she wrote, if you see here, the approach and the guidance you give to my children, that is the art of communication. And maintain the transparency which gives us faith. That's what I was saying. You maintain the transparency, the patient and the family faith goes away. And second part is, as a doctor, we should always put ourselves in the shoes of the patient. And think over how will I like to be treated if I have the same problem? And that is important. Let me give this example. This is in 1987 when I have a acute appendicitis self-diagnosed. And when I told my junior colleagues that this is what is happening, I want one of you to come and confirm that. And that I will go to a big 5-star hospital in Mumbai, that operated by one of the good surgeons whom I knew very well, whether Dr. Waria or Professor Shikande or Professor Bansali. And he told me what disease I take. And I thought that if I am treating or treating these patients in the hospital, in the general ward, in the emergency theater, by and by my juniors, I must get myself operated by my junior colleagues. I have no business to be there as a teacher. That's what I did, and that's what happened. And the second part was antibiotics. At that time, we started following the WHO guidelines for using restrictive antibiotics. And we used to remove the antibiotics after depending on the type of surgery. And the next thing around, the Kabirani were my junior colleague and the resident, they were wondering what is to be done. And they said that what should we continue antibiotics? And I asked them what were the operating findings and what we would have done for the same thing to the other patients in the ward. They said we were limited the antibiotics. It was unused. And that's what happened. So you have to keep it like what you teach others. Okay. The beginning is not the end of the story. Sometimes you have to work as a counselor. That when the patient goes through the process and the complications, there is psychological trauma, which we never address to, because we thought that is a part of the psychologist or the psychiatrist. And this is an example of this young girl who was journalist, underwent multiple operations for abdominal tuberculosis, finally recovered, but at the end, she had a kanamycin-induced complete deafness, and she thought her world had fallen apart, and she was totally at loss. And this is the interview which has been published in the Lancet, and whatever she said in that, and that's what I want to convey, to be able to inspire others to achieve higher goals, particularly in the presence of adversity, is a bigger personal achievement than achieving yourself. This girl was invited by the UNO to speak on how to go about the creating awareness about the tuberculosis. This boy who was treated
When he was 6 years old, hematemesis, extrahepatic hypertension, sclerotherapy was done, he recovered. He used to draw beautifully. And I saw on the rounds once he presented to me. After many years, one day he called me up and he said, I'm so-and-so, your patient. And I could come to you. And he presented this painting and told me that because at that time he told my father that I should put in some art school. I studied from JSF School of Art and today I am teacher myself. So try to make difference in the life of the patient, allow the patient to go to better expert for which you don't have the expertise. The technology you are teaching, and in every case, as we become senior, we have reluctance to adopt to that. To me, the new bar for learning that or adopting the technology, whether it is laparoscopic procticlectomy or minimally invasive nephrectomy, or innovating yourself the percutaneous nephroscopic evacuation of the hyoid cyst. I always feel, I know that somebody can question me that why percutaneous nephroscopic, does it work or not? I feel that traditions are there to be broken, and so for that, be out of box thinking, otherwise science will not advance. Again, when I decided to become doctor, what was the one of that second name? That to solve the patients. But today, when we look at this, we call in this country or the world over, the health is a billion-dollar industry. And here question comes, have we lost our path? This article written by one of those very senior neurosurgeons from Mumbai, and it's little alarming when he says the commercialization of medicines lower the dignity of the profession. I feel the currently prevailing adverse perception of the public about the medical profession is worrisome. The present and future generation of the young doctors will have to work hard to change this. Medical profession is a novel profession. It has to practice with the highest standards of ethics. And when we talk of the ethics, remember one thing, it is easy to preach, difficult to practice. So the message should be practice ethics, don't preach. And that's why I don't preach the ethics. When we talk the evidence-based medicine, Professor Carter spoke very well on various aspects of this. He doesn't blindly follow what is being published. Because when I read this article written by the former editor-in-chief of NPM recently, what he wrote is very worrisome. It simply never possible to be much of the clinical research that is published or even medical guidelines because of the influence of various forces on these publications. I think evidence-based medicine, today we are using the term for a few years. It existed even before that. And this is the photograph of in 1884, this gentleman, he was a resident, now he's a consultant in New Jersey. And what he wrote for what he learned from us at that time. I'm philosophy is a teacher, and that's what I tell everybody, that we should teach how to use the knowledge judiciously, not what you want them to teach. To encourage them to question you, because while questioning, everybody improves. Teach the patient as a fellow human being and maintain the highest ethical standards. You have found the quotes which I thought I would like to convey. Yes, it will get over in that time. This one is sometimes illogical but followed. When you have no expiry date, acquire them. Teaching does create competitors. People are afraid of that. Some people say that don't train your students, otherwise they will be your competitors. Because it forces you to raise the bar of your own abilities to remain in the competition. Ultimately, life is an experiment. Not all experiments are successful. I believe what Franklin Roosevelt said, happiness is not in the mere possession of money, it lies in the joy of achievement and thrill of creative effort, and that's what I'm enjoying today. Life is all about moving on, and one has to accept the changes. As a surgeon, we have to know there's a life beyond surgery. I'm indulging now in creating awareness about the disease organ donation because I feel that working for the cause of disease organ donation is fulfilling your medical social responsibility, which as a medical professional, we must follow. And that's what I appeal to the people from this country at least. I will end with this quote from Bhagavad Gita, the essence of which is the object of knowledge is to remove the darkness of the ignorance. But remember, life is a journey from ignorance to wisdom, and ignorance is an inherent part of the wisdom. Okay, thank you.
Wonderful talk. What a philosophical talk it was, taking us through the journey of your own life, giving us new thoughts about what a teacher has to be. And that's the reason I first called you teacher of teachers. Because if you do not create teachers, who is going to be carrying your torch of wisdom to the human mankind? And I'm really thrilled to listen to the whole talk. And the most important thing is one of my teacher also told me that एक दिन में एक समय उस बिस्तर पर सोकर देखो कि कैसे आपको एज ए मरीज आपसे अपने डॉक्टर से अपेक्षाएं हैं, वही अपेक्षाएं अपने मरीज की पूरी कीजिए, आप सफल हो सकते हैं. और दैट्स द थिंग व्हिच यू taught your teacher students, that you can yourself be operated by a student of yours, and that's a great achievement. Thank you very much for an excellent talk.
Thank you.
Thank you, sir. Thanks for a very enlightening session. And I think with this we have become more wise that education gets us more brighter and from darkness to wise position now. So to get it more lightened, I think I would request a lamp lighting ceremony now. So I would request our emeritus chairperson, Dr. M.S. Venkasa, to please come on the dais. Along with him, I would request Dr. Vivek Kapoor, sir, Professor in Head, Department of GI Surgery and HPV Surgery, to please come for lamp lighting. So please, and Dr. Sachdeva, sir, please, Professor Sachdeva, and Dr. Ramesh Rupa, sir, Dr. Nijavan, Professor Nijavan. For lamp lighting, please. Dr. Vikram Kate, sir, Dr. Mathur, sir, and we have some of our international colleagues. Oh, yes, Dr. Jean Saxena, sir. Please, sir, Dr. Jean Saxena, sir, for lamp lighting, please. I would like to invite the Dr. Vijay Saraswat. He is a famous and renowned gastroenterologist, former professor of gastroenterology at HCPJMS. Currently, he is working as a professor in head department of hepatology, Mahatma Gandhi Hospital. And our online chairperson, Dr. Atul Sharma, he is experienced in gastroenterology and currently working in Baldwin Institute of Digestive Sciences. I request Dr. Vijay Saraswat sir to invite our speaker for the presentation.
After this inspiring first session, which talked about life and athletes in different ways in the lead lectures, we move on to the main themes of the conference. As you know, this is the second JSF week that is focused on HPB oncology. And for the next presentation in this series of lectures organized for today, we have none other than Dr. Dan Duda, who will be talking to us about hepatocellular carcinoma biology and treatment. Professor Duda graduated from the University of Medicine Iași in Romania and from Tohoku University in Japan. He then pursued postdoctoral research at the Massachusetts General Hospital in Boston and joined the faculty at Harvard University, where he is presently the Director of Translational Research in Gastrointestinal Radiation Oncology at MGH and the Secretary General of the International Association of Surgeons, Gastroenterologists, and Oncologists. With this brief introduction, I'll request Professor Duda to talk to us about HCC biology and treatment.
Good morning, everybody. Thank you very much, Mr. Chairman, for the introduction. I want to thank my good friend, Professor Kapoor, for inviting me here today. It's really an honor to be with all of you. And also, it's a tough act to follow Professor Mathur. But I think I will try to follow in his, along the thoughts that he presented to us and see how we can avoid ignoring the wisdom of today in HCC treatment and biology. So the reason we have to work very hard is right here. So this is a SEER database from the United States showing the 5-year survival in different types of cancer. What you can see here is that in liver cancer, actually the survival is quite low. We are talking about less than 1 in 5 patients surviving up to 5 years. And on top of that, worldwide, we see an increase of about 3% in liver cancers, and the majority are actually HCC, the vast majority. So you see here both men and women, there's an increase which is likely to increase even further because of the incidence of NASH and possibly double in the next 10 years. So obviously this remains a major problem. So I think along the lines of what Professor Mathur was saying, I think we need to challenge the paradigm. So the current paradigm is really that, early stage disease should be treated by surgery with the curative potential, of course, and then further down the road, when they become unresectable or they're deemed unresectable, there are other therapies such as radiation or other local therapies. And then when the disease is really advanced, we have seen an explosion of treatments with a lot of drugs that target angiogenesis, the VEGF pathway in particular. You see, I'm not going to talk about this in detail, but just you can see how many treatments are available. And then immunotherapy, of course, created a very exciting possibility of durable responses. And we have seen multiple drugs being approved in this area. And I'll discuss a little bit about this. But of course, the curability and the chance of survival decreases with advanced disease, as one would expect. So how do we challenge this paradigm? I think there are multiple ways. I mean, for surgical disease, surgically resectable disease, what we're talking about is actually a minority of patients, less than 20-25%. And of these, 70% of them will present with recurrence within 2 years. So I think it's very difficult to achieve in this setting. And it's not, of course, the fault of the surgeon, but rather the rapid development of intrahepatic metastases or the novel ACC in these patients who actually have cirrhosis. So we really need to understand several things. One, how do we address treatment feasibility? How do we perhaps bring some of these effective treatments earlier on and combine them with the existing strategies to really avoid these late stages where there's obviously very high tumor burden and liver damage to worry about from the clinical perspective. From the biology perspective, we also need to understand the complexity of the disease. So people say bad biology in surgery. You know, I always had a difficult time to understand what that means as a scientist. I think that we basically know everything about the disease at the single cell level, actually. So we know what the genetic abnormalities are, what the stroma abnormalities are in terms of the vasculature, immune system, immunosuppression, and of course the lack of activation of the endogenous immune response to actually remove the tumor. So in terms of genetics, in fact, we know with precision what kind of mutations are present in this early ACC and advanced ACC. There's so many studies, describing these. Of course, there's a lot of heterogeneity. It's very difficult to imagine that we can address this individually. So we need broader approaches. The other thing we need to think about is, of course, that these are two diseases. There is the liver damage that develops because of all this injuries with the viral hepatitis, alcohol, steatosis, and so on, other etiologies. So these are very important, especially in the treatment and the management, but also in the biology. Because again, as I was saying, we really need, as we move towards immunotherapy as a mainstay of treatment, we need to understand what are the determinants of response and resistance to immunotherapy, how we can avoid, the exclusion of the effector cells from the tumor, how we can increase their activation. So this is what I want to talk about today over the next 15 minutes or so. How do we bridge this gap between what we understand in the lab and what we use in the clinic? So it's actually a very big effort because we need to bring together scientists who usually just think about how to develop, a new mechanistic understanding or identify a new gene. This is really the priority in the scientific world. But of course, in the clinic, we want to know if the treatments are actually feasible, of course, if they're effective, and really a concerted effort needs to be undertaken to really be able to bridge this huge gap that still exists between the clinic and the preclinical world. So I'll talk about two things today. One is how does anti-VEGF therapy, which of course for about 15 years have dominated systemic therapy of ACC, work? How does it feel? Or at least our understanding of that. And then some strategies to integrate these immunotherapies that I was discussing in the beginning in the ACC management to have really more durable responses. So first, anti-angiogenic therapy. So we've been studying anti-angiogenic therapy, as you heard when I started in Japan, also at Harvard in the last 25 years. What is the role of the vasculature in tumor? So we learned that actually the role of the vasculature in tumor is very complex. These are very abnormal vessels that actually help the tumor grow by creating these abnormalities, this hypoxia, these difficulties in delivering drugs, also in preventing the immune system from functioning because of this acidosis and hypoxia develops in tumors. It was really like Chris Jain, who's my mentor, who's actually a son of India. He studied in Jaipur, in fact, who came up with this strategy to normalize the vasculature as opposed to just pruning all the vessels and trying to starve the tumor, which actually failed clinically. His strategy was really, can we normalize? Can we make this function of vessels better? And of course, he was recognized. You see him with President Obama getting the Medal of Science. But I think this is very important for the treatment strategies, especially for immunotherapy, because immunotherapy really needs this type of vessels so the T cells can enter the tumor and function properly. I think this normalization hypothesis is really giving new ground with the development of immunotherapy. This is how it works. This is his work where he actually showed in a time-lapse movie. This is an animal model, but you can see a tumor that has very abnormal vessels under the pressure of VEGF inhibition, vascular endothelial growth factor inhibition. You see the vessels becoming narrower, straighter, actually perfusing much better this tumor while not regressing it. So this was the effect of anti-angiogenic therapy alone. So we've been studying this in patients for the last 20 years with my colleague Andrew Zhu from FGH, really trying to bring the science to the patients. So imaging or systemic biomarkers or tissue biomarkers, all type of analysis, of course, of surrogate biomarkers in the blood, trying to see whether we can first validate this hypothesis that we have in the lab, and also how do we move forward with the therapies. So these are some very good studies, but I think they're important to show. When we did the functional imaging, functional MRI in patients, we received anti-VEGF therapy and showed very nicely with looking at permeability and surface area of the vessels that was very high in HCC because HCCs are hypervascularized. You can see that this was decreased. And in fact, this was associated with the endpoint of the trial, which was time to progression. So this was early days. I think, as Professor Matur said also in his lecture, the role of preclinical studies is very important. And of course, we don't expect preclinical studies to be identical to human disease. However, they can inform us how to go to the clinic. We can do preclinical studies, preclinical trials of different interventions and save billions and billions of dollars that are wasted in these phase 3 trials that you see every day coming back negative in patients, and of course, with all the adverse effects. So I think there is a role of preclinical studies that is very important. Of course, it's difficult to mimic the disease, which is, cirrhosis and HCC in a mouse, but it's feasible, and we've done that successfully. I'm not going to talk about all these papers, but suffice it, I just want to show this because I think this can be very rich in terms of scientific communication, very rich in terms of translational significance. So these are the animal models. You can have very high degree of vascularization. You can have bridging fibrosis. You can start seeing cirrhotic nodules. If you continue, you can start seeing tumors. And also you can start seeing the effects of therapy when you look at the vasculature or hypoxic regions in a tumor. So with this kind of understanding, actually, we came up with a strategy where we blocked with antibodies, both the VEGF pathway and the PD-1, which is the main target of immunotherapy nowadays. And we actually showed very nicely the role of having new blood vessels formed in a tumor. There was regressing, actually. So it's very different than the initial strategy of anti-angiogenic therapy. Actually, the goal here is to normalize the vasculature, to have a vasculature that is functional and permits the immune cells to get into the tumor, be properly activated upon antigen presentation, and really eliminate the tumor. This was one of the papers that we had very difficult time publishing because it went against, the wisdom. But I think we were very gratified when this data came out, which was a combination of antibodies, like I showed in mice. This is now with VEGF and PD-L1, which is the ligand for PD-1. Really unprecedented efficacy in hepatocellular carcinoma versus sorafenib, something we have not seen in many, many trials over the years since 2006 when this study was performed. So really impressive and also durable responses, almost 2 years survival, which is unprecedented. And more importantly, when they did all the correlative studies in this phase 3 trial, they concluded that vascular normalization was really a key element for this treatment interaction that was so successful here. Of course, this is not the cure, and as I was saying, in advanced disease, the bar is very high. However, you can see that there's a very significant delay in progression, and in fact, some of the patients have durable responses. However, we still need to address the fact that the majority of patients actually present with progression even after as early as 15 months. So some of the work we've been doing, looking at mechanisms of resistance, immediately pointed us to inflammatory factors playing a key role in resistance to VEGF therapy. And this is work done many years ago, but I think it's still very timely because of the emergence of immunotherapy. So we found a lot of chemokines, cytokines, a lot of immune cells being associated with with progression when we look at these patients and their, at least in their circulation. So one of them was stromal-derived factor 1 alpha. I'm not going to describe what it does. It's a chemokine that is very important in many ways in tumors by bringing inflammatory cells, by producing fibrosis as well. So we're able to show that this was actually one of the reasons there was resistance to sorafenib therapy, which was the standard of care at that time. Really one of the strategies to address this resistance was to block the receptor, which was CXCR4. And I'll come back to that. So now all of this knowledge points us to maybe potential strategies to design better therapies, especially with the excitement of immunotherapy, which of course has been used primarily in advanced disease, but has shown some potential to have durable responses. So one of the things we did was very basic, just to start, hitting at every single checkpoint, this immunosuppression in the tumor, and looking at all the parameters that we know are determinant for immune response. And sure enough, when we block all of them, we're able to show very, very potent effect of immunotherapy. But of course, this is very difficult to do in patients because you would need to have multiple strategies that individually they're not approved. So then, of course, the antibodies I showed, this is already standard of care, but how do we make progress here? So one of the directions is to use what we already have in our hand, which is kinase inhibitors, because they have multiple targets. So then the idea is, can we use the fact that they are multi-targeted to have a larger benefit with immunotherapy? And again, I go back to this. I think this will be very important. However, we still need to keep in mind the role of the clinical parameters, the feasibility. Is this feasible in the context of liver damage? And can we actually reverse this negative biology or bad biology, some would call it, which is actually related to immune suppression, vascular abnormalities, and the lack of T cells. So we started doing some work with the drug regorafenib, very similar to sorafenib, in fact, but it has some additional targets on the vasculature, such as type 2. I don't want to go into the details, but anyway, this is an approved drug for ACC, where it has a minor benefit of survival. So we started looking at various doses of this and how we can combine it with immunotherapy. This again in mice, in the animal models I showed to you. So we found that there was some sort of a sweet spot where, as you moved with this finding, where regorafenib was actually able to normalize the vasculature at the same time to bring in the T cells. And then we did the survival studies, and sure enough, when we used that dose, we saw that this was actually much better than when we compared with lower doses or higher doses in combination with immunotherapy, with some durable responses. So we got very excited about this, looked at the mechanism of action, and sure enough, we found the role of vascular normalization being key to bring in more drug, increase the expression of some chemokines that attracted T cells, and this is how actually worked, and we published this recently. The exciting part of this is that actually this has some clinical implication. At the time when we published this, people said, well, you cannot do this in patients because how are you going to find the dose? But in fact, we did this trial in Japan with regorafenib and nivolumab with anti-PD-1 therapy. And as you can see here, lower doses, when they lowered the doses because of toxicity, not because of our studies, although they were aware of our studies, but they lowered the dose because of toxicity. Now they've seen, tremendous responses in metastatic colorectal cancer, a disease that does not respond to immunotherapy. 1 in 3 patients responded to this combination, which was incredibly exciting. There are a lot of data in ACC coming out now with this combination, some of them with complete responses. Of course, small trials, but there are many phase 3 trials ongoing now. So we're very gratified to see that. Then the other thing is, how do you schedule them? So perhaps if you don't give them at the same time, you can avoid some of the toxicity. So given the effect of PD-1 therapy, we thought, well, what if we give PD-1 therapy for a few cycles and then stop, which of course would help with the cost a lot, and then give a kinase inhibitor, which we know is effective. So we did that, and this was published earlier this year. We see an amplification of the response. So if you give each intervention alone, you see some benefit. Actually, when you give this some sort of priming with immunotherapy to the TKI, we see this amplification with some really durable responses. And these are really aggressive tumors in the preclinical models. So we really hope this can translate clinically. We have some clinical evidence from Hong Kong to support this, but of course, that's anecdotal at this moment. Then another perhaps paradigm shift would be to bring this earlier into the disease management. Again, thinking about this toxicity and efficacy. So one of the approaches we're taking is, proton therapy has been developed aggressively at MGH for the last 30 years. It has the great advantage of being able to deliver high doses, therapeutic doses, very precisely to the tumor. There are a lot of phase 2 studies showing that this is actually feasible in ACC, and currently a phase 3 study is being done nationally in the United States, led by a hospital. One of the strategies we're taking now earlier in a phase 1 study is to bring bevacizumab and atezolizumab, the standard of care, in combination with stereotactic body radiation early in the disease, and doing all these correlative studies that I've been discussing, with the thinking that radiation may make the tumor more immunogenic and perhaps enhance the efficacy of immunotherapy. So we don't know whether that's going to be true or not, but the clinical trial will show us the feasibility. Another way, maybe more relevant to you, is really to bring this earlier into the disease setting. So we don't have any neoadjuvant or adjuvant therapy currently in ACCs. So with immunotherapy, obviously, we're very excited. Professor Kaseb from MD Anderson has done some feasibility studies with immunotherapy alone in neoadjuvant setting and has shown some really incredible responses. About 50% of the patients actually had major benefit in his study. It was a small study. We are doing now a randomized study in collaboration with them at MGH and MD Anderson that is funded by the National Institute of Health, where we are doing atezolizumab, bevacizumab prior to surgery in resectable cases versus upfront surgery. And there are a lot of studies included here with imaging, with tissue studies, single cell sequencing, whatever you can think about. And this is also funded by the NIH. So we're very excited about this. And hopefully this will help us change the paradigm in this disease. And last thought I want to leave you with is the fact that I was saying in the beginning that there is, truly recurrent ACC from intrahepatic metastases. There is de novo recurrent ACC, which develops in a different location with different genetics. But actually, what's also different, we find, is the immune environment. So in the de novo ACC, PD-1, PD-L1, this exhaustion of the T cells is actually critical in the way that the tumors develop. And in truly recurrent ACC, actually PD-L1 doesn't really seem to play a role. There are actually other parameters that lead to the absence of T cells and the fact that they're not exhausted, they're just not informed in this setting. So this paper was done with a group, Professor Kwang from Guangzhou, and it's really a very nice study looking at multiple strategies to look at this disease, and started with a PD-1 therapy in both true and de novo recurrent ACC, showing up only the de novo recurrent ACC showed benefit in this trial. Again, a very small trial, but we're hoping to extend this to a randomized trial very soon. So to conclude, I want to leave you with this thoughts that normalization of the vessels and the immune environment are critical for the durability of responses and really keeping the disease at bay. The combination of antiangiogenic immune therapies are effective, but of course, new strategies need to be developed. And I showed you several of these and what are the important points for this. And of course, I think that all of this should be based on biology, which currently is not really considered in the management of ACC, and I think is the foundation for more effective and safer therapies. So I want to thank many of the people in my lab, collaborators, wonderful internationally, as well as, of course, my institution. And also want to invite all of you next year for our IASGO Congress in Verona. Please save the date, 10 to 12 September 2023. And thank you very much for the invitation and for your kind attention.
Thank you very much, Professor Dula, for that very enlightening talk on the tumor biology, particularly the roles in the immunotherapy and the anti-VEGF approaches, which have now revolutionized the treatment of advanced HCC the world over. So I think while we wait for questions, I think Dr. Atul Sharma, who is my co-chairperson from the All India Institute, would possibly, is he online?
I think he had to log off because of some other commitment.
Okay.
You please carry on.
Right, sir. So I think while this information about tumor biology and its behavior is very informative and very educative to all of us, but for a practical clinician, for making day-to-day decisions, how exactly would particular tumor markers or any markers that you look for within the tumor, like Lipicantry or others, would they be of help? I mean, what is your experience with this?
Yes, of course. So as I was saying, but I think this has to be done on prospective studies. So this is what we're doing right now. In this randomized studies, we will get information about The malignant cells will get information about the immune cells. This is typically not done because biopsies are not used for the diagnosis of HCC, and especially in recurrent disease. So I think this is a major problem that we need to address. We cannot understand the disease unless we studied it. So I think we really need to bring, new develops in imaging. They may be very useful, which can measure the liver damage, fibrosis, and its role in response to immunotherapy. I think we really need to define not just the disease, the malignant component, but also the immune environment and see what are the determinants. I showed you toward the end. The PD-L1 axis was not relevant in the truly recurrent HCC. I don't think that kind of information is used clinically, and that's actually very easy to do. And I think hopefully with these publications, people will pay attention to that and
Indeed.
Start integrating. Yeah.
I think the other thought that the query that I would put to you is that certain etiologies of HCC, like for example, now in fatty liver disease, we have a non-cirrhotic pathway. We are increasingly finding that even in people who do not have cirrhosis, there is a risk for HCC. So in the various carcinogenic pathways, like the Wnt-Catalytin pathway, the other pathways would differ in tumorigenesis. So would any insights from tumor biology help us in identifying why these tumors are behaving so differently?
Sure. I think that there's a lot of knowledge out there. People have published, especially on the beta-catenin pathway, and showing how that's related to immune suppression. I don't think that gives you any kind of practical direction how to do that. I mean, of course, you can exclude those patients from immunotherapy, but you don't know what to do with them. And unfortunately, the therapies that have been targeting the Wnt pathway, they have not really succeeded in ACC. And I think we have to refocus, or at least to prioritize what works, which is anti-angiogenic therapy and immunotherapy. This has been validated for 20 years. I think we really need to see how do we use this, how do we combine them better, and how do we select patients for them? Because we have so many systemic drugs. They have so many systemic drugs, they don't know which one to use first now. And they also do the same thing. They block VEGF and PD-1. Right. So I think we really need to start understanding a little bit better rather than just getting first to the market.
Well, thank you very much, Dr. Duda, for this. And in fact, I think your insight that what was atezolizumab, bevacizumab came in as treatment for advanced cancer beyond resection has now come to unresectable, and now even to resectable tumors using this therapy will improve results. These are really new insights. Thank you very much, sir.
Thank you. Thank you.
Thank you, Dr. Saraswat, sir, and Dr. Duda.
Dr. Saraswat, I think Dr. Sharma wants to.
Yeah, thank you. So thank you so much. Thank you, Professor Duda, for excellent presentation. I have two questions for you. One is, do you do biopsy in all patients of HCC, or on radiology you are able to treat them?
So in the clinical trials, we do biopsy for all the patients. Normally, yes, no, they don't do any biopsy.
And how common the mix of cholangio and HCC or the diagnostic difficulties are?
Yeah, of course. This still remains a major problem, and for treatment, of course, there would have very important implications. I think there's a lot of excitement now with immunotherapy also in cholangiocarcinoma. So there has been some success with the combination of chemotherapy with immunotherapy. So we're working very hard on pursuing that. So I think that will also possibly impact this ACC-RCC diagnosis.
One more question, sir.
Sure.
That if you are doing TACE or SBRT or any intervention in the tumor, and the immunotherapy is more effective in that after the antigenic stimulus or something like that?
Well, this is the clinical trial we're doing right now, so I cannot say for sure. I think what I can tell you for sure is that with VEGF inhibitors, it didn't work. So there were large phase 3 trials with radiation, also with TACE, they didn't work. But I think that now a lot of efforts with TACE, TARE, SBRT combined with immunotherapy, and there's the hope that now you may actually see some response, but I don't think there have been any reports showing that conclusively. It's just a concept.
Thank you. Thank you so much.
Yeah.
Thank you.
Thank you. Thank you, respected chairperson and speaker. For the next session, I would like to invite Dr. Namish Mehta as a chairperson. Basically, he is a co-chairman and the chief liver transplant surgeon, Gangaram Hospital, and director of the liver transplant, Mahatma Gandhi Hospital. He is having experience of more than 1,500 liver transplant over the past more than 15 years. I would request Dr. Nimesh Mehta sir to invite our next speaker for the session. So thank you very much and for inviting me. And now I have the privilege to invite Professor Jan Leroux from Brussels. Has he joined us online? He joined us online. Okay. So Professor Jan Leroux himself is an emeritus professor of surgery and director of Stars and Abdominal Transplant Unit, University Hospital St. Luke and UCL Transplant Center in Brussels. He has been past president of the multiple international societies, which includes European Society of Organ Transplantation, International Liver Transplant Society, and various other societies. He has worked under the pioneers of liver transplant and done fellowship under Professor Starzl, Professor Bismuth, and learned the nuances of liver surgeries from Professor Blumgard himself as well. He is fluent in 7 different languages and has worked in different cultural environment, which has helped him to actually amalgamate the Eastern and the Western liver transplant world, and this has helped him to serve as further as president of various societies. And he currently is also a worldwide referee in many different transplantation matters. And in spite of all this, he has found some time to publish over 381 peer-reviewed articles. He has organized more than 50 surgical transplantation meetings. He has also been an editor of the book Regenerative Medicine and Organ Transplantation. Apart from this, he has also received the Distinguished Service Awards from IOTS and ELITA. And if I continue further, I guess this will encroach upon his talk time. So let us invite Professor Jan Leroux from Brussels, who will talk to us on liver transplantation in HCC. How far can we go and how far should we go? Professor Leroux, please.
Thank you very much for the introduction. I would prefer that you show the video because there is a lot of interference with the sound. So I think it's better to play my video, and I will be there, of course, live also for questions and answers.
Yeah, please play Dr. Leroux's video.
In fact, today's in almost most allocation organisms, the inclusion criteria for are restricted to the pure morphologic first Milan and afterwards UCSF criteria. These criteria that show when sticking to tumors less than 5 centimeters or 3 tumors less than 3 centimeters, that outstanding results can be obtained. The San Francisco group was the first to realize 5 years later that these inclusion criteria were in fact much too strict, and they extended the tumor load by about 1.5 centimeters. If we look at these inclusion criteria, one can easily understand that the role for liver transplantation is only a minor one when we stick to them. So the question for today's talk is, how can we now safely extend the inclusion criteria for these patients without compromising the outcome, meaning without eliminating the high risk for post-transplant tumor recurrence? So the restricted criteria introduced almost 25 years ago, as you can see, are in fact based on a completely illogical oncologic approach. Nobody takes care of the diameter of a tumor only when treating whatever cancer patients. So these criteria are too conservative and too restrictive. So we have to look at this problem in another way, and this will be the proposal of my presentation. Our group did recently a systematic review according to PRISMA guidelines, and we were astonished to find not less than 58 different scores indicating clearly the insatisfaction of the transplant community with these restrictive Milan and San Francisco criteria. Moreover, as you can see, most of these scores were developed in the Asian or Eastern countries because of their huge experience in the field of living donor liver transplantation, which avoids interference with the sparse organ pool, but which allow also to plan perfectly well an oncologic operation. If we look at the results, we see that excellent 75% overall survival can be obtained, even when extending largely the inclusion criteria. And to our surprise, we saw, in fact, that the recurrence-free survivals were almost not different and only became less good when these so-called new criteria were overruled. So it is clear if we want to extend inclusion criteria, we have to respect the ethical principles of transplantation, namely justice, equity, and most of all, we must look at utility to avoid to throw away sparse grafts. So how can we extend the modality? There are 4 options in my opinion. The first is to combine static tumor morphology and biology. And indeed, that biology is important, has been shown very well by this nice San Francisco paper, in which the authors observed that several patients, despite being Milan-in, dropped out on the waiting list. The reason for this was that they had an unfavorable biological behavior, as shown by a higher AF level. And these observations have then been confirmed clearly by the liver transplantation experience in Asia. You see now that up to 10 tumors less than 5 centimeters can be transplanted with good results by adding to the morphologic criteria, the biologic criteria, and it is not only anymore alpha-fetoprotein, but now also the protein-induced vitamin K absence or this carboxyprotein level. So in fact, if we do living donor liver transplantation, and if we include also biological markers, we can control factors time and tumor in a much better way. The literature is due to the confusion that came off at the different cut-off values of these biological markers. As you can see, there are many publications about this, and you see that all show that if you have a lower than the foreseen cut-off level, that the results are usually better. Now, the group was pioneering in this field by introducing the PIVCA2 levels. And we know that PIVCA2 or DCP is a very unfavorable prognostic factor. And you see that the Kyoto group was able now to transplant patients with up to 10 tumors less than 5 centimeters with extremely good results on the condition that the PIVCA level or DCP level was below 400 milli-arbitrary units. And the Japanese Liver Transplant Society group took up another group to combine alpha-fetoprotein and PIVCA, the so-called A score, and you see that you are reading this score independently of the Milan criteria, that the results can be outstanding. This criteria would be now recently a little bit more refined by applying the 55500 rule, meaning transplanting up to 5 tumors less than up to 5 centimeters with an AFP level up to 500. And you see again, in addition to also disease-free survival, that you are without the Milan criteria, but within these 55500 rules, that the result can be very excellent. We looked in a small collaborative study with Fukuoka, Kyoto, and Kona, and looked to the impact of DCP. First of all, we saw that about 2/3 of the tumors do not secrete AFP, but the most important result of this small study was that the higher PIVCA level, DCP level, overrules, in fact, the Milan criteria and also the DCP level. This has been taken further by the Seoul National University Hospital Group with the development of the model for recurrence after living donor liver transplantation. And you can see again by combining PIVCA and the alpha-fetoprotein level that the results can be excellent even if the patients are outside the Milan criteria. The Milan group developed an alternate model scored by now implementing inflammatory markers such as neutrophil lymphocyte ratio. You see also that if you are Miller out, if you stick within these criteria, the results can be the same as the Milan A patients. The inflammatory markers are important because they give us an idea about the balance between inflammatory and immunologic responses to the tumor. Cutoff values in the literature are set at NLR to be 5 and for the platelet lymphocyte ratio at around 150, and their values seem to be more pronounced in our patients. It is well known that if you encompass the NLR level of 5, that your results are less good. And by the way, these inflammatory markers are not only important in relation to prognosis for HCC patients, but also for patients presenting many other types of tumors. We looked in the group again at the PLR level, and we showed that the level of more than 150 was equal to worse outcome. So extension modality now should be not only to combine static morphology and biology, but now go to the dynamic changes of these two parameters. And in fact, this is logic because we know from the literature that 75 to 80% of the patients anyway will have a local regional therapy independent of their selection for transplantation or not. The local regional therapy can be seen as a bridging therapy that needs to reach the transplantation goal. It can be seen as a downstaging therapy that means to reduce the aggressivity of the tumor, and it can also be seen as a neoadjuvant therapy leading to the improvement of the results of transplantation. So local regional therapy is thus a tool not only to decrease the tumor burden, to accept the criteria for transplantation, but it's most of all a selection tool in order to look at patients which have a more favorable behavior. And local regional therapy can be surgical or non-surgical. Indeed, only a small amount of patients which have a liver disease can have a partial hepatectomy, segmentectomy, or sectorectomy. But we know since 1999, by the publication on the Starkson group, that once you look at long-term outcomes, transplantation is always the best treatment in these patients. And you see here the importance of tumor dynamics. For instance, a French study showing that we have a progression of AFP by more than 50 nanograms every 15 days, that the outcome is much less good. And another study from the Scientific Registry of Transplant Recipients in North America showing that patients with a high level of AFP that can be brought by local regional therapy to a much lower level indeed generated the best result after transplantation. Again, if we look at dynamic tumor behavior, we must include in the future in all these patients also the PIVCA or DCP value. And you see on this slide, again, from our smaller collaboration, these results have not yet been published, that a lot of patients which have no expression of AFP, in fact, can have even a very high expression of PIVCA2 levels. And the example, the curve of this of one of our patients shows very well the importance to look at both tumor markers. If you would have looked in these patients only at AFP, which is a clear blue line at the bottom, we would have no idea if there was a biological response to the local regional therapy. The level of the DCP indeed showed that the response was in fact phenomenal. The patient was finally transplanted and is doing very well now, almost 7 years after transplantation. Again, if we look at dynamic AFP DCP values, we were not able to have the dynamics of both parameters, but you see on these slides, combining the slope of AFP and the value of DCP, that if we have high DCP levels, that the outcome is always much worse. So local regional therapy and tumor dynamics, the role is important, published already 25 years ago by the Bismuth group, and it shows that you have a good downstaging of your tumor, that the results are remarkably better after transplantation. So we can document this downstaging by using the mRECIST criteria, by looking at the evolution of the tumor markers, and you see here a good example of a patient which was refused for transplantation, finally downstaged, finally transplanted, and is now 15 years after transplantation tumor-free. So it is also important, we know this from the analysis of the hepatectomy specimen, that the more pronounced is a necrosis after applying a local regional therapy, the better will even be the outcome after transplantation. And you see from these two experiences, the left one from the Brussels, from my group, and the right one from the Mainz group in Germany, which whom I worked closely together, you see that if we have a response following MRSIS criteria and a response in relation to the AFP slope, that the blue line, which represents the Milan outpatients, the results can be the same as those of the Milan inpatients represented by the green line. And in fact, the Mainz group showed that the most sensitive predictor of recurrence was any progression after local regional therapy. These tumor dynamics have now been widened by including bionuclear markers. It's especially done by the SEO groups and the Kaohsiung group from Professor Cheng in Taiwan. You see if we have a low uptake at scintigraphy, the results are much better. And this is now the reason that these groups go on and started to transplant presenting hepatocellular cancer, even with a macrovascular invasion of the prostate. Waiting time is important. It has been shown in many studies that the shorter the waiting time, the less good is the results. And this is logical because short time does not allow to judge the aggressiveness of the tumor. And we finally combined all these risk factors, which are easily available for transplantation. We put them together in what we call TRAIN score, combining time, radiologic response, alpha-fetoprotein, and inflammatory markers. We put together several centers with a huge number of patients, and you can see that if we classify the patients following TRAIN score or following Milan score, that the results were exactly the same. But importantly, in the TRAIN scores, we were able to transplant 1/3 of patients more without compromising their results. We started then to looking further, refining the scores. So in summary, extension modalities 1 and 2 are well represented on this slide. What we had before these extension criteria is what is indicated there in blue. What we have now since introducing these extension modalities, you see that we are now able to control the factor tumor, the factor time, and we think it is now really necessary that all allocation organisms should change their allocation models for HCC patients. What is the role of biology and biopsy? I'm not so sure it will play a major role because we know there is a huge heterogeneity within the tumor in relation to morphology, genetics, and even immunohistochemical staining. So how can we further progress? Well, we can further progress by implementing donor liver transplantation. And this has been clearly shown by the Western Toronto group, which shows that LDLT has much better survival after transplantation. But you see immediately that the reason for this is that we have less dropout. And we work together. I created an East-West HCCLT consortium, including now 3,000 patients listed in 10 centers over the world. The interest of this consortium is that we can mix patients which have been treated using disease donation and donation. You see that in the TRAIN score, we could already extend clearly the indications, the inclusion criteria for transplantation without compromising the results, I mean, without inducing a high number of recurrence. When putting together the East-West TRAIN score, we now added more parameters based on statistical analysis, and these parameters were living donor liver transplantation and the diameter of the largest tumor. You see immediately in the training set and the validation done by the Hong Kong and the Toronto centers that the dropout is almost zeros. And based on statistical analysis using propensity score matching and inverse propensity therapy weighting, we could see that in fact LDLT is an enormous protective factor, reducing the intention to treat risk for death after transplantation in these patients by around 40%. And this is due to the virtual MLA elimination of dropout. The results of these studies have been published recently in a very high impact factor journal, JAMA Surgery 2021. You see that LDLT markedly reduced intention to treat mortality after transplantation, and that we have a benefit at 10 years of 20% survival. And the same results were seen in the validation sets. We went now further on to refine this East-West train score by implementing artificial intelligence, as already suggested by the Toronto and the Seoul groups. We included now 8 variables: LDLT, diameter of the largest lesion, the number of nodules, the MELD score, and what is important probably also is the eye center volume, because allowing a better access to transplantation. And based on these analyses, we show that the train eye study score was performing better than all other classically used models in liver allocation today throughout the world. We were able to create a calculator which allows not only to calculate but also to recalculate the risk model at any time point during the waiting time, and thus also what is important after applying neoadjuvant local regional therapy. This work is now submitted to Journal of Hepatology, and we are working also at integrating DCP dynamics in this model. So finally, but I would say last but not least, what about immunosuppression? Because all studies about cancer and liver transplantation speak about all possible parameters and score, but never about immunosuppression. And this is very curious because we know that immunosuppression creates a pure pro-tumorigenic environment. We know that transplant patients have an increased cancer risk, and we know also that patients which have a prophylactic treatment of allograft rejection, they have depressed host immunity, and they must therefore have an impact on the development of tumor after transplantation. So it is well known from clinical and experimental work that immunosuppression promotes cancer by direct cellular effect independent of the recipient immune cells. And hepatocellular cancer recurrence after liver transplantation has almost never been addressed in the literature. I made some years ago a systematic review about this, and it is curious that this only happened in 2017 because we knew already from 1981 that Professor Stasel and Israel Penn indicated that there is a much higher incidence of tumor development in patients which have a chronic use of immunosuppressive drugs. The role of immunosuppression is very controversial. There has been a hype in relation to the mTOR inhibition. Suddenly, mTOR inhibition would reduce in an important way recurrence after transplantation. To my surprise, in this literature review, this happened even more in patients with a lower tumor burden. But in fact, when we look at the only prospective randomized study that has been done in this context, the SILVER study, led by Edward Geisler from Regensburg in Germany, you see that at 5 years there is no difference at all in the outcome of these patients. So mTOR inhibition is not the answer to the question. The answer to the question is to use an as low as possible prophylactic immunosuppression. In this Journal of Hepatology publication is very well shown that low levels of tacrolimus or of CNIs are equal to a lower risk of recurrence. In a study we undertook in relation to therapeutic immunosuppression, namely patients treated for rejection, we looked at patients transplanted for HCC with an IBAN score. There were IBAN scores who were not treated, and there were IBAN scores which were treated, but you see that those who were treated, exact the same patients, had an 18 times more incidence of transplantation. Where mTOR inhibition surely plays a role is when a recurrence appears after transplantation, very well shown by Sungyoli's group in Assam Medical Center, and you see that the outcome is better if you use mTOR inhibition, and this is independent of the use or not of sorafenib and similar drugs. So to come at the end of the presentation, I think we can now say that we can extend safely the inclusion criteria for transplantation based on dynamic combination of morphology and biological tumor characteristics. The question is now, can we go further to advanced criteria patients? Probably we can, not only by including dynamic biomarkers, but now also with radioimmunotherapy, and this will surely be another avenue that is now ready to go. So in conclusion, Mr. Chairman, ladies and gentlemen, how far can and should we go in this field of transplant oncology? We must take the actions necessary to expand justifiably the inclusion criteria and especially to avoid futile liver transplantation. How can we do this? We have to combine morphologic and biologic markers. We have to evaluate the dynamics of the tumor markers under optimized local regional treatment. We have to use much more widely living donor liver transplantation because this is also very important when interpreting the difference of results obtained in the eastern and western parts of the world. And there is now a proposal to use an online artificial intelligence-based HCC recurrence risk calculator, which will hopefully show to be of great help for the transplant. So implementing these action points will all be necessary to optimize the outcome of these patients. And I think therefore we should from now on consider every patient with early, intermediate, and also some with advanced lesions for transplantation. I thank you for your attention.
Thank you very much, Professor Leonard, for such a fantastic. Can we have him back? Is the link on? Thank you, Professor Leonard, for such a fantastic and eloquent session. I would like to thank you for joining online from Brussels, despite the time difference. And while we are waiting for questions from the stadium, there is one. Yeah, okay. So please come, Professor Duda.
Hello, Jan. It's great talk and great to see you. So
thank you.
I want to ask a question about the last part. So you didn't discuss about immune checkpoint blockade. I mean, too much, but sorafenib, I think conceptually may be difficult to prevent the recurrence. But with immunotherapy, there's some hope that you can also characterize after you do the transplant, the tumor, and maybe tailor the immune checkpoint blockade. So do you think there's a role in the context of immunosuppressive treatment? Do you think there's a role for immune checkpoint blockade?
Yes, I am convinced of it. So I did not go into this more because of the time constraints, of course, and it's more a general talk. But I think there is now already enough evidence that we start to know that we combine immunosuppressed transplant patients and immunotherapy. There have already been, I have no personal experience, but there have been already very nice publications about this. For instance, from MD Anderson, and I think also now from the Mayo Clinic. These patients must, of course, be carefully followed because it is known that you have a greater risk of rejection, but this risk is in fact not prohibitive. There is already no indication, for instance, that patients who are under monotherapy with CNIs, that you can combine rather safely already immunotherapy with their immunosuppressive treatment. It is also known that it is surely bad what has been done initial trials. The patient has a recurrence, has an aggressive recurrence, and then the teams decided to stop immediately immunosuppression and to go to immunotherapy. But several of these patients made a major rejection. And this is also known from kidney transplantation. There have been cases described in kidney transplantation in which immunosuppression has been stopped because of de novo tumors, and they made even an hemorrhagic necrosis of their graft. So it is a combination of a cellular and antibody-mediated rejection. But I think that the future of transplantation is anyway oncology. This is the start of transplantation, and we now know that we can already safely combine immunosuppression and chemotherapy. This is the initial experience for metastases who are transplanted, but we can also now combine immunosuppression and immunotherapy, and probably in the future, the transplant will be, as in every oncologic treatment, it will be in between neoadjuvant and adjuvant treatment. That's my opinion. And the progresses go parallel in oncology, in medical oncology, in surgical oncology, and this is a very good thing for the patients. And also, it may be important to say that these transplantations are the most economic treatment of cancer patients. A transplant who is successful is much better and much cheaper, in fact, than all other therapies, because the recurrence-free survival, as you have seen, even if you extend the criteria, is 75% disease-free survival after 5 and 10 years. So I think we should also start to speak more about disease-free survival and not anymore about overall survival.
So I think this was the adjuvant setting what Professor Duda was asking, and he's trying to explain the use of therapy in the adjuvant setting. But I think there's still a lot of work going on, including the neoadjuvant as well. So can we add the similar therapy in neoadjuvant setting while the patient is waiting to get a graft if he doesn't have an access to a living donor, or even if he has an access to a living donor, would you advise to treat them preoperatively with a neoadjuvant setting chemotherapy, which with the newer drugs which has come in?
Yes, it is already been done, but I think we must also be careful, because that we don't overuse it and that it's not become a hype like it was with sirolimus and everolimus. I have seen the first case was being published in a big journal, Hepatology, about successful use of immunotherapy as neoadjuvant treatment in the context of liver transplantation, was a patient who was Milan-in. So I think this is not right, because Milan-in, they have normally 90% 5 and 10-year disease-free survival. And if it is not a mixed cancer, this is excluded. So I think all these therapies should be addressed to the patients who really need it. So, and the more you extend, I think that the rule should be more oncologic approach and use much less immunosuppression. You know, probably from my experience, since more than 20 years, all patients are on monotherapy, low dose, even infratherapeutic from day 0, no other treatment. And this is what we have to do. We have to combine now all the knowledges from oncology, immunology, and transplant.
Thank you, sir. And what do you advise for portal vein tumor thrombosis? Do you advise liver transplant for these cases, or are they still under study?
Can you repeat, because the sound is not always there is some delay. You can.
No problem. So liver transplantation for those patients who have developed portal vein tumor thrombosis, what is your thought about it?
I think there is again a place for it, but we must be careful. We know from the experience from Seoul, from Delhi, and so on. You have to apply stereotactic radiotherapy. It's, I think, a good way to do. But for instance, it's like sirolimus, in my opinion, the early results were better. But if you go at 5 years, the results are the same. But again, it is an avenue that is open. And I know from Seoul, for instance, Assam Medical Center has now really developed a huge program already, combining TACE with stereotactic radiotherapy, and then transplant the patient if they respond to the treatment.
So do we have any other questions? Yes, we have one more. Dr. Shalin, please. Go ahead.
Professor Leroux, this is Dr. Shalin from Delhi. I just wanted to share this personal experience with regards to what Dr. Duda asked about the role of immunotherapy, management of recurrence. So we were very enthusiastic about it, and we had treated 3 patients of early recurrence. Early, I mean to say within the first year after transplant, but we had to stop the therapy midway because of rejection in 2 of these patients, and that was a pretty severe rejection, difficult to treat one rejection. So I'm not sure that we are really at reached that stage where we can recommend immunotherapy routinely for patients of recurrence after transplant, especially early recurrence. So we have a very small experience, but just wanted to share on this.
Point well taken, Dr. Shalin. So even
I agree, but it is well known These patients must be followed very, very closely. The slightest hesitation you have, you must stop the therapy. That's clear. That's known. But the more recent results are already much better than the initial experience in relation to rejection. But you are absolutely right what you said.
Yes. We have one more question, please. Go ahead.
Thank you, sir. I'm Trilango Sethu from Chennai. With regard to bridging therapies prior to transplantation, the recommended wait time is about 3 months. The tumor doubling time in HCC is usually between 3 and 5 months. Would a longer wait time be better when we select patients for LDLT to get a better long-term outcome? Or you still go with the 3-month recommendation?
I think 3 months is more than enough, because otherwise you lose the advantage of what you do. In my opinion, the main criteria is, I have other opinion than many others, of course, but what is downstaging? A lot of confusion from the literature comes that downstaging means, for instance, bringing a patient which is outside Milan criteria within the Milan criteria. But I think this is not the real meaning of downstaging. In every field of oncology, take it pancreas cancer or whatever, downstaging means that you have a morphologic and biologic response. So I think if you have a morphologic and biologic response, you can wait a little bit, some months, but not more, and then transplant the patient, especially if you have living donor. We should not forget also that the more you do local regional treatments, the more you may compromise the surgery of living donation in relation to arterial arteritis and so on and so on. We should not forget the complications of repeated local regional therapy in living donor liver transplantation. This has been published already a long time ago also. So I think we must gather all these experiences. But in my opinion, when you get a response, you should go on.
Thank you, sir.
Thank you so much. Once again, I would like to thank Professor Jan Leroux for joining us from Brussels. Thank you, Professor, and I'll hand over to Dr. Anand, my colleague.
Thank you very much for the invitation. Thank you.
Thank you, respected chairperson and speaker. We'll be having a tea break for 10 minutes, and we'll start next session on 11:30. Thank you.
और अच्छा किया जा सके इस बारे में प्रयत्न हो रहे हैं। और ये जो जयपुर सर्जिकल फेस्टिवल 3 दिन का हमने महात्मा गांधी अस्पताल में आयोजित किया है, इसका एक पर्पस गॉल ब्लैडर, लिवर और पैन
to moderate the session. Dr. Shalin Agrawal is a senior consultant liver transplant and hepatopancreatobiliary surgeon at the Center for Liver and Biliary Sciences, Max Saket Hospital, Delhi. And sir, over to you. Sir,
Dr. Ajay, should I start or wait for the people? Okay. Just a gentle request, we'll start the sessions on time and we'll try to end the sessions on time. I am sorry if it is inconvenient to anybody, but I think we'll have to restrict to the time.
Yeah.
Please.
So at the outset, I would like to thank Dr. Ajay, Dr. Professor V.K. Kapoor, he's my teacher, my guide. So it's an honor to be here, and it's very nostalgic for me to meet my old colleagues and teachers. So thanks a lot for having me here, Dr. Ajay. So I'll begin the proceedings for this session, and I have been asked to moderate a panel discussion on liver resection for hepatocellular cancer. So as we know that this is a very pertinent topic because resection can be performed more easily, it's more widely available vis-a-vis transplant, although there are indications and contraindications for liver resection, and my aim in this panel discussion is to highlight those issues keeping in mind that this conference and this meeting is aimed towards postgraduate. So there will be some issues which you may find very elementary, but they have been purposely put in so that the postgraduates who are here or have joined online can benefit from this discussion. So I'll begin with inviting my panelists. Amongst the esteemed panelists are Dr. Hitesh Chhabra, who is the senior consultant in GI, HPV and liver transplant surgery at Sir Sterling Hospital, Ahmedabad. Next, I would like to invite Dr. Vishal Kumar Shelat, who is a senior consultant in HPV and general surgery at Tan Chok Seng Hospital, Singapore, and he's also the director of surgical science and training at the same hospital. Next, I would like to invite Dr. Swati Purohit, who is a consultant radiologist at this very center, that is Mahatma Gandhi University of Medical Sciences, Jaipur. Dr. Swati, please. Next, amongst the panelists who would be joining online are Dr. Govind Nandkumar, who is the Director of GI Surgery and GI Oncology at Manipal Hospital, Bangalore, and also courtesy faculty at Weill Cornell Medical College, NY. And then the fifth panelist would be Dr. Jayant Reddy, who's again a senior consultant in hepatobiliary and multi-organ transplant at Apollo Hospital, Bangalore. So a very warm welcome to all our panelists. So I would set the ball rolling now. So just a brief background. HCC is the sixth most common malignancy and a very lethal one because it's the third most common cause of cancer-related mortality. Amongst the primary liver tumors, HCC is the most common. However, 90% of these arise on a background of liver cirrhosis. So normal liver is kind of protected from it has a immune protection from development of cancer, and most of the cancers develop on a background of cirrhosis, which has very important implication when we embark on treating these cancers, especially with surgery. However, some cancers may arise de novo, especially in patients with chronic hepatitis B, even without cirrhosis. Therefore, surveillance is recommended in the high-risk groups, and there are various guidelines. The ASLD guidelines are followed most often, where ultrasound every 6 months has been advised as a surveillance tool. And there are multiple treatment options, but due to the shortage of time and my topic is limited to resection, so I would limit to surgical resection. The other treatment modalities would be covered in the subsequent sessions. So I would just start this session by highlighting two cases that we operated over the last during the last 3 months. The case one is a 54-year-old gentleman who was a known diabetic for 10 years, presented with vague complaints of dull aching pain and weight loss during the last 6 months, but there was no history of any jaundice, GI bleed, or ascites. Physical examination was non-contributory. He presented to us with a screening ultrasound which had suggested a mass lesion in the left lobe liver with the liver parenchyma showing a normal echo texture. His blood investigations in the form of complete blood counts, the liver function test, the kidney function test, INA were within normal range. And we just did a fibroscan to rule out fibrosis, and which again showed a normal liver. His tumor markers, serum AFP was elevated, 489, and PIVCA was 1220, both of them being elevated. So this is the MR picture of this patient, and since it was a large tumor but restricted to left lobe, we thought of resection, but we wanted to calculate the residual right liver volume, which was quite satisfactory, 67%. Therefore, we performed a staging laparoscopy followed by left hepatectomy. We always do a staging laparoscopy for two reasons. One is to look for any surface mets, which though are less common when we compare with gallbladder cancer or pancreatic cancer, but we do have surprises, and more importantly, to rule out cirrhotic morphology, because that may change your entire plan. You may not be able to perform a major resection, because we have been caught in the past where every imaging had shown a normal liver, but ultimately it turned out to be a cirrhotic liver. And this is the case 2. This was another 57-year-old gentleman, known case of chronic hepatitis C that had been treated. Patient had achieved SVR. He had presented again with anorexia and weight loss of 2 months duration, and there was no history of hepatic decompensation. Physical examination did not show any positive findings. As per the investigations, he fell into the child's A score category. AFP was normal, and upper GI endoscopy did not show any evidence of portal hypertension. This was the CT scan, and I put up this case just to show that this was an advanced right lobe infiltrative lesion, which was with a thrombus in the right portal vein going up to the confluence and just into the main portal vein. So again, we did further investigation to rule out extrahepatic disease, which was not seen on a PET CT. And the MRI confirmed the findings of the CT, which shows a diffusely infiltrative lesion with enhancement and washout. And the future liver remnant was 46%. And we did again an open right hepatectomy, for this case. And both these patients recovered well. This is just to give a brief background for the subsequent discussion. So now I would start the discussion part. So first of all, diagnosing the hepatocellular cancer. So this would obviously be a question for Dr. Swati, who's the radiologist in this group. And the first question be, what is the role of screening ultrasound in a cirrhotic liver, Dr. Swati?
So ultrasound is a very non-invasive technique, and therefore it is very easily available, and therefore it is used as a screening this. In patients who already have chronic liver disease and cirrhosis, ultrasound is a very good modality because every 6 months we can just do the screening, and if we find any lesion, new lesion which does not fit into the criteria of any benign nodule, definitely we, and if it is suspicious, not very much confirmatory on USG, then we ask for further imaging modalities, that is CT and MRI.
You are absolutely right, Dr. Swati, but my question was more with regards to that in a cirrhotic liver, it is a nodular liver. So how easy or what would be the specificity of any lesion being picked up of an ultrasound? Because very often patients come to us who said that an ultrasound was done about few months back, there was nothing, and now suddenly there's a large lesion on the cross-sectional imaging. And when I looked at the literature, it said that the reported sensitivity of ultrasound in a cirrhotic background is not more than 60%. Even with the most experienced hands, it's around 80%, though, as you rightly said, it's the standard recommendation amongst the various guidelines, including the ASLD guidelines, just because, as you said, of the low cost, easy availability and safety profile. So what would be your take on the low sensitivity in the cirrhotic background of an ultrasound?
Sir, actually, in case of cirrhosis liver, the liver architecture is very much deformed, and at times it has a very nodular kind of an architecture and heterogeneous. So at times it is very difficult to pick up subtle small nodules. This is not in the case of huge nodules, big nodules, which can be easily, because they are at times they're not well defined, they have a mosaic architecture. But yes, if in case of subtle nodules, it is very difficult to be picked up on USG. Definitely the sensitivity is very low. But along with, sometimes, sir, instead of just we have an ill-defined area, but then along with that, if we see any thrombosis in the veins or any focal architecture distortion and something, then definitely we feel that there is something wrong. And then it is always good to have a look at the previous USGs, because this is how we can understand if there is any new finding in the current USG.
So basically, the person who's doing the ultrasound has to have a very high index of suspicion whenever performing even a screening ultrasound in a patient with a known cirrhotic background. So this is the only message that I wanted to convey to our postgraduates. Coming to the main imaging modality, which is cross-sectional imaging. So, Dr. Swati, I know all of the people present in the audience will know what are the diagnostic criteria, but just would you kindly reiterate what are the diagnostic criteria for HCC on a contrast-enhanced CT or an MRI? And second question in the same vein would be, what are the advantages or the disadvantages when you compare contrast CT with a contrast MRI?
Sir, considering CT and MRI, actually nowadays we are using the LIRADS criteria, and this criteria basically it helps us just in the standardization and of the report, so that the clinician exactly knows what we want to convey to them. And CT and MRI both are good imaging modalities, no doubt. And when we talk about the major diagnostic features which help us in diagnosing the HCC, then there are 5 main features. That is, the major features are that there should be a non-rim arterial hyperenhancement of the lesion. There should be a non-peripheral washout of the lesion in portal phase. In delayed phases, we see there is a capsule enhancement. Along with it, there are two other criteria. The criteria is that the threshold growth and the size of the lesion. Because these major features, they help us in diagnosing, and this is how we come to the which category of this is to be assigned in the LIRADS. Like LIRADS 5 is when it is definitely HCC. Apart from this, there are other few ancillary features which will help us in the diagnosing of HCC. They are mostly seen better in the many sequences of MRI, and in a way that is why MRI is slight, it has a upper hand. Like in case of we have extra sequences, like we are doing the in and out phase sequences, we are doing the hepatocellular phase also we are doing. For that we are giving a separate contrast. So this is why MRI can have a slightly upper hand when it comes to diagnosing these small tumors. When I talk about the ancillary findings, there are other such findings also. When we are doing, for example, if there is fat inside the lesion, or if there are blood products in the lesion, then if there is a nodule in nodule appearance, if there is a mosaic architecture of the nodule which we are seeing, then all these definitely help us in the diagnosis of HCC.
So, Dr. Swati, I've just briefly put it what you have said in detail. So, definitely LIRADS is of great help in really saying which of the lesions would actually be cirrhotic. So, L4 and L5 should be considered as HCCs in a cirrhotic background. And basically, it's the hyper enhancement and the washout, which as physicians and surgeons we all follow, besides the rim enhancement. So, Dr. Swati has enumerated that nicely. And MRI scores over CT to some extent, especially in smaller lesions, because of the additional sequences that you can run. But again, disadvantage is that we have seen higher false positivity rates, and of course many patients wouldn't like to undergo an MRI because of they are claustrophobic. So MRI does score, but again there are some disadvantages. Quickly coming to the role of PET-CT, Dr. Swati, just in brief, because time is very limited.
Sir, PET-CT basically has a more role when it comes to the extrahepatic disease spread, and that is mostly in cases of patients who are having a normal liver or non-cirrhotic liver, mainly because in the chronic liver disease or the cirrhotic patients, we are doing a regular ultrasound say after 6 months, and the patients are mostly under observation. But in cases of non-cirrhotic livers, usually we see that the lesions are large enough when they present to us, and that is the time when there is a more chance of a spread, and that is when FDG PET is basically used.
You're absolutely right again. So, Dr. Swati, what I have enumerated, you just said that. So, detection of extrahepatic disease in advanced HCC, because you have higher chances of a positive report. It's not recommended as a routine investigation tool for oncological workup. That is the point I wanted to make. And then FDG is considered as a biological marker of it's a poor prognostic factor. So as Dr. Jean Leroux also said that it has been included in some of the prognostic scores for predicting the outcomes after transplant. And then it is done routinely by some centers for patients who are planned for liver transplant, because this PET-CT may pick up some incidental lesions, but that in our experience often confuses the matter. So we don't routinely recommend PET-CT, and that is not recommended in any of the guidelines also. It should be done basically for picking up extrahepatic disease in patients with advanced HCC. And its usefulness is greater when you are following up these patients. So any patient after resection or liver transplant, if presenting even with slight rise in AFP, you should subject these patients to a PET-CT, and you may pick up recurrences. So the main role of PET-CT is for diagnosing extrahepatic disease in advanced HCC and in follow-up. So coming to the role of liver biopsy, and this question would be for Dr. Vishal. So when would you consider a liver biopsy, Dr. Vishal, when you are evaluating a patient of HCC in your OPD?
I think routinely we don't perform liver biopsy to diagnose or manage a HCC. In situations of uncertainty, when the tumor is peripherally located and it could be technically removed easily by laparoscopic means, we would be advising patient for resectional biopsy rather than percutaneous diagnostic biopsy. I think for sure role of liver biopsy is in patients where you have a diagnostic dilemma, and when the patient is not really ready for you to proceed with the therapeutic procedure. Many times, if the lesion is below 2 centimeter, in Singapore, we have this approach called bite and burn. So biopsy and ablate at the same sitting. Of course, with the counseling and discussion with the patient, that if it's benign, it's an overtreatment, but it's cancer, you don't need to be readmitted, and so on and so forth.
So that is a very important point that you have made, Dr. Vishal, and that is what I would like the students to take that message, is that biopsy is not routinely recommended. Although there's a lot of talk, and the previous speakers also stressed about the need for biopsy, because as we all know, and this is a very oft-repeated statement, that biology is ultimately the king, but still, routine biopsy for determining the biological or genetic profile of the tumor is still not recommended outside of clinical trials. So biopsy, there are only two indications: when it's an indeterminate lesion and the patient doesn't want to undergo a resectional biopsy, either laparoscopically or open. So, and you have a diagnostic, like it's an L3 lesion on both CT and MRI, then this would be a very small percentage of cases, of course. So the indications of liver biopsy are very few and far apart, and this would be the two indications inside a clinical trial for determining the biology, and if it's an indeterminate lesion on imaging. So now coming to liver resection proper, and this would be a question for Dr. Hitesh. So what would be your considerations when you are considering a surgery for HCC usually it's a cirrhotic background?
So first of all, selection of patient is very important.
Yeah.
The performance status of the patient, ECOG 0 or 1, the associated comorbidities. The other thing is, as you said, it is in a background of cirrhosis. So we have to see the amount of cirrhosis, degree of the portal hypertension, liver function test, platelets, INR, presence or absence of ascites. We don't do HVPG routinely, but it is done in a few centers in India. And the last thing is the amount of resection that we are planning, whether it is a small resection or a large section, because in cirrhotic background, there has to be adequate future rival remnant, at least 40%, which is well vascularized. So the magnitude of resection in cirrhotic is important. And the other thing is the approach, whether we are going to do an open surgery or a laparoscopy. For peripherally located tumor, even if it is bigger in size and the remnant is bigger, then probably this patient will tolerate surgery well. So patient factors, the liver and the surgical approach, this all matters when we select a patient.
So Dr. Hitesh, what you just said, I have just enumerated that. So the evaluation of a patient prior to liver resection should be under these 5 heads. First of all, of course, whether the patient is fit for surgery or not, because most of these patients are geriatric population. And though age is no bar for surgery, but the performance status of the patient has to be assessed thoroughly, including the comorbidities that many of these patients often carry. Second is the liver function assessment, followed by the degree of portal hypertension, because as I just said, most of these patients do have a cirrhotic background. And then you have to assess the tumor burden, and as you rightly said, the surgical approach, that is what would be the amount of remaining liver after resection. So a unique thing about HCC is that vis-a-vis other cancers or malignancy which you are planning to operate upon, here besides the tumor burden, which is the consideration in all other malignancies, here you have to consider the condition of the underlying liver. So HCC is unique in that manner that besides the extent of tumor, the degree of invasion, you have to take into account the condition of the underlying liver before you proceed for a surgical intervention. And this is just again the enumeration of the same facts that you have to see for performance status, liver function, portal hypertension, tumor burden, and the future liver remnant. So my question would be to Dr. Nankumar, who has joined online. So welcome, Dr. Nankumar. And the question to you is, how would you assess the liver function in a patient whom you are planning to operate for HCC? And consider that this is a cirrhotic patient, because most of these patients carries underlying cirrhosis. He's not audible. Oh, Dr. Nankumar, you are muted.
Can you hear me? Yeah.
Can you unmute yourself?
Yeah, I'm unmuted. Can you hear me?
Yeah, now you're audible.
Yeah. So I think starting at a very basic level for the juniors in the audience, I think you need to look at the functional liver volume rather than the absolute volume. So tying into the prior discussion, we typically use our radiologists calculate with us the functional liver volume based on the size of the tumor and the size of the potential remnant. And we need to tie that in, obviously, into the actual function of the liver, so the quality of the liver. So now I know this is controversial, but sometimes I prefer to get in a tricky case, I prefer to get a biopsy of both the normal liver so that we can figure out how good the function is.
So, Dr. Nand Kumar, I have prepared this slide, and what the literature says and what we all follow is that first of all, you have to start from the simplest things, and that is you score these patients on the basis, the most commonly used being the CTP scores and the MELD scores, and resection is not recommended beyond A. Maybe some early B patients can undergo resection safely, depending, as you rightly said, depending on the size and the location of the tumor and the remnant volumes. And then any patient with MELD score 10 or above should also not be, they are not safe for resection. They may develop post liver failure. And many of the Asian centers, though I don't have much of personal experience, we have not been using ICG, but yes, in East Asia, this is a routine practice, and I think Dr. Vishal, you are using it. So ICG retention test is a very good test for assessment of the functionality of the liver. Although the criticism for this is still that you are not assessing the function of the remnant liver, you are assessing the function of the globally. So you may not be very sure how this resected liver would behave post-operatively, but it is a very good test. So Dr. Vishal, would you like to throw some light on this aspect of liver function evaluation?
Yeah, I think just to add on the ICG, we routinely do it for all our patients before they go liver resection, especially everybody with a major hepatectomy will have an ICG. Just I'll make 3 or 4 points which are important for juniors in the audience. The first is ICG is time-based. So you need to take the blood at specific time. Is 15 minutes is sacrosanct. Yeah. So you need to be there with the patient. You can't delegate the staff nurse or phlebo to do the test. So when I was junior in Singapore, I used to insert 2 cannulas, 1 cannula for injection, second just to draw the blood at 5 minutes, 10 minutes, 15 minutes, and 20 minutes. But now we have got rid of that, just 1 15 minutes. So I think timing is very important. If you're not timing, is inaccurate, patient must be fasted. The second part of ICG now, increasingly we are doing the colorectal patient had a previous chemotherapy exposure or even ALPS. In that situation, we are not so clear with these numbers of 15% and 20% with the previous chemo exposure to the liver, or in a dual situation where we have done ALPS in the first setting and to assess. So there, I think some investigations or data need to come out.
So that is a very important point that you raised, Dr. Vishal, because post-chemotherapy livers, though they may look morphologically normal, but functionally they may not be normal livers. And CASH, that is chemotherapy-associated steatohepatitis, is a very important factor to be considered when you are planning to do a major liver resection in a post-chemotherapy liver, because you may land up with problems with ascites and post-resection liver failure. So there the ICG has a role to play. So you made a very important point. And Dr. Nand Kumar, so how often would you do a biopsy of a normal liver? I know literature does mention that to assess the actual situation of the morphological status of the liver, people do biopsies, but how safe or how often do you?
I want to clarify that that is for a one-off case, where you're not. It's not. We wouldn't routinely do it. I think I agree. Your slide very nicely suggests the criteria that we use. I haven't started using the albumin bilirubin score, but I think it's something I should start doing.
So that is also because it's considered to be more accurate, the ALB score, albumin score. So if you have patients grade 2 and 3, please don't subject them to liver resection. And the accuracy of this score is even higher than the CTP scores that we have traditionally used. So even if a patient is CTP-A, just look at the ALB score, it's so easy. And then FibroScan is so commonly available. Again, it's been said that liver, and that is an EASL guidelines also, that any liver stiffness above 14 should be a contraindication for a routine major liver resection. Now coming to the next step, because you may have a normal looking liver, but then you may have an underlying portal hypertension, and that is again a very, that is clinically significant portal hypertension that you can assess on the basis of your routine clinical investigations. And that is again a contraindication for a major liver resection. So is Dr. Jayant Reddy with us? Because he was our 5th panelist. Has he joined?
No, he's not. Jayant is not able to join.
Okay. Thank you, sir. So I'll pass on the question to Dr. Hitesh. Dr. Hitesh, how would you assess for portal hypertension? You did mention about it, but can you elaborate it a little more?
We don't do
just a
HVPG as a routine investigation
Shalin,
preoperatively.
While we are having an active discussion between the panelist and the moderator going on, I think I would request if anybody has any questions, you can join in so that we can have more.
I didn't ask the audience because Dr. Kapoor said that there will be 15 minutes separately for the panelists.
After the panel.
Otherwise, we can do what, like if anybody wants to have some. Sorry, please.
So we don't use HVPG as a routine investigation. We see the size of the spleen. We do upper GI endoscopy if the patient is undergoing a major resection in cirrhotic background. We see for ascites, platelet counts. So all this indirect evidence of portal hypertension before we subject this patient to a resection. So,
Dr. Jain, would you like to add on to that? Hello, Dr. Jain? I think, sorry, Dr. Govind, I'm sorry. I apologize for that. Dr. Govind, can you add on to that? How would you assess the degree of portal hypertension? What is your routine practice?
So, I mean, I think I use the platelet count, splenic size. We haven't done, we don't routinely measure portal pressures as such. And, in it, again, here in a difficult case, I rely on the evaluation of an experienced hepatologist.
So this is what is being recommended that we routinely do. HVPG, as both the panelists, and I think Dr. Vishal would also agree, have said that HVPG is not done routinely. The surgeons do it routinely, although in many of the hepatology centers that is a very common practice, but then it has many drawbacks. Although it is a very standard cutoff you have that more than 10, it is clinically significant portal hypertension, but that is easier said than done. In the real life scenarios, there are many drawbacks. One, there is a lot of inter-observer variation. Then you can have technical complications. I myself seen, and we stopped doing HVPG after that, of major bleeding complication after an HVPG test. And the patients have decompensated after the procedure. So we have now, we are banking more on the less invasive test. Basically, it's such a simple test like a platelet count, and that is in the recommendations also, the various guidelines, EASL, ASLD also, a platelet count of less than 1 lakh. Splenomegaly, as our panelists mentioned, about more than 12 centimeter. These are signs of clinically significant portal hypertension. And there was a Bavino consensus that a fibroscan value, if you have a fibroscan value of less than 20, that is the mean stiffness, and the platelet count above 1.5 lakh, then they are low risk of clinically significant portal hypertension, and you can embark on a safe liver resection. And of course, upper GI endoscopy again is an easy and widely available tool. If you have anything more than grade 1 varices or PHG, then there is a sign of clinically significant portal hypertension. And you can also, even the cross-sectional imaging on CT, MRI, you can easily look for collaterals. And if there are significant collaterals, then it's another sign of significant portal hypertension. So these are the parameters. So vis-a-vis HVPG, HVPG was considered to be the gold standard, but no longer because of the various issues, though the papers do mention it. So I think in routine clinical practice, there are some simpler methods, including imaging and the blood counts, where you can, on the basis of which you can decide whether this patient is harboring underlying portal hypertension or not. So these are the Marcucci criteria, very famous Marcucci criteria. Therefore, I have put up this slide, and it is a very simple way of deciding on which patients can undergo and to what extent you can resect their livers. Basically, they are based on the ICG findings, the retention time of, like if less than 10%, you can do major resection, between 10 to 20, left hepatectomy, and then as the percentage, the retention time increases, then you do not do any major resection, and of course above 30% no resection. So these are Marcucci criteria basically for centers which are routinely doing ICG. Now coming to the oncological, from the oncological standpoint, so Dr. Vishal, what is your take on how to assess the tumor burden and which tumors would you like to resect? There are guidelines, I'll come to that, but in your center, what is your practice, how big the number, and what are your criteria on the basis of tumor burden which you will accept or reject for resection?
Ours is a non-transplant center, so resection is probably the forefront of our multidisciplinary board discussions and recommendations. Generally, broadly, we would not disqualify anyone based on the number or the size, because more important is what stays behind in the patient, which is our future liver remnant. So we do not have any size-based exclusion, any number-based exclusion, though we are aware that size and number probably could affect long-term survival outcomes or prognostic outcomes. Definitely, we wouldn't select anyone with an extrahepatic disease. Anecdotally, we have done some young men with portable lymph node, no evidence of other disease, just solitary lymph node, which was a metastatic lymph node, but we still went and did resection in those anecdotal situations. Probably, yeah.
So I totally agree with you that a small individual lymph node about 1.5 centimeters should not prevent you from proceeding going ahead. You may do a staging laparoscopy, although it's become quite routine to do endoscopic ultrasound guided FNAC of these nodes. But the more you investigate, the more problems you land in. So there should be a judicious balance of to what extent you are going to investigate these patients. And just because it's a forum for students, so I have put up the guidelines. And these are the EASL, ASLD, and the APASL guidelines, so that covers the entire globe. And they are unanimous that you can resect large tumors. And APASL guidelines are the widest. They say that if there's no extrahepatic disease and if your liver volume remnant is good, then you can resect any liver cancer, provided there's no extrahepatic disease, regardless of portal vein bile duct invasion. While the EASL guidelines are a little restrictive, although they have no size criteria, but they would not recommend liver resection with a patient who has obvious macrovascular invasion. On the other hand, ASLD has some size limitations, that is T1 and T2. Probably they have been borrowed from the transplant criteria, that is any cancer beyond T2, that's more than 5 centimeters or more than 3 tumors should not be resected. Although they have not put any restrictions with regards to the vascular or bile duct invasion. So there are some differences, but basically, when you are considering a patient, choose a patient who has Child's A, no clinically significant portal hypertension, and size, it's up to your expertise, your center's philosophy, but size should not be taken as a limiting criteria. And lastly, but most important, you have to see for the future liver remnant. So, Dr. Govind, question to you. What would be your considerations prior with regards to the future liver remnant? And this is the slide that I have put.
Yeah, I mean, I think especially with HCC, one of the things you need to consider is how much actual, functional volume the tumor itself is taking up. So sometimes the larger tumors, most of the liver function remains in the remnant liver. And I think the numbers are up on the slide. So that's one. Number two is going back to your prior discussion. I think one thing that we didn't talk about is the number of lesions. If it's a, if the remnant has foci of, tumors, or it looks like it's multifocal, or, I don't do transplant, but I'm more likely to, get one of the, so the short answer to that is I look at the remnant liver, both the volume, the function, and the risk of subtle HCCs that may be in the remnant liver. In addition to that, I think that you do need to consider the vascular anatomy of the remnant and what you're taking out.
Yeah, so that's a very important point that you made, and that's why it's not only the remnant functional liver volume that you have to calculate, and it's not sacrosanct that if you're more than 40%, then you can safely go ahead. There are many other considerations, and that's why the anatomical modeling. Many of the centers are doing 3D reconstruction, but even if the CT reconstruction of these livers is very important, basically to see the relation of the tumor with the Glisonian pedicle, the hepatic veins, because ultimately the amount you resect will depend not only on the size of the tumor, the distribution of the tumor, but at the same time you are not supposed to leave behind any devascularized areas of the liver, because they are worse. Even if in a patient who has 50% remnant, if you have a large devascularized area, they are more prone for decompensation vis-a-vis a patient who has a borderline remnant. So that's why a 3D modeling or any kind of reconstruction where you can see the relationship between the tumor and the vessels is extremely important. Dr. Swati, would you like to make a point here on regards to 3D reconstruction?
Yes, sir. This is one of the important aspects of CT scan because the volumetry is basically done in it, and definitely when we are calculating the FLR, that's what we are doing. We are also giving the various if there is any venous involvement and etc. And even the anatomy is very well delineated, and along with the calculation of the FLR, which definitely helps us in further management.
So this is a very important issue, and this should always be done. Next point is that is a lot of talk and controversy about anatomical versus non-anatomical resections. So I just want to summarize it in 2 lines. Anatomic resections have been shown to be superior to non-anatomic resections. There are recent meta-analysis on that, and as Dr. Kate had said, that is the most superior form of evidence. So the meta-analysis clearly show that the recurrences, both early and long term, are less when you are doing an anatomical, even if it's a segmental resection, because the intrahepatic metastasis occur through the portal pedicles. But the precedence over that is the safety. You are not going to remove the parenchyma just to get an anatomical resection. The first priority should be having an adequate and safe liver remnant, because you have to send the patient home alive without complications. Recurrence, the issue of recurrence is secondary. It is important, but it's secondary. And that's why Professor Torricelli would be joining us later, but I think he has mastered that art of ultrasound guided liver resection, very impressive videos. So he would talk about the segmental and some segmental resections. And with that, you can actually increase the gamut or the frontier of your liver resection, the number of patients that you can resect. Bilobar nodules, especially in colorectal liver mets, the extent of resection has been taken to a new level when you are doing these ultrasound guided limited segmental or subsegmental resections. And then if you don't have a future liver remnant, then portal vein embolization has a very important role. Dr. Hitesh, would you like to, Dr. Vishal and Hitesh, both of you, a brief word about portal vein embolization for augmentation?
I mean, in normal liver, portal vein embolization is going to work, but for cirrhotic, probably it is not going to, hypertrophy much. So it has got a limited role, and same with ALPS for
Dr.
cirrhotic
Vishal,
liver.
your experience with the portal vein embolization for augmentation of liver, remnant liver volume?
Yeah, I think we have done about 25 to 30 resections after PVE. In fact, in some patients where there is not enough hypertrophy after waiting for 6 weeks, we even go and do hepatic vein embolization. So we have now about 10-15 patients where we do a combo of PVE plus HVE. And I think it's important to select your patients well, because if it is very cirrhotic liver, PV is not going to make it any better, and it's just time is clicking. Sometimes we have patients where we have done PV, it's not growing, we'll do combined PV TACE. So we'll do a transarterial chemo plus PV, and after 6 months, if there is no disease progression, then we'll go and resect. And in my opinion, it's not only the future liver remnant size and etc. I think what this achieves is also ischemic preconditioning. So that is not actually easily measurable by any clinical or morphological means. But I've observed patients with apparently small FLR, but if they have got PVE and TACE done before, that tiny bit of liver, that small bit of liver is damn strong, and it's good enough for a patient to survive. Thank you.
Totally agreed. So our panelists have made the point that portal vein embolization is a good tool, but in cirrhotic livers, it doesn't work very well. And actually, it is a prognostic marker. If you wide variation of response rates from 30 to 80%, and that's probably of the mixed nature of the patient, the livers. Non-cirrhotic livers would respond very well to PVE, while on the other hand, cirrhotic livers, and as the degree of cirrhosis increases, the response rates go down. And many of these patients may actually decompensate. So augmentation of the volume is a sign that these patients are more prone to develop post-resection liver failure. So it's more of a prognostic marker, and it should be used with great caution when you are dealing with the cirrhotic liver. And of course, the results of ALPS have not been good in cirrhotic livers, especially for HCC. Very high mortality rates, early mortality rates up to 30%. And the low mortality rates that have been shown in some series like 7-8% are basically in patients who are very good risk patients. So patient selection is the key of success when you are considering ALPS, and avoid ALPS in a patient with significant cirrhosis. So now a purely surgical question. What are the challenges of liver surgery in cirrhosis? Dr. Govind.
Well, I mean, I think we have, for me, if we have planned this out, you know, looking at the FLR and everything that we've talked about to this point, then your challenges are very mechanical. Obviously, you may have portal hypertension. You need to be meticulous in your dissection. Your liver parenchyma is going to be hard. So in this situation, you have to have your comfortable kind of dissecting device. But really, I think now we are at a stage where if you have done everything we talked up to this point, then the plan in the OT, even your resection line, all of that is sorted out. One of the things I do routinely for liver resection, whether we need it or not, is I do my own ultrasound, because it gives us a roadmap and it gives us an ability to plan your surgery. And I think you had mentioned that you, in your cases, that you start with a laparoscopy. Obviously, in a cirrhotic patient, if you can achieve the resection as well laparoscopically, you probably will, laparoscopically and safely, then you'll probably decrease your complications. That's what I would comment.
I'm just putting your words into a slide. So actually, liver surgery in a cirrhotic is quite technically demanding. The reasons being that the Glisonian sheath is very thickened. You cannot do a proper hilar dissection. You can do it with experience, but for the novices, it may not be that easy. Ischemic line is often difficult to delineate. You get such a strong, fine division between the ischemic versus the non-ischemic lobe of the liver. But in a cirrhotic liver, it's sometimes very hard to delineate that line. Fibrosis leads to a difficulty in parenchymal transaction, as Dr. Govind said. So you have to be very meticulous with your dissection, and portal hypertension can lead to excessive blood loss. And all this can lead to the dreaded complication of post-resection liver failure. And even if it's not liver failure, they may land up with ascites and a higher incidence of infection. So all emphasis should be on doing a clean surgery. Meticulous surgery is the key. So this is just a continuation of the previous slide. Meticulous surgery is the key to success when you are resecting a SCC in a cirrhotic liver. All attempts should be made to minimize the blood loss. No difference has been shown with regards to the various energy devices. So with regards to energy devices, Dr. Vishal, what energy device do you use routinely? What are you comfortable with?
Well, it's very interesting that we are 5 surgeons in my hospital and all of us have different preferences. So we have Thunderbeat, harmonic, everything, yeah. So, we have QSAP, we do staple liver resections as well if they are too cirrhotic sometimes. Yeah.
So sometimes some surgeons do agree, and I partly tend to agree with that harmonic may be more useful in cirrhotic livers, but we use a combination of both harmonic
even ligature.
And ligature. Yeah. So I don't have much experience. So
5 surgeons in my hospital and all of us have different preferences. So we have.
So I totally agree that it is an individual surgeon's choice. It doesn't make any difference, and the literature supports that view. But more as important as minimizing blood loss is not leaving behind devascularized areas, because a dead area of the liver is the leads to the release of lot of inflammatory markers, the cytokines, and that can initiate the cascade for post-resection liver failure. So don't leave behind any devascularized segments, and that's why it is said that leave behind a 40% liver which is well vascularized. So that is the bottom line. And there's a lot of, I think from times immemorial, they say that you should have a low CVP, but that is not the recommendation. Now we do all our liver resections at a normal CVP, because low CVP is a double-edged sword. It may reduce your blood loss to some extent, but at the same time, hypotension is detrimental for a cirrhotic liver, and you may have renal dysfunction post liver resection if you keep a very low CVP. On the other hand, a Pringles maneuver is a more often used and a more useful maneuver, and we do use it in our cirrhotic resections because the goal is to minimize the blood loss, and Pringles maneuver really helps in that. So you can safely clamp the liver, the inflow for 15 minutes with a declamping of 5 minutes. But it is said that you should not use more than 2 or 3 clampings in a single surgery. So, but it is a very useful technique. What is your take on Pringles maneuver, Dr. Hitesh?
We try to avoid Pringles maneuver. We do it, we sling it, but we just use it only if there is a bleeding.
I totally agree that you have to avoid it, but if you are having blood loss, it's a very useful tool. So who would be, and now I'm coming towards the end of my this discussion. So after all this discussion, who would you be labeling as an ideal candidate for liver resection? Dr. Vishal. And then Dr. Hitesh, you also.
I don't think beggars are choosers, so I think we don't have an ideal patient at all. But if you want me to label someone, then I'll go with a good performance status, active, well, fit guy with ASS score of say 1 or 2, small disease where there is good amount of future liver remnant without any jargon of PVE and those considerations, and where I could do it safely with laparoscopic approach. Periphery located lesion, I don't have to worry of higher complications like bile duct injury and so on, or major blood loss is not close to inflow or outflow. Those kind of things would be ideal in my thoughts. Yeah.
Dr. Hitesh, do you agree with that?
Yeah, and thin and young patient.
Dr. Govind, do you want to add anything to that?
Yeah, I would actually. I think when you, now what the other panelists have mentioned is very important, but in our day and age where we have multiple other modalities, so the thought process for me also comes in about multifocal disease. I'm not sure if I'm helping a patient if resecting if there's multifocal disease, and sometimes you need an experienced radiologist, liver radiologist, to look at the MRI and tell you if there is hints of multifocal disease. If I feel that, I think the part of this decision, in addition to everything mentioned, you also play in is, should I ablate, should I resect, or should I transplant? So that the people with very poor liver performance, I'm likely to tell them, look, why don't you also see a transplant surgeon, because we need to think and do this. Yeah.
I think all of you have made that point, and I'm just reading that out in a single statement. If you want to ask who would be an ideal candidate, so solitary HCC, size not a major criteria, in a compensated cirrhosis without significant portal hypertension and a well vascularized adequate FLR, that would be an ideal candidate. Multifocal tumors with doubtful decompensation are better served by liver transplantation. Of course, again, the results of liver transplant would depend ultimately on what the biology of the tumor is, but multifocal tumors don't do that well on liver after liver resection unless they are localized to a very small area of the liver. Then less than ideal candidate would be a large solitary HCC that I showed in my two cases. We get usually patients at a very advanced stage. So they do well after resection. So it's not a bad idea to resect large tumors, and most of the experience comes from, again, East Asia, and they have been routinely resecting giant HCCs that is more than 10 centimeters, and we have had the same experience. And further expanding the frontier, and that's why it showed that case with portal vein tumor thrombus. It's not a routine practice, but you have to be very selective, and please mark my words, very selective, when you are choosing a patient of HCC with portal vein or bile duct tumor thrombosis. Because these patients, though, you compare with patients who don't have a portal vein tumor thrombus, they have earlier disease, a lesser disease-free survival, but these patients are not candidate for liver transplant, except for those who do downstage with SBRT and TACE versus TARE, but those numbers are very few. So resection is a very good option. You cannot ablate these large tumors. You can radiate them. You can do some TARE, but the literature also supports that if you resect these livers, they have a better outcome vis-a-vis TACE, TARE, or other non or lesser invasive modalities. And now, as was being discussed in the morning, that combining resection with other therapies like immunotherapy has further improved the results. And with our initial limited experience, we can vouch for that. And the discussion wouldn't be complete if I don't talk of minimally invasive surgery. This is the last slide. So Dr. Vishal, would you share your experience? What kind of minimally invasive surgery do you perform, and what are your criteria for choosing these patients for lap versus robotic?
Yeah, I think it's very important to have patient safety in mind when one embarks on minimally invasive or laparoscopic approach, because there is learning curve is a reality. It is there. You need to select your patients well. In your early experience, you should be selecting peripheral lesions, segment 6, segment 2, and 3, where you are more confident. Then you could slowly approach to a larger size or close to the hilum or near the outflow. But I think at every stage you need about 30 to 50 cases. So is a gradual progression of your own learning. There are two types of learning curve. One is the individual, one is the team learning curve. So your learning curve and your team's learning curve both need to slowly consolidate. Some units I'm aware have done a hand-assisted approach in the first before going on total laparoscopic approach. So that is something to be considered if you are doing a major right or left hepatectomy, because with a laparoscopic instrument, moving the liver, mobilizing could be a little bit difficult with without a hand in there in the early phase. But I think at any point of time in the learning curve, if there is bleeding, you need mentor. You need somebody to be there who is a little bit more experienced than you, who has done and who could salvage you. And I think you need to be fairly comfortable in your temperament. You can't just panic when there's bleeding, because this bleeding could be massive, pooling of blood. And if you lose your temper, you're not cool, you can't control yourself, your emotions, is going to be a downward slippery slope for your patient outcome. So you need to be fairly comfortable with intracorporeal suturing skills, with intracorporeal clamping like bulldog clamps, etc. And of course, laparoscopic Pringle maneuvering, and all these things are a slow and steady progress during your learning journey. Thank you.
So you're very right, Dr. Girish, that that this is a procedure which has a relatively longer learning curve. And just sharing our personal experience, so we are doing a lot of living donor liver transplants also. So we are very comfortable doing laparoscopic liver resection in non-cirrhotic livers. But our results or our experience with cirrhotic livers till date has not been that good when we embark on a minimally invasive liver resection in a cirrhotic liver. So it has to be done judiciously. Patient selection has to be good. Choose left lateral segment or a peripherally segment 6 tumors, which are the ideal cases in the beginning. And they should be done in a normal background of normal liver parenchyma, and then you embark upon the cirrhotic livers. However, there is plenty of data on minimally invasive surgery for HCC resections, and that clearly supports the better early outcomes and same oncological outcomes of when compared to the open surgery. So the emphasis nowadays is on minimally invasive surgery because of the obvious advantages in terms of overall reduced morbidity, lesser ascites, lesser post-op liver failure, because the trauma of excess is taken out and the patient stress is lesser surgical sites infection, and then the outcome is lesser length of stay, although there was no difference in mortality. So wherever possible and wherever the expertise is available, we should at least put or keep minimally invasive surgery, whether it's laparoscopic or robotic, in the armamentarium. And till date, no difference has been found between laparoscopic versus robotic. Both are equally good. So I would like to end here and summarize. Thank you very much, all the panelists. And I will just summarize what you just said, that diagnosis, the basic diagnostic criteria are wash in and wash out on cross-sectional imaging. PET-CT has a limited but definite indication in the workup of these patients. Ideal candidate would be, just repeating that, solitary tumor in a non-cirrhotic compensated or a compensated child source cirrhosis, without clinically significant portal hypertension and adequate well-vascularized future liver remnant. Portal vein and bile duct tumor thrombus should not be taken as a contraindication. In expert centers, these tumors should be resected because they offer the best chance at survival, especially when combined with subsequent adjuvant therapy. Meticulous surgery is the key to success. Whatever evaluation or imaging you have done, unless you can do a clean bloodless surgery, you will never have good long-term or short-term results. MIS therefore scores over open surgery in selected cases, and post-resection liver failure is best avoided because there is till date no definitive treatment for that. Thank you for your kind attention. And thank you all the panelists. Thank you very much. Thank you, Dr. Gomen.
Thank you.
One question, sir, one question. When a child is cirrhotic patient, resectable tumor, what is your cutoff level for alpha fetoprotein in these patients?
Yes, so high alpha actually cutoff is for transplant, not for resection. The patients who have high alpha fetoprotein, Dr. John Lerud very nicely showed that it is the biology, it's the number and size criteria, they are all surrogate, it's ultimately the tumor marker. So these candidates, even if like it's a solitary tumor, high AFP, they won't be candidates for transplant. While on the other hand,
resection,
you can always do resection in these cases, and depending on whatever the level, if they have, see, high AFP is usually seen, it's not a dictum, in patients who have vascular invasion. Yes. If they are secretors. In non-secretors, it would be the PIVCA. So you have to do both the tumor markers, and the high tumor markers are usually sign of aggressive disease because the tumor has already invaded the vascular system, whether it may be microscopic or macrovascular, which can be picked up. But these patients are served best by a safe liver resection, combined with other therapies. Some people have combined these with prior TACE or tear, as Dr. Sharath was talking about, but resection should be definitely considered.
The legs also we can go for.
Sorry?
If the level in the legs, 2 leg, 3
yeah,
leg.
yes. You can do a prior TACE if the patient is a good risk patient or a radioembolization, but resection followed by therapy, which are still in the trial stage, not a definite recommendation whether it's immunotherapy or, but we have added immunotherapy to these patients, especially with aggressive tumors. These would be called aggressive tumors, but resection is a very good option for them.
Thank you, sir.
Yes, Dr. Anand.
Unanticipated cirrhosis or the liver remnant doesn't, I mean, the liver looks a bit naffled like, and you didn't anticipate it before the operation was started. So how do you approach it?
So yes, that's why I mentioned that we have added staging laparoscopy. It wouldn't be called a staging, it would be more of a diagnostic laparoscopy from the standpoint of assessing the morphology of the liver. So we always put in a scope when we are anticipating, like it's an elderly patient, 60s, 70s, diabetic, but imaging is pure, like no evidence of cirrhosis, fibroscan is good, but we still put in a scope just to see. And we have abandoned many of these cases if we were planning a major resection. For small resections like a left lateral or a right posterior, we'll still go ahead. But if it's a right hepatectomy, we would just abandon the case.
Shalin, very nice discussion. I'm Dr. Pari from Coimbatore. Got a few questions. First one is, Dr. Sheth was talking about usage of ICG. We know that ICG is rampantly used in East Asia and we don't. And specifically in cases with CASH, post-chemotherapy, so in India, what do we do? We know that, the remnant looks okay, say 35 to 40%, but we don't know the quality. So what do we do practically? Is there anything we can do in India? We don't have
yes,
ICG.
I'll divide your question in two parts. One, ICG should be done. I don't know why we are not doing it. Even my center is a bit reluctant to it, but many of the oncology centers have started doing ICG. But if you're not doing ICG, then you should, what we practice now is that we leave a larger remnant if we know that this patient has undergone a chemotherapy, prior chemotherapy, and we would shift to a non-anatomical kind of resection if we know that we will know that this patient has a risk of CASH. So instead of going with a formal right hepatectomy, we would try to plan a resection for a lesser resection, try to save more parenchyma in these patients, and that is decided preoperatively itself. So we wouldn't abandon this patient if our laparoscopy shows a normal looking liver. These CASH livers usually look just like a fatty liver, or a little what they call the blue liver, the slightly bluish tinge, but I have not been able to appreciate this blue kind of thing. So they look like a fatty NFLD liver only. And we would go with a margin of safety, a larger remnant. And if the remnant, we can increase the remnant by doing a lesser resection, we'll do a lesser resection. That's what we have been practicing. And fibroscan you should always do, because if the CAP value is high, then you should be wary of planning a major resection in these patients. Fibroscan is a poor alternative to other functional tests.
So can I put it this way? We don't have a functional marker for assessing the remnant function. Is that right?
Well, there are some, it's described in literature, but practically we are not using it. No.
So we don't,
In the like real life situation, in actual practice, we don't have, but yes, in literature there is mention about various like PET CT with the other kinds of agents, not the routine FDG, where you can assess the function.
Dr. Shalin, I think due to time constraint, we can close the session.
Just Shashwat, one last question.
Small question. One is, would you offer surgery to a patient who had an HCC tumor rupture? Number one, sir. HCC tumor rupture, sir.
No. We have burnt our fingers multiple times in the past, so we now don't resect livers patients who present with a ruptured tumor, because we found on opening they invariably will have some recurrence if some time has elapsed between, because most of these ruptures would be silent ruptures. And massive rupture, you have to embolize the bleed, but if they have a history of rupture, you should not open these abdomens, or at least do a laparoscopy.
So, and if in case there's a locally advanced tumor, it's involving the diaphragm, the cava, or the bile duct, rarely, in that case, do you have a threshold till which you will offer them transplant, and then after that you'll...
It's up to it depends on your expertise, sky is the limit.
Okay, thanks, sir. Thank you.
Sorry, Dr. Hitesh.
Thank you.
Thank you very much.
Thank you, respected panelists and moderators, sir. For the next session, I would like to invite Dr. Deepak Chabra. And Dr. Deepak Chabra is a senior surgical oncologist at Lilavati and Hiranandi Hospital at Mumbai. He has a keen interest in the GI and HPV surgical oncology. He was the first clinical coordinator of Asia Pacific Neuroendocrine Tumor Registry. I request Dr. Deepak Chabra to invite our chairperson, to invite our speakers for the presentation, next presentation.
Thank you so much, Professor Kapoor and his team for having me here. And I saw in the earlier session that Professor Guido Torzilli was on the screen. Can we have him on the screen, please, the audiovisual team? Thank you. I see that Professor Guido Torzilli's mic is muted. Before I begin your introduction, on behalf of Professor V.K. Kapoor and his entire team at Jaipur, I thank you for accepting to be a part of this meeting. A quick brief on Professor Torzilli. He's leading the team of hepatobiliary surgery at the Humanitas Research Hospital and is a professor of surgery at the University of Milan. He was appointed as a fellow of the Japanese Foundation for Promotion of Cancer Research. He has a PhD at the University of Tokyo. He's a member of European Surgical Association and a fellow of American College of Surgeons. I can say that we often have lost our ways, and I think the only way we are trying to navigate into our routine lives is by using Google Maps. And I think the same situation happens when we do liver surgeries. We are often lost. Either we are losing the tumors, either we are losing the pathways. And let's see what Professor Torzilli can guide us to when it comes to navigation in liver surgeries. Over to you.
Thank you very much for the invitation. It's my real privilege, and I was interested in following the previous discussion, and I congratulate for the event that you have built. I don't know, nowadays I think I should show my recorded slides or not. Should I run by myself or because I sent the recorded presentation?
Right, I think so your screen is shared, so you can continue the way you want to present it.
So I will share my presentation.
Right.
Okay. I was expecting that you would just a moment. I have to open my presentation in this way.
Shall we play your video?
As you like. I have the presentation also, of course.
Quality would probably be better with the video, so probably we will play the video and then the chairperson will interact with you.
Okay.
Dr. Torzilli's videos, yes, please play.
Okay.
Professor Kapoor for the invitation to the second Jaipur Surgical Festival to talk about HPV oncology. The title of my talk is Validation in Liver Resection. I have nothing to disclose. Overseas policies in surgical oncology of the liver have been done numerous. I will focus on colorectal cancer liver mets for a question of time, for 15, 16 minutes. And for my talk, well, surgery in the 90s was able alone to guarantee long-term survival also to the multiple bilateral colorectal liver mets, with the estimation of around 30% of them surviving 10, 15 years. For sure, chemo has provided many advantages resulting in better prognosis. And we could say that nowadays, with the introduction of immunotherapy, the future will be more than promising. This is the case with the colorectal cancer with complete response, 100% and disappearance of tumor after immunotherapy for colorectal cancer. However, surgery remains central in the treatment, and resectability, systemic treatment, resectability, systemic surgery, nowadays also liver cancer, at the end, the target any preparation for this patient because the output could increase a lot in case of surgical perspective. In this sense, with this condition, the request of cure for this patient with tumor in the liver has increased. And nowadays, we are demanded to face with patients with multiple nodus, like in this case, scattered in many parts of the organ. So, the panel of patients that we have to treat is increased, more complex, and we have to adapt our offer. And the offer that has been disclosed in this paper published in Nature Gastroenterology was stage procedure, one stage just for liver disease, and one was paying for pouch nodular presentation, maybe also the association of anti-elevation. The stage procedure for this last disease offer not always as neurosurgery, or one is not visible, 43% of the cases. And the mortality is ranging from 3 to 6% for the two-stage and from 5 to 12 for the Alps. Coming from the school of Professor Makuchi, where I worked in Tokyo, in the 90s, I could not omit the fact that the real pioneer of the labs of surgery, the major hepatectomy safely conducted in the complex parenchymal space is for sure Professor Makuchi, with the portable individual for the major hepatectomy. And for this paper as SGO, actually JAX in 1987 was disclosing 4 hepatectomies, and it was the first paper describing complex parenchymal sparing operation or otherwise unresectable patient. The main principle that has inspired him and inspired me and my group is keep the scaffold. The parenchyma, you have to keep the scaffold. And here is in kind example 36 lingering metastasis, now cyst, and we plan to keep whatever we could. Also, this is slice of the liver, and you see the dissection planning and realize in this sense perfect inflow and outflow and the spare of the scaffold of the organ. How we would like to show you the modality we do. Take profit as an example. This is a patient with multiple myeloma colorectal events. Before and after chemo, the resectability will change significantly despite the response. And the pillars for this policy for attending this kind of surgery is based on the 3D cast. The 3D cast for the estimation of volume, detection of cluster, and compass points. The volume nowadays, even after complex dissection and the 3D difficult reconstruction, can be estimated thanks to the 3D cast relatively time. Completing by the surgeon can be estimated with quite adequate approximation. Then we can keep our patient within the range of volume, future value that we need. The cluster to make a parenchymal sparing major hepatectomy single session operation for multiple nodules in the liver, we have to be able to identify cluster. If we can identify, we can do the patient, the lesion, then we can estimate which will be the future liver variant and calculate the volume. And this is the case of this patient. And the compass point are those nodules that feature rosacea line. Then those nodules in yellow flag deep into the liver in contact with the liver vessel. And those lesions in the liver flag are describing the edge of the section line. If we comprehend all these lesions, just this lesion, you will be sure that you have included everything that should be removed. Surgical oncology, an important aspect is the introduction of the cornerstone, the concept of vascular, which is different from airline parenchyma. And we investigated how oncologically was different, and we were able to show, introducing that concept in this paper in 2009, while we were showing that the clinical one-stage ultrasound guided hepatectomy for multiple myeloma colorectal cancer, but it was proven oncologically after long experience, showing that the vascular was behaving like R0 in terms of local recurrence and implantation and resection area. This was confirmed, of course, also at the Cabal conference for in contact with the Pakistan for the lesion. In the Cabal conference for the Pakistan, we have a further option, which is not only amputation of the transplant, but also partial reconstruction. Then we could say that L1 vascular is a suitable option for surgery. This has changed everything. Everything, not only of vascular, but also the adjustment, the adaptation of the liver to the undesired guest. Here you see a tumor in the segment 8 superior, 8 4 superior, 1 paracaudal, and caudate lobe. The middle patient cannot be seen because it's infiltrated. The contact is with the right and before left hepatic vein. And in these cases, we had proven in 2006 on British Journal of Surgery, in 2010 British Journal of Surgery, that we are almost always communicating well. We have the duty to detect them, to respect them. In this case, there were at least two branches communicating the middle patient with the right hepatic vein, and the patient received a liver panel. Another attractive condition is, like in this case, tumors occupying the cover conference of the 3 main hepatic vein. There was an inferiority and communicating very can be seen at the preoperative 3D cast. They were confirmed intraoperatively. The clue of the dissection was this, where there were the two lines communicating, and this is the edge of the tumor. We were able to respect this breach, and at the end, this was the resection with all the hepatic vein cut except the inferior right hepatic vein. And the guidance, of course, the guidance is the relevant aspect. US fingers vessels disappear using the penis. US, of course, is everyone knows, radical but conservative. We can shift from vertical dissection to the dissection that you have already seen. The liver become transparent, but the finger make the liver touchable. It's important for these cases that are still open environment while the mobilization is complete, the end is behind, the liver is over behind, and then the ultrasound on the end in this, as in the schema, allowing us to depict, this is the finger, all the part of the dissection that we are figuring in our mind, that we describe the resection area, and this is always the position of the hand. The resection area is then anticipating the dissection, and the vessel are taking the role of the main actor. The vessel can be seen just below the surface, follow the vessel, and arrive to the major hepatic vein. The major hepatic vein in this case is resected, and jump to the left portal branch, resected because you confirm the communicating vein. You follow the dorsal portion of the right anterior, you have to resect it with infiltrated P8, and then you open the angle between P8 dorsal, P58 and P7, then is the right hepatic vein, the complete exposure right hepatic vein, and the end. You complete a liver panel. And this is a pure lesion. With the technology, with the fact that you can upload on the ultrasound machine, the ultrasound system, the pre-chemo imaging, then the vessel become the landmark, you can find the same area, and then you can estimate to remove the area. At this point, you will not see really the lesion. And this has allowed us to make resection also with neurons lesion disappeared 37 before based on the pre-chemo CT at MRI with only 5 lesions seen. The pre-chemo CT is uploaded on the machine. They identify the compound points, the cluster, and we estimate the dissection. The dissection is done with recognizing all the anatomical feature with the fusion imaging. And this is the liver, the resection area, and the resection at the end. And then this path allows us to reduce dramatically the number of major hepatectomy. In this series during the current conference, only 0.7% of the patients received the major hepatectomy. And then back to the initial example, this is the CT, the pre-chemo CT, and this is the results that we did with the sort of so-called Holocaust hepatectomy. Some others example, here is an oral coaster with the trajectories of the dissection of the liver, the cast that we did with exposure of all the 3 hepatic veins. This is a sliced liver. This is the cast of a patient. We identify the portion that can be filled, and at the end is perfectly diffused with in and out from, and this is the slice of liver that we preserve, achieving the critical limit of the future environment. The results, well, we did up to 83 colorectal liver mets in a single operation. Major hepatectomy is only to 1%, one-third at L1 vascular. The mortality 0.7%, and the major the post-operative warfare occurred in 5.5% more than half was made, and only 10.7% had severe. The intention were almost not significantly different from L0, L1 vascular, L1 vascular, 11. The salvageability, thanking to the fact that we can spare the scaffold, 66% of the patients in liver recurrence benefited of reduced surgery. The comparison, we were challenged by the two-stage hepatectomy, and in terms of the inclusion criteria by the Pembroke, and they had less good results than us, are zero, and on the intention to treat basis, we had better overall survival. Local recurrence-free survival was equal. This means that the two stages does not select the best patient. ALPS Italian registered 12% challenged us to compare our series with them, but they couldn't achieve the same complexity. The matching was 1 to 2. Two patients were provided by us, every patient provided by the registry. Mortality with a failure was in favor of the last stage, and also the outcome was equal, but we treat more advanced disease. And then to the end, I'm concluding, parenteral spread major hepatectomy is can offer more surgery and safer surgery, and then it was a successful path accepted by the community. This is a recent editorial on surgery in which there was the full agreement and appreciation towards our policy. Thank you very much for your attention.
Can we have Professor Torzilli on the screen? Yes, that is very well summed up. Wonderful talk. I think we will have questions from a number of audience. Can I invite the first question?
Sure. Two questions. One is, which ultrasound system do you use for the disappearing lesion, where you can load the CT or MR images on the ultrasound system? And the second question is, what is the status of the real-time navigation during liver surgery, which came about a few years ago and then disappeared?
Could you get the questions, Professor Torzili?
Yes, yes. We are using that. I'm sorry because the audio of, I mean, on the streaming was not so nice. I hope that the people outside could, outside the room, could listen at least something, because I don't know why, but there was the voice that was not clearly shown. The system that we use is Fuji, previous Hitachi, previous Aloka. But I think there are other systems that are doing the fusion imaging. At least as I know, there is the GE and the Aoka that are doing it.
So do you use the RVS system of Fuji?
I use the what do you mean for RVS?
The name of the system, the machine.
The machine is the Arietta, the latest release.
And status of the real-time navigation that for liver surgery, like during.
The problem is that the real time, if I have to address the question, is in the fusion imaging, the matching of the images is not perfect. So you have to adapt, and it works for having a reconfirmation of what you had and to match the images of the ultrasound and the CT, although the matching is not perfect. I mean, actually there should be more advancement to, and there have been a lot of attempts of putting mark on the liver and trying to superimpose the 3D image on in the so-called metaverse with the. But at the end, nowadays, at least for us, this technology is not available. For us, we still use the ultrasound and we match our expertise with the imaging. It's a great benefit for us to have the CT on the screen of the ultrasound machine, because we can match, although not simultaneously, the two images, and then having the position essentially of the lesion in relationship with the vessel. Then when we catch on the ultrasound also the vessel, the main trunk, we can recognize the area quite good, in a quite good approximation, and then do the resection. It's important then the information that we get preoperatively with the 3D cast, the identification on the 3D cast of the compound lesions. So those lesions who are limiting in the deep in relationship with the major vessel, and at the periphery, the area that you want to resect. Once they are disappeared, you can do that on the cast built on the pre-chemo CT. And then the relationship with the vessel drive you. Of course, the ultrasound is the connection between the reality and the 3D cast. Up to now, I think that technologically we should have a big, we may have a big impulse in progression in this technique once we will be able to the machine will be able to read the modification of the shape of the organ. And then in this sense, it will be a real navigation. And possibly at that time we will have people like me will disappear because there is no need to learn the ultrasound.
No, Professor, I think that statement is wrong. There is always a man behind the machine.
But it was just to diminish my role. And so it was, of course, I believe that, I hope we will have more doctors able to follow the imaging guided surgery.
Yes, we have one more question from the floor. Please.
Prof, this question is with regards to, like, many a times when you have multiple tumors and the main tumor is abutting the major vein, like a right hepatic vein or the middle hepatic vein. So in such cases, would you, during the procedure, when you are doing the parenchymal sparing, would you resect that portion of the right hepatic vein and the middle hepatic vein and reconstruct with a graft? Or you would like to shave off the tumor? Many times you can shave them off. So what would you prefer from the oncologic standpoint?
I always try to shave off, but if it is once I see that there is no possibility to make the detachment, I do the partial resection. But as for the tumor in contact with the inferior vena cava, most of the time the real infiltration is much less than the appearance at the imaging, and you can, in the vast majority, do the reconstruction by direct suture. We have done patching 2-3 times.
Absolutely true for IVC, but I'm talking about when the tumor is abutting.
Also with the hepatic vein, the same.
Yeah, so you will.
I mean, when, sorry, when the vein is normally so invaded and shrinked, in that condition, it's almost constant the presence of the communicating vein. Then you don't need to reconstruct the vein.
That was the point, yes. Thank you.
In this condition, you always see but you can see the vein already before the MRI with the hepatospecific phase with the perfusion. If it is normal, the perfused liver, there is no area with lower intensity of the contrast enhancement at the EOB phase. And in that phase also, most of the time you can see quite well the increased density of tiny vessel belonging to the hepatic vein system. And this means that there are the communicating vein that can be confirmed intraoperatively. Of course, the intraoperative confirmation is necessary because you should avoid to draw a dissection that interrupt the communicating vein. Otherwise, of course, it's a disaster. So you have to know exactly where they are running. In this way, you can foresee a resection area that permit you to keep the outflow through the communicating vein and anyway to be radical resecting the hepatic vein that is infiltrated.
Thank you.
Professor Torzilli, one last question from my side, and then we will sum up this session. What is your sequence of imaging when it comes to doing your resection with so many multiple metastases? Does it always start with a CT scan? Do you add PET CT scans to it? Where does the ultrasound come in? The routine ultrasounds then get superseded by the intraoperative ultrasounds. How do you sequence the events, and how many number of scans does your patient go through when you're doing a liver resectional surgery of this sort?
We used to do for the staging, the chest and abdominal CT, the MRI with EOB, and the PET scan also. And it depends. The PET scan, it depends. If the patient has had the PET scan before chemo, yes. But if not, it's useless. Luckily, and should be recommended always to the oncologist to do the MRI also before chemo, because it's the most sensitive and specific to identify the tiny lesion, while the CT provide better anatomical details. And then for such an operation, you have to have the best imaging that you could have before, because otherwise the risk of missing something is not minimal.
Thank you so much for being a part of this meeting. I think if we have no more questions, thank you for being on time, being so crisp with your presentations, and we had a wonderful audience interaction for this session. Thank you once again on behalf of the Jaipur Surgical Festival. I hand over the mic to the next speaker. Thank you.
Thank you very much.
Thank you, sir, for a nice discussion. Thank you, our chairperson and speaker. For the next session, I would like to invite Dr. Hitesh Chawda as a chairperson. Dr. Hitesh Chawda is a consultant surgical gastroenterologist and hepatobiliary liver transplant surgeon, director department of GI surgery and chief division of the HPV surgery and liver transplant at Sterling Hospital, Ahmedabad. And our online chairperson is Dr. William Lancaster. Basically, he is a HPV surgeon at the South Carolina. I request a chairperson to invite our speaker for the next session.
It's my privilege to invite Dr. Daniel for the presentation on management of colorectal liver metastasis.
Can I start? Yes? Thank you, Prof. Kapoor, for this great invitation. It's always a pleasure to be here in India and to share experience. I have two challenges. The first one is to talk after all these great talks, and the second challenge is to talk before the lunch. So I am in between, and I will try to cover my topic. So as you can see here, the time scale and things have changed in terms of management, medical management, chemotherapy for liver mets from colorectal cancer, and in terms of what I could say, all the strategies that are now available for these patients with colorectal liver metastasis. The first point I want to stress is the impact of the genetics in the management of these patients. I'll give you just one example. The mutation of the BRAF is bad. As you can see, there is no survival at 5 years following resection for BRAF mutation, particularly this subgroup of D60 something. And second, we have a very aggressive relapse after surgery when patients are mutated BRAF. So BRAF is bad overall, but sometimes it's not so bad. Some patients with mutation BRAF and MSI plus microsatellite, they show that they have a very good response to immunotherapy with a significant response to chemotherapy, and sometimes even no need for resection, because when you resect these patients, there is no more tumor. The second point I want to stress with you is the agreement about the surgical strategy. This slide shows the main results of an international survey, 43 HPV experts, 10 clinical cases of liver mets from colorectal cancer, and the cases were simple to complex. And you see that for low complexity cases, there is no agreement. The agreement is measured by this so-called kappa index. There is no agreement between experts about the approach for low complexity cases between open and minimal invasive. But more importantly, there is no agreement, almost no agreement, for complex cases about so important points such as portal vein embolization, preoperative volumetry, the type of surgery that would be performed, and the type of resection. In other terms, there is considerable inconsistencies today in the decision of the strategy. It's confusing for surgeons and for patients, and we need still a high level consensus. I will focus on two questions in the patients with colorectal liver metastasis. Is it resectable? And when it is synchronous or metachronous, what we should do mainly in these patients. So first, the definition of resectability. MRI, it was said already by Guido Torzilli just before, is now part of the evaluation of these patients. You see on the CT scan, no lesion, MRI, a tiny lesion. Second, What counts, and it was discussed today, what counts is not what you remove, but what you leave in place after the liver surgery, and all these volumetric assessments are now needed. The third point is that the resectability should be decided by a liver surgeon, and the liver surgeon should attend the multidisciplinary meeting to tell if a liver tumor or liver mets are resectable or not. And second, we don't know yet the place of portal vein flow or portal pressure modulation that we could use in the limit cases of future remnant liver. Synchronous and initially unresectable. This is the objective, to shrink the tumor and to shift them from unresectable to resectable. We know now that there is a clear relationship between the response rate to chemotherapy and the resection rate of the liver mets, particularly for the patient with liver-only liver mets from colorectal cancer. So the message is clear. We have to give upfront the maximal induction chemotherapy, and usually a triplet is better than a doublet. When it is initially unresectable and switched to resectable by chemotherapy, the results are very promising. And you have here one example that for finally resected patients, 35 survival at 5 years. The same from our group in 2004. For patients switched from non-resectable to resectable by chemotherapy, 5-year survival, 33%. So the prognosis in patients switched to resection is quite comparable, quite the same to patients that were upfront resectable. The fourth point, what about the reverse strategy? This is the results of our liver met survey, more than 7,000 patients with liver mets from colorectal cancer. You see that when we do liver first as compared to primary first, not big difference. Liver first versus simultaneous resection, no big difference. But the difference appears for patients with extended disease. So when the liver disease is extended, probably the liver first is the best approach for this. I will skip this for due to time. Very important question. When a patient with unresectable liver mets remain unresectable despite chemotherapy, should we resect the primary? There was a big debate about this point. Clearly, the answer is probably no. This is a Japanese study showing that patients with unresectable liver mets and treated with chemotherapy alone versus primary resection and chemotherapy, no difference. And even worse, from this study from Holland, they showed that for patients treated by primary resection and chemotherapy versus chemotherapy alone, the results are much worse for the patients having the primary resection. So unresectable liver mets, probably we should not resect the primary tumor. Now, synchronous and upfront resectable liver mets, overall, all experts agree we should give chemotherapy in these patients. It is also confirmed by the different societies. Only one specific point is the metachronous lesion, unique single lesion, below 5 centimeters. There is no difference, sorry for the slide is cut here, no difference between pre-op versus no pre-op chemotherapy for this specific situation. But there is an improved survival if you do chemotherapy to this patient after upfront resection. Now I want to challenge some old dogmas. The first one is the R1 resection by necessity for colorectal liver mets. It was already tackled by Guido before me. Clearly, overall survival after R0 versus R1 by necessity due to contact or to major vessels, no difference in terms of overall survival, no difference in terms of disease-free survival. Second, no surgery if progression while on chemotherapy. This was a dogma, and we have participated to this dogma, showing that patients with progression under chemotherapy had a terrible prognosis after resection and probably should not be resected. However, this dogma was tackled by a multi-centric study that identified 3 prognostic factors for this patient under progression despite chemotherapy: the number of metastases, the size of the largest tumor, and the level of CEA, the tumor markers. When there is no one of these 3 factors, or only one, except the CEA, resection can be, we we can proceed for resection. You see the 5-year survival are acceptable for the first 2 lines, almost acceptable for the 3rd line. But when the CEA is elevated, mainly the results at 5 years are really not good, and this patient, again, should not be resected. The vanishing lesion, the missing lesion on CT after chemo, it was shown that in these patients, even when the tumor disappeared, there was remaining microscopic disease in 83% of cases. With the MRI and hepatospecific contrast, things have changed. The positive predictive value in MRI of a missing lesion is almost 80%. So when there is no more lesion visible on this type of MRI, probably there is no more tumor remnant. Recurrence is part of the game. This is a paper we published a long time ago, showing that patients after 1 hepatectomy, more than 1 hepatectomy, when we do rehepatectomy for recurrence, they have a much better survival as compared to patients with only 1 hepatectomy that could not be resected for recurrence later. This is very different as compared to 96. Henri Bismuth showed this, that survival after repeat hepatectomy was 2% at 5 years in the 90s. This is clearly due to the progress of chemotherapy. And second, the need for repeat hepatectomy should be anticipated mainly by parenchyma sparing strategies at the first hepatectomy. We go towards, of course, laparoscopic approach. You see this prospective study showing that with cilioscopy, with the laparoscopy, morbidity was decreased and the margin were absolutely comparable. The only limit of this randomized study is that the median number of nodules was only 1.5, which is quite rare in our patients today. In fact, the literature opposes different techniques, and I will give you some examples. First, ALPS versus 2-stage hepatectomy. This is the first randomized study published in 2018, showing that the primary endpoint of this study was the resection rate, and the resection rate was significantly higher in the ALPS as versus 2-stage hepatectomy, but this was obvious. If you spare the time that you have for the 2-stage for dropout due to progression, of course, the resection rate is higher after ALPS, and the 90-day mortality was the same. The same study gave the long-term results and telling ALPS improved survival compared to 2-stage hepatectomy in patients with liver mets from colorectal cancer. No difference for the failure of strategy, and survival better for the ALPS group. But as I say, the evil is in the details. If you read in details this paper, and this is a communication we sent about this paper, first, there is no place for bioembolization in this study. Second, there is no data on repeat hepatectomy for liver recurrence. Third, if you remove only 1 patient from the ALPS group and you put it in the 2-stage group, you lose the significativity of the statistics, showing that the p-value is of very low weight. And fourth, the gain in survival was 5 months, which can be debated in this situation. So at least ALPS versus 2-stage, the jury is still out. Oh, this is about the deprivation. It was told already today. But we have this paper in press, probably it will come in 2033, showing that simultaneous hepatic and portal vein embolization is better than portal embolization or ALPS for hypertrophy. And these are the 3 main messages: better hypertrophy with bioembolization, portal vein embolization and B-embolization had a lower morbidity rates as compared to ALPS, after surgery, of course, of these patients, and the bioembolization showed a lower mortality rate compared to the 2 other techniques. So sometimes also talk about the mini-invasive surgery. The maxi-invasive is worse, and we have, during the last 20 years, developed this technique of vascular exclusion with hypothermic perfusion and the veno-venous bypass that we use in liver transplant. In the subgroup of patients of colorectal liver metastasis, so far 33 cases can be analyzed, and the survival in these cases with large resection, resection on the remaining size, resection of the vena cava and replacement and reimplantation of the remaining vein, it is possible to have 30% overall survival, it's not disease-free survival, in this type of patient, which is better than any other management. A small part for splice for liver transplant. When we compare liver transplant to liver resection for colorectal liver metastasis, you see that overall survival and disease-free survival was always significantly better for liver transplant as compared to liver resection. For a specific subgroup of patients with liver mets that are resectable, sometimes it is better to do liver transplant. I want to finish with this. The discrepancy between the different models for prognostic of liver mets from colorectal cancer. This is the time scale. And here, the different progress that were performed. It is very difficult today to evaluate the prognosis of a patient with liver mets when you don't take into account the progress that appeared after the development of these models. So this is not interesting, but this is an example of what we could do with the models. This is a paper I asked for my young colleagues to do about what is the value of prognostic system in colorectal liver metastasis in the current era of multimodal modality. This was the proof, and the proof in the title was written utility. When I read the proof, I said we should change the title because in fact all these models are futile on an individual case basis. So I changed the proof and I asked the editor to put futility instead of utility. And the editor called me and he told me, it's not very nice to tell to all these colleagues that have been working for many years to develop these models that they are futile. So we had to change the title, and the final title was Utility or Futility of these models, and I accepted to change it. I want you to keep the open mind to evaluate these patients on an individual basis and to resist to the dictature of RCT and or any other guidelines. Thank you very much.
Thank you, Professor Daniel. Dr. Lancaster is there. Can we hear you on the screen?
Yes, can hear you.
Good afternoon, sir. Any questions from the audience? So, I have a question for you, sir. So, you said in synchronous resectable metastasis, you will give chemo first rather than resecting. So, how many cycles of chemotherapy? Is there any defined guidelines? And when we stop and resect?
So first, I think it's not me, it's the current guidelines and the current consensus overall is in favor of chemotherapy before surgery in synchronous liver metastasis, even if they are upfront resectable. We are talking about this.
Yes,
okay?
yes.
Now the number of courses, usually we attend all multidisciplinary meetings about these patients, and we evaluate these patients every 3 courses. Usually after 6 courses of chemo, if the patient becomes resectable, we go for surgery before some lesion becomes missing. We try to reach the point where the patients are resectable and before some lesions become missing. So we decide on a case-by-case basis. But usually after 4-6 cases of chemo, if the patient becomes resectable, we go for resection.
Professor Zule, can I have?
Yes, Dr. Shalin. Yeah.
So, is the chemotherapy targeted towards the liver or towards the primary rectal primary? So the question is, what is the regime that you are using, the chemotherapy regime, and are you combining it with radiotherapy for the primary?
I'm sorry, I did not understand very well your question.
So what is the chemotherapy regime that you are using for such kinds of cases where you have resectable synchronous mets?
Okay. For synchronous and resectable upfront.
Resectable.
Resectable. First of all, I am not oncologist, so I don't, maybe I will say stupid things if I tell you something. So I don't use these drugs, but as I told you, now the genetics is important, and I think the oncologists now take this into account, and usually they give the strongest chemo as possible upfront. They don't escalate in terms of aggressivity of chemotherapy. So usually it's a triplet. It's FOLFOXIRI, usually as the first regimen.
And do you combine the radiotherapy for the primary rectal tumor?
To resect the primary before?
No, my question is, do you combine radiotherapy, radiation therapy?
For rectal cancer?
Yeah.
Yes, for rectal cancer, we do the radiochemotherapy. And in some cases, we have started to do what we call the intermediate strategy. We do radiochemotherapy for the rectum, as you have to wait usually, and this delay has been increased to 8 to 11 weeks sometimes. So in between this delay, we do the liver resection if it's a small liver resection, and then we go to the rectum.
Yes. Time.
But we don't do the rectum in my unit. We send the patient to a specialized unit.
Fantastic talk, Professor. I want to ask you about your thoughts about the future of liver transplantation for many of such cases where you are doing resection right now. Do you think, I know there are a lot of studies going on, including in France. So where do you think is the role of liver transplantation going to be in such multiple liver metastases, colorectal liver metastases?
So we are talking about liver only, of course. Liver only metastasis. There is no extrahepatic disease. We are talking about these patients after the primary has been treated and resected. And we are talking about liver only liver metastasis. There are two situations. The first situation is resectable at the price of a heroic surgery with vascular exclusion, hypothermic perfusion, vena cava replacement, portal vein reconstruction, arterial reconstruction, and so on. And the second situation is patients that are absolutely not resectable. Those patients who are resectable, we go for resection first. If we consider that they are resectable, even if the risk of postoperative mortality is almost 20% in this patient, which is 10 times the mortality that you would accept, more than 10 times for usual liver resection. For patients we have that have definitely are not resectable, in these patients, we consider transplantation like the Oslo group, the same. We need to have a tumor burden, good response to chemotherapy, and good response also in terms of tumor markers. This is very important. And then in these patients, we can go for liver transplant. In my unit, we have finished a prospective randomized study about this attitude, and the results are being deciphered, so it's not yet published. But we have still continued to transplant these patients with livers that have not been accepted by other units, so we can give it to anyone. With the domino transplant, with the liver from patients with familial amyloid polyneuropathy, and in some cases with living donors, very selected cases.
Living donor transplant, if there is a donor, would you consider living donor transplant for such patients?
Yes, we consider it in specific conditions, very young patients, rare blood group that will not get a liver, and when the donor wants to participate, yes, we open the door for these cases, yes.
Thank you.
Dr. Chabra. Thank you, Professor. The jury is still out for the ALPS, I do understand, but in your comparative analysis within portal vein embolization versus portal vein embolization plus the hepatic vein embolization, has there been difference in the timelines when you have to wait for performing your liver surgeries?
Yes. Up front, I will tell you that this argument of delay to surgery and the risk of delaying surgery, I think can be reversed. Delay is also a way to select the best patients.
Correct.
If your patients after 4 weeks presents a progression of the disease, it means that probably should not be operated.
Yes, so the biology is important.
This time delay argument can be reversed. The second is that when you do bioembolization upfront, because you save some time, it's a very easy procedure. It's so easy that I do it myself. I am not a radiologist, but I do it to my patients personally. So it's a very easy procedure. And I think when you see the morbidity and mortality of this approach with the resection as compared to ALPS, I think there is no way to compare. I am not against ALPS. I think there is a place for ALPS. But the place that has been given to ALPS is too large today. I mean, there is probably a publication bias, but to me, there is too much ALPS performed.
So still for you with bioembolization, 4 weeks is still the criteria. It doesn't decrease the time from 4 weeks to less.
Probably it can be decreased, even with portal vein embolization. You know that with portal vein embolization on a healthy liver, we had to wait 4 weeks, but it is clear now that after 2 weeks, you can operate the patients.
Thank you.
Dr. William Lancaster, can you unmute yourself, please?
Yes, sir.
You are still not audible.
Can you hear me now?
Yes, yes. Your comments, please, sir.
No, I thought it's a wonderful talk, and thank you very much for that review, and it gives us a good idea of where we need to go and what we need to learn. My question, one of the things that I was thinking about is, what is your approach in terms of your surgical approach for patients with synchronous disease? So when the colon tumor is in situ and you have synchronous liver disease, do you still approach that liver first, or do you do a combined operation with your colorectal surgeon? I'm interested to know your approach there.
Yeah. So first of all, it depends on the status of the primary. When the primary is symptomatic, we have to treat the symptoms. Bleeding usually resolves with chemotherapy. Obstruction, occlusion has to be surgically treated by stoma or resection. And the third situation is, yes, occlusion, bleeding. These are the two main situations. But apart from this situation, we do not combine major surgery with colorectal surgery. We don't combine. So if the liver is the predominant disease, we do the liver first, after chemotherapy. If the rectum or the colon is the more threatening disease in the patient, we go for the GI first, and then we do the liver second. So in practice, no combined surgery when it is major hepatic surgery, particularly with the left colon and more with the rectum. No synchronous surgery, no combined surgery. And we go, and the surgery first is dedicated to the most threatening disease. Usually the liver disease is most threatening, and we do liver first, particularly if the liver disease is extended. I'm not sure I answered your question.
Yes, thank you, and thank you very much for this wonderful talk. I've enjoyed it immensely.
Thank you.
Thank you, Professor Daniel. It was a wonderful presentation. We really enjoyed. Thank you very much.
Thank you.
Thank you, Chairperson and the Speaker. Now I request all of you for lunch. We will start our session at 2 p.m.
No, we have good surgeons that are capable of handling it. We have to it's less than 2 kilometers, so that we come if we need to do it separately. Yes, yes, of course. Maybe I can Yeah, I'm sorry if I did not.
हेलो 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 पढ़ो हेलो हेलो चेक 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 थोड़ा बेस भी कम करो हेलो हेलो हेलो
panel discussion on non-HCC space occupying lesion in liver. For moderating this session, I would like to invite Dr. Ravi Mohanka. Dr. Ravi Mohanka is a senior liver transplant surgeon, and he has performed more than 1,500 liver transplants. Currently, he is working as a senior surgeon at Reliance Hospital, Mumbai. Over to you.
Thank you very much for the invitation, and very happy to be in Jaipur. Request our panelists to take this dais. Dr. Giriraj Bora. He's Chief of Liver Transplant and a Senior Consultant GI and HPB Surgeon at Artemis Hospital. Dr. Jay Chaudhary, he's a radiologist, Professor of Department of Radiology at this hospital in Jaipur. Dr. Shalin Agarwal, he's a Senior Consultant Transplant and HPB Surgeon at Max Center for Liver and Biliary Sciences. And we have two panelists online. Dr. K.R. Prasad, he's Consultant Hepatobiliary and Transplant Surgeon and Clinical Director for Surgery and Transplantation at NHS System in UK. And Dr. Subhash Gupta, who is the Chairman of Max Center for Liver and Biliary Sciences in New Delhi. So invite all our panelists. So we'll start off, and the pattern of this panel discussion will be that we'll have representative cases of different non-HCC SOLs that we're going to discuss, and the radiological description by Dr. Jai Prasad, followed by a clinical discussion by all the surgeons. So typically what we'll do is we'll just lay out the standard guidelines that are published for managing those lesions, but then any pearls of wisdom or clinical inputs, surgical input from any of the panelists will be very welcome. So when we deal with a liver SOL, there are a few key things that we are trying to figure out when we do imaging on them. Whether they're cystic or solid, whether they're single or multiple, and most importantly, are they benign or malignant? What are we dealing with? Because then the treatment obviously is highly variable. We're also now faced with a lot of incidentalomas because of the increase in imaging that is being used, and very often these are benign, asymptomatic, but they do cause a lot of anxiety. So based on what clinical background you have, such as risk factors for various diseases, you could make a guess of what you're dealing with to begin with, but then the standard way of figuring out what you're dealing with is an imaging. And this is the armamentarium that we have available with us. So on the left side is the all types of imaging, which all of us are familiar with. And then tumor markers. Sometimes we have to do an FNAC for indeterminate lesion when the imaging is not characteristic. Rarely you have to do a biopsy, but then one of the very interesting uses of intraoperative ultrasound, which we saw in the previous talk, is for localizing the lesion and guiding the lesion. So the goals of our investigations that we do is to not only detect the lesion, but to characterize it, also characterize the background liver, whether it's normal or cirrhotic, and then the spread within the liver and outside the liver. So we'll start off with the first case. So this is a 45-year-old lady with vague upper abdominal pain. Blood investigations essentially were normal, and this was the lesion that was seen on the CT. Request Dr. Jay to comment on this.
Good afternoon, everyone. Here we can see this is a multiphasic.
Can we get the slide back? Yes, thank you.
Okay, this is a triphasic CT scan. On plane scan, we can see a faint hypotense lesion. And then the second image is of arterial phase scan, and we can see intense heterogeneous spoke wheel type of enhancement in the lesion. The lesion is very well marginated. And then in the portal venous phase scan, we can see that lesion does not show washout, and we can see a central scar within the lesion. And then on equilibrium or delayed scan also, the lesion does not show washout. and we can see a central scar. So these findings are suggestive of FNH, focal nodular hyperplasia.
Great. So this is a very typical lesion for FNH, but the important point that we made here is that for characterizing any liver lesion, we need a good quality triphasic scan, which has all the phases clearly delineated from each other, so that we can, without doing a biopsy, we should be able to characterize them. Now, here are some of the, another case that, would you like to describe the imaging findings on this one before we go to management?
This is also a triphasic CT scan. We can see multiple lesions here in both lobes. The largest one is in the right lobe involving the segments 8 and 7. Here also we can see a central scar and the enhancement, and the vessels are displaced. The lesions are showing intense arterial phase enhancement. We can note the enhancement of the central scar on the delayed phase images. That is the third image.
Yeah. Wonderful. So, this question is open to all the surgeons. So, although these are the standard guidelines which we'll read out, but Dr. Shaleen, what is your take on investigating or managing a case with diagnosed as FNH?
So now that the previous slides, we saw that this is a classical case of FNH with all the features of a central scar, no washout and hyper enhancement of the scar. So there is no diagnostic dilemma here. Okay. And since I presume that this patient was asymptomatic, it was an incidentally detected lesion. Yeah. So I don't see any reason that we should be intervening in any form. Maybe we can just follow up for the satisfaction of the patient with the imaging every 6 months. Maybe it's a CT scan or an MRI, but I don't see any indication for a surgical intervention.
Wonderful. Dr. Bora, any differences of opinion?
Ravi, I agree with Dr. Shaleen that a typical FNS even doesn't need surveillance, in fact.
Great.
But EASL's guideline recommend that if you are 100% sure on imaging that it's an FNH, there is no need to do any follow-up scan, MRI or CT scan, because the CT picture or MR picture is quite suggestive and diagnostic of FNH in vast majority of patients.
Dr. Gupta, would you have any concerns about fibrolamellar HCC in such a case?
Very good question. Actually, the more older I get, the less confident I get in all the imaging findings. And particularly when they, nowadays what happens is patients come to with a lot of reports from elsewhere and they're reported somewhere. And we've seen so many times that some sequence is missing. In fact, today morning in our tumor board, we're discussing cases where they confirmed HCC and the histopathologist says there's no HCC. So I would not follow what has been recommended elsewhere that, FNH, you forget about it. I would definitely follow closely until it's proven conclusively that it is nothing else except FNH, only then. And that would be, I think the interval change is the best clinical tool that in medicine than any other modality.
Dr. Prasad, in any situation, would you like to resect this lesion?
No, never. And in a very early in our experience, 20 years back, occasional resection we did for vague symptoms. And I always say this, you may take the FNH out of the liver, but not out of the mind. So you'd never solve the symptoms. So we wouldn't resect, and we would discharge, reassure the patient and discharge them from follow-up. The only FNH we would ever be worried is an FNH in a male.
And also an FNH which is, sometimes on the porta, causing compression, splays out the blood vessels.
Right, sure. Great. So we go to the next lesion. Dr. Jay again, I need your comment on what you see here.
Okay, this is a triphasic MRI image of the upper abdomen. The first one, T1 weighted, is a non-contrast image. T1 weighted fat suppressed. We can see a well-defined hyperintense lesion. The lesion is hyperintense on T1 in non-contrast images. It suggests that there is some amount of hemorrhage in the lesion. Okay. Then on arterial phase scan, we can see the lesion is showing intense heterogeneous contrast enhancement. And on the portal venous phase, the lesion does not show washout as compared the lesion does not show washout, but if we compare it from the arterial phase, there is some amount of washout, but that washout is, the lesion is not hypointense to the liver parenchyma on the portal venous phase. So this suggests that it is a benign lesion and most likely an adenoma. We can see a pseudocapsule also on the delayed images. If it would have been an HCC, then it would have been hypointense to the liver parenchyma on the portal venous phase images.
Wonderful. Yeah. So again, we'll just project the standard guidelines. But my question is to Dr. Shaleen again first. So how often are you worried about adenoma or confused between adenoma and FNH on imaging? And do you have a preference for CT versus MRI on this?
So the second question first, definitely we will do an MRI. MRI is a better imaging. I am a surgeon, but we feel now more comfortable with doing MRI for liver lesions. It describes the morphological characteristics of the lesion much better and doesn't lead to diagnostic dilemmas. Like in this case, as Dr. Jay has nicely described, that it fits into the picture of an adenoma, which may not have been possible had it been a smaller lesion. Then you may have to resort to MRI after a CT. So it's better to do it.
So Dr. Bora, so what would be your treatment plan for this patient?
So like for adenoma, I mean, treatment depends on the gender of the patient as well as the size of the patient. Like in a male patient, adenoma of any size, I mean, should in a female, I mean, lesion which is either equal to or less than 5 centimeter, the standard guidelines say that, I mean, you follow up the lesion, maybe, I mean, you can withdraw OCPs if the patient is taking OCPs and then some lifestyle modifications. But yes, if the lesion is, I mean, more than 5 centimeter in size, symptomatic, showing hemorrhage, or in that case, possibly there is some sort of intervention, maybe in the form of, I mean, ablation or preferably some surgical intervention.
Sure. Dr. Gupta, how worried would you be about this adenoma, transforming into a tumor, like a malignant?
I think, I don't know the exact percentage, but adenomas are known, everyone agrees that they're pre-malignant. But I saw in one of, as I was going through a slide, it said that if it's less than 5 centimeters, you could wait and watch. I'm not sure whether, where that recommendation has come from.
So these are the standard ACG guidelines, American College of Gastroenterology. But there are other guidelines which differ from these. So I agree with you on that. Dr. Prasad, would you agree with the follow-up guidelines laid down by the ACG, or would you have a different follow-up protocol?
So it came as a surprise to me, the ACG guidelines. So we increasingly see young women who have who are overweight in their 30s, incidentally detected multiple adenomas. This is an increasing problem we see in our clinic and in the MDT. So it's hard to keep following them up at 6 to 12 monthly intervals, and most of them are actually inflammatory or steatotic adenomas, and the risk of malignancy has always been overstated. That's my view, and I think the literature also supports that. And the occasional one which bleeds in this setting with multiple adenomas, we never seen a fatality from an adenoma causing rupturing and bleeding to that extent. So we follow them up for 2 years, and if it's all stable, we tend to give them, after the lifestyle advice on pill, we tend to discharge them with that advice that you develop a sudden pain, you attend and you attend the A&E department and let people know you have adenomas in the liver. So that's one group, and then the solitary adenomas. I think it's the guidelines here. What's there on the slide are what we follow. I think solitary adenomas we treat a bit more seriously and resect them if they cross the threshold.
Great, thank you. So, although there are clinical pointers towards which lesion, it could be FNH or adenoma, this has been a long-standing confusion and debate. But then the character of the tissues that are present within those two tumors, they help you identify them much better. And depending on what tissue you are looking at, If you're looking at the scar, then probably a CT will guide you better. But on the other hand, if you're looking at the hemorrhage and fat, then MR may be better. So any preference, Dr. Jay, for these two, differentiating these two lesions?
So for differentiating these two entities, definitely MR is better. But MRI has a problem if the patient may be claustrophobic, the patient may not hold the breath. Otherwise, MRI is much better. We can do many sequences. We can do in phase and out phase sequences, by which we can know whether the lesion contains microscopic fat or not. That is very important, especially to differentiate FNH and adenomas.
So that was the message that we wanted to give, is that to differentiate the two, MR is better. Now we come to a common lesion that we all see. So this is it's more common in women, generally small, but if they're more than 10 centimeters, they're termed as giant. And they have very typical findings on imaging, such as this. Dr. Jay again.
Okay, this is very typical of hemangioma. This is also a multiphasic CT scan. The first image is a non-contrast image. We can see a very well-defined hypodense lesion. The lesion on arterial phase and the rest of images, it shows peripheral nodular discontinuous type of enhancement. This type of discontinuous rim enhancement is very typical of a hemangioma. And on the delayed phase, we can see that the lesion is almost isodense to the liver parenchyma, but we should not compare the lesion to the liver parenchyma. We should always compare an enhancement of the hemangioma to the blood pool. It follows the blood pool.
So there is centripetal filling.
Yeah.
So, Dr. Shaleen, so this is another, MR of hemangioma, which is again showing the same typical characteristics, the central pool, the centripetal filling, and everything. So, although these are the guidelines, so Dr. Shaleen, what would be your management plan for either of these two lesions? One of them was a smaller one and the other one was a giant one and exophytic, quite exophytic. So, actually, you take one and Dr. Bora take one.
So, the first one I would follow up, and not even follow up, we know it's a hemangioma, though they are known to increase in size. That's why I said we can follow up with a simple ultrasound once we have made the diagnosis, maybe yearly ultrasound.
Sure.
And second one, I would prefer to resect, although it's easier said than done, these hemangiomas. But since it's Dr. Bora.
So, Dr. Bora, what would you do? That's a giant hemangioma which is exophytic and it's like almost occupying the entire left lateral segment.
So, yes, being a surgeon, for a giant hemangioma, I will be, inclined to resect. But yes, in literature nowadays, there are some reports. People are dealing with this hemangioma by means of angioembolization. In fact, I was reading a series of 836 patients, and they had almost, zero, close to 0% zero morbidity. In fact, one of the series. So maybe somebody who is reluctant to undergo, surgical procedure, a giant hemangioma close to surface, angioembolization can be an option. But yes, depending upon, the location of the lesion is that it's into left lateral segment. I can easily do even a minimal invasive, left lateral hepatectomy, and can do an enucleation.
External beam radiotherapy has been described
with partial success.
So, Dr. Gupta, what do you think about angioembolization? Does it work?
Yeah. It's a very favorite topic of mine. It does work, but you have to embolize not only with, you have to embolize with lipoidal plus bleomycin. Now, the question is that bleomycin is an anti-cancer medicine, and sometimes we have difficulty in, getting consent and all for giving it. But if you do it without bleomycin, it doesn't work.
So, Dr. Prasad, in what proportion of hemangiomas, let's say, they meet the typical thing of being giant and exophytic, would you not resect these patients?
Almost 100%.
I agree with that.
I wouldn't operate on any of the hemangiomas unless an occasional one with symptoms, and that too a very occasional one.
So that's where most of the evidence is pointing nowadays, is that you can leave behind almost all hemangiomas. Very rarely do you need to actually, and even the symptoms are so subjective that even if you do operate on them, they persist, the symptoms may persist, and then you're like, stuck. So anyway, so that is the controversy regarding the hemangiomas. Now this is another lesion. I didn't get the clinical details on this patient, but Dr. Jay, will you describe this lesion?
This is a contrast enhanced MRI. We can see a lesion in the segment 5 of liver, a very well-defined lesion, which is showing heterogeneous enhancement. And this was a mass-forming intrahepatic cholangiocarcinoma.
Correct. So this is, obviously like a very attractive tumor for a surgeon. So, Dr. Shaleen, what would you offer to this patient? This is an intrahepatic cholangio, which is probably around 2 centimeters in size. So, what would you offer to this patient?
So definitely I would like to resect, and since the location is quite peripheral, so this tumor should be amenable to minimally invasive approach of resection. But yes, in cholangioCS, I would like to look for the lymph nodes also, because it's recommended that you should do a lymphadenectomy along with the primary resection in a cholangiocarcinoma.
So, in this case, there were no lymph nodes positive.
So it would be very good for it's a good case for a minimally invasive approach.
Sure. And Dr. Bora, what happened is that you started, did a diagnostic lab on this patient with the aim of resection, and you found that there was some cirrhosis. What would you do?
So, in this particular patient, you just require, you can just do a non-anatomical resection also. Sure. So, cirrhosis child A is not going to change, right. Outcome, in any way, in this particular patient. Sure. But even for a patient, if it's a left lateral hepatectomy, I won't hesitate. I will go ahead with, my resection plan. Sure. And when we talk about a lesion being in segment 4, if I can save the MHV, I'll not hesitate to resect. In fact, even in that case, I will go ahead and resect the lesion surgically.
So, Dr. Gupta, so there is some evidence that intrahepatic cholangio mass-forming lesions that with cirrhosis, if they're up to 2 centimeters in size, even the outcomes of transplants are actually very good. So, would you offer a transplant to this patient instead of resection?
I think at the current moment, the thinking is, even if there is, it never truly, at least for the hemangio, the cholangio HCC sort of, you often find different components in the same. And at the current moment, I think you would follow the same guidelines for intrahepatic cholangiocarcinomas as it is for HCC with cirrhosis. But in a cirrhosis, if the liver function is disturbed and and you don't want to, if it's a cholangiocarcinoma, you won't offer transplant. I think that would be wrong.
Dr. Prasad, would you offer, would you do a biopsy in this or any other cholangiocarcinoma patient?
The biopsy is, we would do biopsy in someone with background chronic liver disease, where you are not sure about the nature of the lesion. Is it a HCC or an intrahepatic cholangio, the LRMs? We do biopsy. And we have a new service evaluation within UK, transplant for intrahepatic cholangiocarcinomas, which also mandate a preoperative diagnosis with the biopsy. And obviously, in non-cirrhotics, if you are not going to offer resection, you would offer biopsy. So these are the situations we would do biopsy.
So another quick question for all the panelists. Any role for any of the loco-regional therapies like TARE or TACE or RFA? Anybody can answer that.
So since in this particular lesion was peripherally located, easily resectable, so I think a resectional biopsy would be the best approach. I wouldn't go for ablation. Yes, if it's the same, was a deeply centrally located tumor, a small lesion, we can do that like biopsy and ablation.
Right. Dr. Gupta wants to say something.
I think that, nowadays we keep forgetting, but TARE is curative for single lesions if you don't want to do surgery.
Wonderful. Yep. So this is the current guidelines updated last year, and there is an increasing role for adjuvant chemotherapy as well in these patients. And appropriately discussed by both Dr. Gupta and Dr. Prasad, there is a role for liver transplant in select cases up to 2 centimeters in size, and there is a role for loco-regional therapies as well for larger lesions. So the protocols for intrahepatic cholangios are definitely changing. So there are two very naughty lesions that we want Dr. Jay to talk about. One is fat sparing. So because they can confuse you between this and real lesions.
Okay, we can call this lesion as focal fat sparing also, and focal fatty infiltration also. Fatty infiltration is in segment 4, 2 and 3 as we can see here. These are in phase and out of phase images. On the in phase images, we can see the lesion is not very clearly seen, and out of phase images, the dark area that we can see, the lesion is hypointense to the normal liver parenchyma. So it indicates that there is focal fat in the lesion. And the vessels are not displaced, there is no mass effect, there is no other findings. All these ancillary findings, when we combine them, we know that it is a focal fatty infiltration.
Wonderful. And the second one.
Okay, this is THAD, what we call it as transient hepatic attenuation difference. We can see in normal patients also as a normal variant also, and associated with some benign or malignant conditions also. So what happens is that we all know that liver has dual supply, hepatic artery and portal vein. Some of the areas, peripheral areas of the liver may have a more of arterial supply as compared to the portal supply. So we can see areas of enhancement on arterial phase images which are peripherally located. But when we follow these abnormal areas on successive images, there is no lesion there.
So for a clinician or for a surgeon, if you do get confused with one of these two lesions, what do you do next? If you're done a CT, do you do MRI next, or what do you do?
Sir, if if a triple phase CT or a triple phase MRI is there and the radiologist is saying it is THAD, then I think it's okay.
So you trust your radiologist?
Yeah.
Sure. All right. So now we come to multiple solid tumors.
Can I comment on this one? Can I make a comment on this one?
Please, sir, go ahead.
I think an ultrasound is very helpful in this situation. And there's a lesion there. Ultrasound would tell you that there's no solid lesion there, no vascularity, and you can then relax.
Yeah, any role for contrast enhanced ultrasound except for the renal dysfunction aspect? Is it better than any of the cross-sectional imaging for differentiation?
I think whenever we get a situation like this, ultrasonography will tell you, don't worry about it. They won't find anything there in third and all.
Okay, so we'll go with that. Now, another case of multiple solid tumors. So this is like a classical case of secondaries, proven biopsy from a rectosigmoid mass and then metastasis into the liver. So really, not much to describe here. But then, in a patient with known primary and then multiple liver lesions, obviously we often do PET scans also, not only to look at the avidity, but also look at extra liver disease. Now, how would a standard colorectal met will look different from a neuroendocrine met?
So a neuroendocrine met will show very intense enhancement. Mostly colorectal metastasis will be some amount of necrosis will definitely be, we'll see as we saw in the previous images. Here we can see, we can see in all these lesions with central areas of necrosis and there, and this PET image also shows that peripheral areas of uptake and central photopenic areas. So these kind of, if we compare the NET metastasis, we can see the homogeneously enhancing lesions, multiple homogeneously enhancing lesions.
So obviously secondary, we won't be discussing management of secondaries in this panel, but we then come to cystic lesions. So it is rare for HCCs to get confused, to confuse HCCs with cystic lesions, but we'll just complete all SOLs of the liver and therefore we'll discuss the cystic lesions. So this is a 68-year-old lady who had very non-specific symptoms, and then firm mass in the upper quadrant, right upper quadrants. On CT, there was a surprise, a large cystic lesion. What do you think about this?
We can see a very large lesion here, and it is homogeneously hypodense. There is no enhancement, no internal septation, no calcifications, and very thin imperceptible wall. There is no perifocal edema. So all these features are suggestive of a clear simple cyst.
Dr. Shalin, what would you offer to this patient?
It all depends, as you have mentioned, that it will all depend on the patient's symptoms. So if she is grossly symptomatic with heaviness, pain, then I can do a laparoscopic deroofing of this simple cyst. But yes, I have to keep in mind that in some cases, rarely, it may be a type 1 hydrated cyst also. So it would be wise to send a hydrated serology also preoperative.
So if the hydrated serology was negative, then would you still do deroofing?
If the symptoms warrant, otherwise.
Yeah, okay. So I'm going to, for the cystic lesions, because they are easier, we'll just have one person talk about the treatment. Unless Dr. Gupta or Dr. Prasad, you want to make a comment, welcome to do that anytime. Then we have a classical case of hydrated cyst. Dr. Jai, if you could describe that. So it's rare for somebody to do a MRI for a hydrated cyst, but I found a case where it was done and it looks beautiful actually. So.
Sir, you are exactly right, but we should do an MRI for a hydrated cyst, so that we can know the status of the biliary system. It has a propensity to invade into and communicate with the biliary system.
Right.
So here we can see a large loculated cystic lesion with multiple internal daughter cysts, and this appearance is very characteristic of hydrated cyst. We can usually, if we do a CT scan, in most of the cases, we can find areas of peripheral calcification. We can appreciate some kind of sand also. On MRI, we can see fluid level also in the dependent portion of the cyst or internal undulating membranes. So
Dr. Bora, for a patient like this, how would you manage them, and any other situations which you would like to talk about in management of hydrated? And then followed by Dr. Gupta and Dr. Prasad, because this is, there are various situations in hydrated and there are various treatment options.
So like a single large hydrated cyst, if I know in radical surgery, we are not proponent of doing a laparoscopic deroofing because of higher incidence of recurrence and the biliary complication later in the post-op period. So if I can do a limited parenchyma preserving resection, or if I can do a cystopericystectomy, I'll always be more comfortable doing this kind of operation rather than just doing deroofing and higher. But yes, if the performance status is not very good and the lesion is deeply situated or requiring a major hepatectomy, in that case, possibly FAIR is not a bad option. So I mean, recurrence rates are not significantly higher as compared to an open surgery or a more radical surgery. So it depends upon the patient's profile, location of the lesion, and the treatment has to be individualized, I mean, case-by-case basis.
So Dr. Gupta, would you agree with that surgical plan, and what do you think about the anti-helminthic therapy with that?
Very important. I mean, I've been involved with this for a long time, and particularly because we deal with a lot of patients from Central Asian countries. And so I think I agree with Dr. Giriraj Bora that surgery is probably the best, open surgery is the best treatment for it. And the way we do it is we remove even the sort of pericyst wall completely. So we don't do what we call closed cystopericystectomy, but we open the cyst and then sort of remove the wall from the pancreas. That seems to have done well. As far as anti-helminthic therapy is concerned, we do give it sort of 2 weeks before and about a month after the surgery. But I don't know whether it actually cures anybody or not. And finally, PAIR, I think we did a few in the beginning, but generally patients are fed up with that repeated tube change, and so whereas surgery can give very good results. So nowadays we don't recommend PAIR to our patients.
Dr. Prasad, how often do you see hydrated in UK, and how worried would you have a preference for cystopericystectomy versus opening a cyst, or anything different you would like to manage these patients?
Ravi, we see it very rarely. Rare enough that now there is actually a national MDT in one of the hospitals in London, where we send all of them, and those who they believe should be surgical candidates, they refer back, and we tend to do a resection because it's something we're more comfortable with. But I think I would defer to my more experienced panelists on the best management for hydrated cysts.
Wonderful.
Thank you.
So here's another case, patient with fever, high white count, CT shows some characteristic findings. MRI was also done, which showed a thick-walled cyst. Dr. Jai.
We can see a very thick-walled cystic lesion. and the main imaging finding in this lesion is the perifocal edema. The adjacent normal liver parenchyma is compressed and shows some kind of edema which appears as hypodense rim. So this is very characteristic of abscess, and the edema differentiates it from the hydrated cyst.
Okay. Dr. Shaleen, how would you treat this patient?
So definitely I would like to drain this.
Yeah.
So usually it would be this one not very large. So I may be tempted to do a single time aspiration and put him on antibiotics for 3 weeks, both aerobic and anaerobic coverage. But I've seen many a times they don't resolve completely. So putting in a drain, a percutaneous drain, may be more a better option.
So,
but
Dr.
this one
Bora,
is small, so it may just one-time aspiration may be enough for this.
Dr. Bora, would you treat somebody just with antibiotics without drainage or without any resection?
So like I'll differ slightly with Dr. Shaleen. I mean, it looks a small, abscess. So maybe, maybe antibiotics to be continued for maybe, 7 to 14 days and then having a repeat scan. If the patient is having persistent symptoms, like the pain or fever has not gone completely, then possibly I would like to put in a drain. But to begin with, I'll be reluctant to put in a drain. I'll try to give an antibiotic, maybe 10 days, 14 days trial, and then decide for putting.
So, Dr. Gupta, you have to tell me a situation. If you put in a drain and you found bile in that, in addition to pus, what would you do different? Anything?
Yeah. First, I'd like to comment on Dr. Bora's statement that 2 weeks of therapy. I think it's very important when you're treating with abscess that the fever should come down in 48 hours. If not, then it would be an indication for some sort of intervention, which may just be aspiration or just be. But I think if the fever doesn't settle down in 48 hours, you are in big trouble in large liver abscesses. Now, coming to a specific question that if you find bile or you find pus, and I think if it drains out, whether it's bile or pus, eventually it will stop.
Okay. Dr. Prasad, if you put a drain and you found tuberculosis, if you grew tuberculosis in that, what would you do different?
Very little experience, Ravi, in that area. We see it. So, we resected one solid lesion, which turned out to be a tuberculoma in all these years. So I don't know. Sorry, thank you.
Really bad experience with one of the patients where, we did exactly the same. It turned out to be tuberculosis and we resected and they just, he kept getting more and more abscesses and they're really tough to treat. And eventually, he thrombosed his right hepatic vein, then his middle hepatic vein. And then now, for the last 5 years, we are thinking whether we should offer him a transplant. But we are really scared to do that.
Just one point I want to make with regards to that, if you find bile. So these cases may be cases of infected hydrated cyst. So in that case, a resection may be in order.
Exactly.
And we can easily resect seeing the location. And with regards to one-time aspiration, actually it reduces the morbidity. Yeah. As Dr. Gupta also mentioned that the fever and all comes down rapidly. Yeah. So, and it's an easy procedure. Drain should be secondary.
Great. So next is, classical case of biliary cystadenoma, which we resected. So Dr. Jai, please, your comments on the imaging.
We can see a large exophytic cystic lesion and with internal septations, some solid internal papillary projections. And the internal projections, this is a contrast NCT, so internal projections and the septations are showing enhancement on this lesion. So this may be a cystadenoma or adenocarcinoma also. It's very it is very difficult to differentiate on imaging.
So Dr. Shaleen, how would you differentiate the two?
Again, maybe a second imaging in the form of an MRI, it may help.
Okay. But if it doesn't give you an answer?
Then an FNAC may be on the cards.
So Dr. Bora, how would you resect this?
Obviously, if it's a resectable lesion, whether it's cystadenoma or cystadenoma, it has to be resected. That's my first point. Right. Another important thing I would like to share is that, once we have burnt our finger with one of the cases, which was referred as a case of hydrated cyst rupture into the biliary tract. There was calcification. Already a PTBD was placed. This was a patient from UAE, so we also thought we are dealing with a hydrated cyst with, biliary rupture. And Because of the PTBD, the jaundice has resolved. So sometime, I mean, this was a very typical picture, but the diagnosis of cystadenoma on imaging may not be very clear at times. So one has to be, a little careful on making a diagnosis. And sometimes all these symptoms, all these typical features may not be present, on imaging in every case. So calcification can be misleading at times that we are dealing with cystadenoma or we are dealing with pharyngeal cyst.
Sir, here I want to make a point that we should not only rely on imaging findings while treating such kind of cases. It is very common to confuse cystadenoma or carcinoma with hydrated cyst. So clinical and then laboratory parameters, hydrated serology, all should be done before treating the patient.
I don't have an image of cystadenoma, but some of the differentiating things that you will see on imaging, if you could please talk to.
Sir, cystadenocarcinoma may show very coarse calcification. Hydrated will have very linear, thin wall-like calcification. Cystadenomas will have more of a heterogeneity, we can say hemorrhage also, calcifications also, and the enhancement, and then obviously we can see other features of malignancy like lymph nodes and local invasion, vascular invasion and all.
So this is another case of multiple liver cysts. This was a typical case of polycystic liver and kidney disease. Now, Dr. Gupta, what would you offer to this patient with known polycystic liver and kidney disease?
Oh, that's very interesting. We just have a case like this. So who's absolutely normal liver function, huge liver up to the pelvis. And in fact, he's in renal failure though. But his kidneys are actually because of the size, the squash. So we've been debating whether we should just go ahead and remove one of the kidneys and place the kidney there. But the liver function is absolutely normal. And the second question, do a combined liver kidney transplant? I really don't know the answer. Maybe next week I will be able to tell you what we've decided in this case. Huge polycystic liver, kidney failure, but on regular dialysis 2 years. Refer to us for combined liver kidney. I don't know what exactly to do.
So, Dr. Prasad, in which situation would you offer a combined liver kidney to this patient?
Our experience with transplant in polycystic liver disease, there's a subgroup of patients who don't do well. And that's the elderly, those who are, 55, 60 plus, and then especially if they have coexisting renal failure and who needs a liver kidney, they are metabolically very poor and their reserve is poor. So that's a group we really, increasingly we started saying no. The ideal ones would be young people, young patients with kidney failure, but it's important to intervene much before the kidney failure goes on for many years, because dialysis has quite a debilitating effect on the cardiovascular and metabolic parameters of patients. So you should do it early rather than late.
So these patients, like Dr. Gupta said, will always have normal liver function. So how do you get them on the list and get them the organs? Because they will never get priority.
So there are two ways. Obviously the systems vary in different parts of the world. So we have they get listed as variant syndrome. So a proportion of livers within the pool will go towards variant syndrome patients like hepatopulmonary, polycystic, and where the liver failure is not an issue. And the second is LDLT.
Yeah.
So we've done a few LDLTs for them.
Yeah. Okay, great. So that's the guidelines which, sometimes you have to do a de-roofing for these guys just because of their symptoms, but otherwise we spoke about everything else. So these are, again, biliary hematomas, if you can describe the imaging findings, and then...
we can see small bearing-sized cystic lesions in both lobes of the liver which have irregular margins and they are not communicated with the bile ducts. So these are very typical of biliary hematomas. Right. There is no enhancement, no septations, nothing.
So Dr. Shalin, would you do anything for this patient?
No, actually they do raise some alarms when we are evaluating donor CTs. We were just discussing.
Yeah,
exactly. So nothing to be done.
Yeah. And the next one is this, again, classical Caroli's disease. Dr. Jay, if you could describe it.
Here also we can see multiple small cysts, and we can see the central dot sign, which is due to a vessel, enhancing vessel in the between, and these cysts will communicate with the dilated biliary system. We can see that IHBR are also dilated.
So in this particular case, although there are cysts on both sides, which is typical of Caroli's, there is more cystic disease on the right side. So Dr. Bora, would you offer any resection to this patient?
So again, it depends upon the symptoms of the patient. If patient is having, recurrent episodes of cholangitis, we do an MR and find that, there are stones and intrahepatic strictures which are confined to only in the right side of the liver. Maybe, if there is no significant portal hypertension, we can do a right hepatectomy.
So, Dr. Gupta, would you offer a patient a resection in Caroli's disease if they are asymptomatic?
I would not.
Right,
You mean it's just one-sided Caroli's disease? Is that what you say?
If it's like predominantly one-sided, so you're not going to fix the problem.
No. I think you end up, these people keep coming back to you with, I once did a wide anastomosis. I did a right hepatectomy and wide anastomosis, and that hepatico-jejunosis strictured in 1 week's time, with stones formed there in that area. So I burned my fingers a number of times. I would not do anything. If they're doing well, I would just leave it alone. Or maximum, I would do a sort of hepatico-jejunostomy and hope for the best.
Dr. Prasad, anything different?
We've done resections for some segmental Caroli's where they are localized to some segments of the liver. And otherwise, if they're asymptomatic, we won't intervene. And recurrent cholangitis, we treat with antibiotics like everyone else.
Okay. So this is the second last slide. So I would like Dr. Jay to sort of help us to choose which imaging is best for which type of tumors based on what component of tissue is present or expected in that type of tissue, in that type of tumor.
It's liver protects.
Okay, sir. And CG PET scan is okay. Mongolia patient, we are going ahead for.
Okay, most of the liver lesions we will see on ultrasound. Ultrasound is the best modality to differentiate between a solid and a cystic lesion. Okay, it will tell us whether it is a cyst. Most lesions will be benign only, and the most will be cysts only. So cystic lesion, they will be very well defined. Hemangioma, if they are small, then they will be hyperechoic, sharply marginated, and they can be followed up with a triple phase CT scan or MRI. The choice of CT scan or MRI in cases of hemangioma and other lesions entirely depends on the local expertise, machines available, patient acceptability, and if the patient is claustrophobic, obviously we have to go for a CT scan. Because MRI will take time, then fatty sparing and infiltration, it will be geographic. We can see very well see on ultrasound. Usually no other imaging is required. Metastasis has very varied appearances. On ultrasound, we'll see target shaped appearance, and obviously, if we are suspecting metastasis, we have to go for higher imaging. And for staging also, we have to do a chest and abdomen CT scan. HCC will have predisposing conditions, vascular invasion, and obviously CT and MR is required because no therapeutic decision can be taken on ultrasound alone. FNH we will see in middle-aged women, scar is seen, and we can confirm it by MRI mostly. Adenoma also, same thing, we'll know by the demographics of the patient that it is an adenoma, and we can confirm it by MRI because varying appearances are there. Abscess, we will have clinical sepsis, we can decide on basis of ultrasound only. Cholangiocarcinoma, definitely we will need higher imaging. Triple phase CT will be best. Fibrolamellar HCC also, they'll need a triple phase MRI. And benign cyst adenoma, it can mimic any kind of disease, so we'll definitely need a CT or MRI.
Wonderful. So that's just a summary of all the SOLs we discussed and what imaging will be best for them. This is one of the algorithms to decide which modality to choose when, but there are several algorithms like these. And we have about 7 more minutes, so we'll be happy to take any questions from the floor about any of the SOLs. Yeah.
May hello. I'm Dr. Nisar Hamdani. I come from Srinagar, Government Medical College, Srinagar. I want to bring your kind attention one more type of non-HCC space occupying lesion, which we have been seeing. There is a sort of surge in those lesions, that is alveolar hydrated. From past few years, since I'm now working as a consultant, previously I was as a postgraduate. That time I didn't had that exposure of alveolar hydrated. Now I am seeing surge of alveolar hydratates. So peripheral lesions, fine, resection is okay. But regarding centrally located alveolar hydratates, which are sort of infiltrating, I would definitely like to get comments from my senior colleagues who are practicing in Delhi, because most of these patients get a second opinion from the nearest capital city, that is Delhi. What is your experience regarding alveolar hydrate, especially the centrally occupying infiltrating type management?
So we have had some experience with treating alveolar hydratates, and most of these patients, actually all of them have come from Central Asia, like Kyrgyzstan, Turkmenistan, and probably it's just spillover from there. And these patients have had some kind of intervention previously, a resection which may have been incomplete, or some drainage. So when we receive these patients, they have exhausted the less invasive means of treatment, and especially the ones which you are talking about, the centrally located ones where the resection would not be feasible, I believe, in most of these cases. So for these patients, I think liver transplant serves the best modality for treatment, because there is no other way of treating these patients. But again, transplant, we have to be very careful, but because many a times these alveolar hydratates may have infiltrated along the porta hepatis and gone down. And we have had a case where we had to do a lot of extrahepatic resection, because that was our initial cases. And you have variety of lesions. Some are cystic, some are calcified, some are abscesses. So the treatment for these cases is really difficult, but yes, liver transplant should be in the armamentarium, and it serves these patients well.
So do you have experience with
Yes,
liver transplant in these patients?
We have transplanted quite a few.
Thank you.
I would like to share my experience of a very interesting case. We recently had a lady presenting from these, CIS countries. Basically, she presented as a case of alveolar hydratic cyst and ACLF. Now we were wondering how could somebody present as ACLF. So when we worked up, she was found to have Hep B, Hep C, together with an alveolar hydratic cyst and previous surgery. Now, this was a very large cyst, and in fact, the portion of cava was not visible. So when we went in, what we found that from suprahepatic, from suprarenal portion to up to the hepatic veins, the cava was completely digested by the hydratic cyst. So because it was completely thrombosed, and the cyst got eroded into the cava. So now, because there were a lot of collateral, so we did not reconstruct that portion of the cava. So we just mobilized the suprahepatic cava and brought the right atrium little down, and we made an outflow for the liver. But the middle, around 7 centimeter of cava has been, it's absent in that particular lady, but there has been so many collaterals that her kidneys are alive, and there is no, edema or something, in our lower limbs. So yes, these patients, they have more aggressive kind of, they have more aggressive cyst as compared to the normal hydratic cyst.
So we had a similar experience with one lady.
Yeah. We'll take 2 quick questions and quick answers.
One question to Dr. J. Regarding this radiology, how close is neuroendocrine tumor in the differential diagnosis of biliary cyst adenoma? Does it stand somewhere close?
No, neuroendocrine tumor mets will show intense arterial phase enhancement.
Not metastasis.
Intense, homogeneous. The entire lesion will show enhancement. And biliary cyst adenoma, only the cyst and the peripheral wall will show enhancement. The central portion, the cystic portion, will not show any enhancement.
We recently had a young girl in her 20s. She had a typical cystic lesion in the central part of liver with enhancing walls. We presumed it to be a cystoadenoma, as was the radiological diagnosis. We went ahead and considered enucleation. That came out to be neuroendocrine tumor in the histopathology and confirmed by immunohistochemistry.
Great. Okay, next, we'll take two more questions, a quick answer to these. Yeah.
Sir, I'm Nirjar from AIMS Rishikesh. I want to ask question my question is for Raj Prasad, sir. Sir, are you not worried for when you advise conservative management for giant hemangioma that this will grow in future and it will make simple surgery in difficult surgery? It will involve some vein and vascularity also will increase.
Thank you. I've been pushed many a times by patients. Why don't some of them? I remember very well. There's a particular patient who plays rugby, and it's a very contact sport, and he was worried if he would rupture the hemangioma. But I think after repeated counselling, he got around, and we never had to do anything, operate on him ever. So I think the risk of rupture, the bleeding is all overstated. I think you can quite safely discharge these patients. So it's a routine practice.
Thank you.
Thank you, sir. And do you consider, sir, as a upper abdominal discomfort with a giant tumor, big tumor, as an indication for surgery?
Possibly.
All right.
Sir, I've come to ask you about intrahepatic cholangiocarcinoma. You said the data is very small. Whatever has come is from very small retrospective series. There's one non-randomized prospective trial which has just started.
Yeah.
So I hope you're not pushing the concept that we should be transplanting cholangiocarcinoma.
Oh, no. So
Thanks.
this is a experience from incidentally detected on explants.
Yeah.
So therefore, we are not pushing for. This is a panel discussion, so we have to ask.
I would make a point, like to make this point in this regard, that when you mentioned the word incidentally detected on explant, actually when we looked at our data, these mixed hepatocholangios have the worst prognosis.
Yes.
And most of them have recurred within less than, we have around 14, 15 such
Within
cases,
months.
and they've recurred within 2 years.
Yeah,
less than 2 years.
within months. Yeah, great. So, we're done. So, thank you very much, all the panelists. It was a very, enlightening for me and very engaging discussion. So, thanks a lot.
Thanks again, Ravi. You've done an excellent job.
Thank you, sir, for a great radio surgical discussion.
Thank you very much.
For the next session, for the panel on the liver cancer, the liver transplant, I would like to invite the moderator, Dr. Nemish Mehta, senior liver transplant surgeon and Mahatma at the Gangaram Hospital, and the director liver transplant at the Mahatma Gandhi Hospital.
Thank you, Dr. Anand and Dr. Kapoor and the whole team for inviting me for this session. Can I only start my slides? Thank you. So we are going to have again a similar panel discussion on liver transplant. There have been some questions coming up. Thank you. Can you go to the slide below? So I'll call all my panelist colleagues. I would like to call Dr. Anand Bharathan, who is a senior consultant and surgeon in HPB, GI surgery and liver transplant at Sri Ramakrishna Hospital, Coimbatore. Dr. Anand Bharathan, please join us. Dr. Pari Vijay Raghavan from Coimbatore. Again, he's a senior consultant and clinical lead in HPB surgery and liver transplant and kidney transplant at Kovai Medical Center and Hospitals, Coimbatore. Sachin Daga is going to join us online from Hyderabad. He's a senior consultant, HPB and liver transplant surgeon in Hyderabad. Setsen Yonjen Tamang from Nepal, lecturer and consultant surgeon at Kathmandu Medical College and Teaching Hospital, Nepal. And Vinay Kumaran, my old colleague, who is now moved to USA. He'll be joining us again online, working currently at VCU Medical Center, Richmond. And Professor Jen Leroux, who was there with us in the morning from Brussels. He himself is a professor emeritus of surgery and director of Starzl Abdominal Transplant Unit and UCL at Brussels, Belgium. So I would like to welcome all my panelists. Do we have the online panelist as well?
Okay.
I'm here.
So I'm going to start. So since again HCC being the most commonest for which liver transplant is being done, so let's start with the role of liver transplant in HCC. And this is for my younger colleagues. We'll keep on talking about Milan criteria and UCSF criteria and what exactly is Milan criteria. A single lesion less than 5 centimeters or less than 3 lesions, but each being less than 3 centimeters, that's the Milan. And that is still considered as the gold standard. All the other criteria are compared with Milan. UCSF, single lesion less than 6.5 or less than 3 lesions, each being less than 4.5 and a total diameter of less than 8 centimeters. So let's start with the cases first. We have got a 56-year-old male, type 2 diabetes, NASH-related CLD, decompensated with ascites, esophageal varices, severe portal hypertension, presented to us with AKI with a creat of 3.28, CTP score of 7/15, child's B. If you look at the lab parameters, platelet count of 38,000, hemoglobin of 9.9, TLC of 2,500, INR 1.45, Billy of 2.3, albumin of 3.7, alpha fetoprotein or other tumor markers shows fairly within normal limits, viral markers negative. Scans done shows CLD, an isodense lesion in segment 2 in the subcapsular region, atypical late arterial phase enhancement and hypodense in the venous phase, no evidence of thrombus seen in the splenoportal axis. So that's how the various phases of the scan, plain scan, arterial as well as the portal venous washout scan. So there were changes of CLD with a non-FDG avidity on the PET scan with no evidence of extrahepatic disease. And that's how I would sum it up. Can we start with Anand the first? How Anand would you like to go about now from here?
I don't come from a setting like what you work in. So my social setting is different. I will not transplant this patient most often. This patient, if it is treatment naive, I will actually get him treated, get the liver disease stabilized, do a radiofrequency ablation or a microwave if it is accessible. We have a wonderful intervention radiology, provided you have it, and keep them under follow-up. Try to raise finances for the patient because
right.
we
So
have
did
all
we miss some of the points here? Pari, I'll bring out those points, but Pari has something to say?
Yeah. If I can go back to the CT imaging, it wasn't typical of HCC, was it? The description was
so atypical, so late. So that's why they said there's a small lesion, arterial phase, late pickup, and then there is some bit of washout.
We are not very sure whether it's HCC.
Correct, but my radiologist
I would get a contrast enhanced MRI to see characterize the lesion.
Okay.
And if it's a HCC, then it falls within Milan's criteria.
Excellent. So as we all discussed, what is Milan? So that's again for my younger colleagues who are learning. So yes.
Yeah. So apart from the financial issues that Anand was mentioning, so this patient is a decompensated chronic liver disease patient with we presume that the MRI shows a typical HCC.
We go ahead with that, yes, that MRI did show an HCC, yes.
In which case, I think this patient would be a candidate for a liver transplantation.
Right.
I mean,
so
medically,
again,
he'll be.
Correct. So what I wanted to point out, what Anand missed out is again, it's a decompensated, which Pari pointed out, ascites, AKI, severe portal hypertension. You look at pancytopenia, platelets of 38,000. In these cases, they are decompensated CLD. You have a tumor which is within Milan. Dr. Setten, would you like to say something in this? How would you manage this patient?
So I'd like to know the tumor markers, were they the alpha fetoprotein or things like that?
So alpha fetoprotein is 5, CAA is 5, 19.9 is 16.4, fairly within, everything is fairly within normal limits.
So on a background of a cirrhotic liver, decompensated
There is,
liver,
yes, all the scans does show that there is cirrhosis on background of cirrhosis. So technically, would you call this as child J cirrhosis with a small lesion, or you would label this something else?
Yes, I think the LFTs were rather deranged for a...
Correct. So that's what we are trying to, yes.
Yeah, it would be a...
So you agree with us that it will be child's B cirrhotic liver with decompensated disease and a single lesion within Milan. So according to you, this should give us a good outcome as per even literature as well?
Yes, sir. So if you go according to BCLC, this would be a very early stage kind of a HCC, if it turns out to be HCC. And according to that, if we follow, there'd be two options. If the patient is a candidate for a liver transplantation and if there's no contraindication for transplantation, I think this would be a
You would also would want to go ahead with transplant. Any of my colleagues who are online, Professor Lerut, Vinay, and Sachin, you would want to add a comment to this? Though we did go ahead with liver transplant on this gentleman, but is that Vinay? Yeah. Yes, Professor.
This patient would need a, sorry.
Yeah, go ahead, Vinay. Go ahead, please.
This patient would need a liver transplant in any case. The early HCC is not a contraindication. But even if there was no HCC, he would still need a liver transplant.
Professor
I agree. He has two reasons to go to transplantation. He has a decompensation. This can probably be improved. We will see. But he has a cancer, which is also a complication of the cirrhosis. But it is an atypical imaging. So I would surely do a biopsy and do done independent of the decision doing an alcoholization or a local regional therapy, because it is an atypical lesion. It can still be a mixed hepatocellular cholangiocellular cancer or another type. And we know that the results in these cases of transplantation are less good. So it is also important to be able to tell the patient something about his prognosis. Because if it is a mixed tumor, 1.9 is the limit. And there have been some papers, but very few about these mixed cancers, but the results are markedly worse. So this is important to know. But I would do a biopsy and doing at the same time already a treatment with ablation. But I think if shall be, I would do the least invasive. I would just do an alcoholization. Is a tumor less than 2 centimeters? Then we have a biopsy, then we have the treatment. If you're an LDLT, it's easier, but if it's easier to be on the waiting list, it's better to do right away a treatment and to do the biopsy.
Right. So again, for biopsy, two points which were against it. He has ascites. Even for ablation, he has got ascites, which we're missing out. Platelet count is 38,000. No interventional radiologist would want to stick in a needle in that without obviously giving platelets. And if the radiologist is fairly convinced, and as Dr. Pari has already pointed out, we may go ahead with a CE MRI, contrast enhanced MRI. And if that gives you a fair bit of clue towards HCC. So within Milan, decompensated liver disease, that's what we did. We went ahead with living donor liver transplant this year itself, and the histopathology did come back as the moderately differentiated grade 2 HCC. So let's go to the next case. Wanted to again for the younger colleagues. Within Milan, there are multiple options you can actually offer these patients. Within Milan, there are multiple microwave ablation, radiofrequency ablation, TACE. These are the options available. But if the patient has got a decompensated liver disease, transplant definitely has superiority over the rest of the treatment modality. So coming to the next case, 50-year-old patient, HCV-related CLD for more than 15 years. Viral response, again negative, has been treated. Decompensated, presents to us with decompensation with ascites. Child's A, no jaundice, coagulopathy, AKI or HE. Most of the parameters are fairly within normal limits. Alpha fetoprotein, the tumor markers here is 4.8. Anti-HCV antibodies is positive, but as he was already being treated, HCV RNA is negative. Scans show changes of chronic liver disease. Segment 7 has a lesion of about 4.4 centimeter. Segment 8 has 4 centimeter, and segment 7 has got about 2.9 or 3 centimeter lesion, likely of HCC. These are the scans again. The 3 scans are showing segment 7 lesions, and this is the lesion which is being seen, and that's the washout. No, okay, so I'll show it here. So that is showing a washout here, and that's a segment 8 lesion in the hepatic venous phase washout. So technically, Professor Setan, if we go to the terms of classification, he is child A, but tumor-wise, which criteria would you think he would fall in, just for our younger colleagues' knowledge? Within Milan, outside Milan, and within UCSF? Sorry, okay. So So that's 4.4 centimeter lesion in segment 8 and 2.9 centimeter in segment 7. So there are two lesions. If we go within Milan, then the lesion size should have been less than 3 centimeter each individually. So technically this becomes within UCSF and outside Milan. PET CT again. Wanted to ask Pari, do you do PET in every case?
We do end up doing PET in most of the cases. It gives us some idea about what the biology of the tumor is going to be. So we are happy when the PET is, the lesion is FDG negative. And if the patient has got a very densely FDG avid lesion, we know that the biology is probably not good. So the answer is yes, we end up doing PET for most of the cases. And that's give us, apart from saying whether there are metastases elsewhere, it also tells us what the biology of the tumor is going to be like.
Right. So what Dr. Pari is trying to point out is if you do a FDG avid PET and if the lesion is non-avid, this a sort of a surrogate marker where it may be a well-differentiated tumor. If it is FDG avid, then there is again a surrogate marker that it could be a poorly differentiated. Can we have an opinion from Dr. Vinay Kumaran from USA? Do you do PET on every cases, Vinay?
Sorry, trying to unmute. No, we don't do PET in all cases. We only do it in select cases where we're looking for specific information. So someone like this within UCSF with normal AFP, we would not do a PET. We just do a CT chest.
So fantastic differences again. So, but to rule out any bony metastasis, would you like to add a bone scan also with it?
We don't routinely do bone scans.
Okay.
The yield is very low.
Right. So here again, we went ahead.
If I may say something, we do a bone scintigraphy because I do not agree with the fact saying that this is expensive. If you do, and we have this experience, if you do a transplant and then the patient has a bone metastasis, this costs much more than many scintigraphies, and there is a graft loss. So I think a scintigraphy should be part for all patients, even if AFP is normal. I have from own experience patients who were child A, one lesion, Milan in and so on, and they had an isolated lumbar metastasis. So this is a drama when you transplant a patient because they go immediately in a diffuse recurrence. So I think that the staging should be done as it should be done. When you lose a transplant, it's a lot of money you lose and another patient who dies. This is the problem for me.
Point well taken.
So more specifically in India, we used to do bone scans in all cases. When I moved to the US, I found it's not done routinely, and apparently it's because of a very low yield. So yes, if I was back in India, I would do a bone scan.
No, in which cases, Vinay, would you like to do a PET? Any specific indications?
So we do selectively offer LDLT in patients who are beyond Milan. And in those cases, we do a PET to assess the tumor biology and to ensure there's no extrahepatic disease.
Did I hear it correct? You said all LDLT you would like to do it. Did I hear it correct?
No, specifically in the LDLTs in patients who would not qualify for DDLT. That's a group of patients in whom we do PETs.
So those who are outside UCSF criteria, you would like to do a PET.
Right, yeah.
Right, but I think
or with exceptionally high AFP levels, even if they are within criteria.
Correct. So Professor Nehru's point is again well taken here that PET, a lot of people say that it is an expensive modality of investigation, but if you're going ahead for a transplant, recurrence will end up costing more, and hence PET is a good modality which can be as an investigation, as a staging investigation to decide whether you want to go ahead or not. If for whatsoever reason you do not have access to PET or you think it is too prohibitively expensive, a CT chest and a bone scan are the two other investigations which can be added to rule out metastasis, and that is what we follow. So in this patient, again, we did a PET scan which showed multiple FDG avid arterially enhancing lesion involving segment 6 and 8 of the liver, likely residual mitotic disease. There are multiple non-FDG avid hypodense lesions, probably regenerating lesions, and no extrahepatic disease seen on the PET. So here again, we had two nodules, 4.4 centimeter, largest one, no portal vein involvement, no vascular involvement, no extrahepatic spread, outside Milan, within UCSF. Dr. Setan, would you still go ahead with transplant with this patient with you, or would you like to offer some alternative therapy to this individual?
So on a background of a cirrhotic patient with
Yes.
this malignancy, liver transplant would be an option, yes.
So do you routinely try to downstage them in your center, or you within
Yes, it
UCSF you
is.
would go ahead?
No, we in Nepal, it is imperative that our patients are within Milan criteria, so we would need to downstage these
So you would
patients.
downstage.
Yes.
So what modality would you use to downstage?
The DAYS or RFAs are available.
Okay. Pari has any opinion to that? Would you downstage, or you will still
Yes,
straight go ahead?
one will downstage. What I would always prefer whenever possible a microwave ablation. This first tumor is slightly little too big for a microwave, 4.4, but with the latest probes, they say that up to 5 centimeters they can confidently do ablation. But if it's probably a decision between a TACE or a TAR, for those lesions. If they are very well seen on a CT scan, very well, if I'm confident that they're going to do a selective, selective cannulation, I will send them for a bridging therapy, TAR or TACE.
TAR or TACE. Okay. So with microwave ablation, there are now, they actually go up to 5 centimeter as well. And you are right, it's a little on the higher side, but they are able to do it. Professor Lerut, would you like to downstage this?
Yes,
straight
yeah,
away?
yeah. Yes, I would surely do in this patient a TACE for sure, and even maybe more than one, because he has two big lesions. And we did a study showing that even in Milan-in criteria, when you have, the more you have necrosis, the better was also the outcome, disease-free outcome after transplantation. There has been a lot of discussion to do downstaging in Milan-in criteria, as you may know, but I disagree with this. I think these patients should have a pre-transplant treatment,
So
even if AFP is normal.
Right, sir. But in the morning session which we had from you, we had a good debate as well in terms of expanding the criteria and Milan being too restrictive a criteria. So do you still would want to transplant only those patients whom you are able to downstage to Milan?
No, we go further than Milan, but the problem is that I work in the era of Eurotransplant, and in Eurotransplant you cannot transplant a patient outside Milan criteria, which is of course completely over. This is not following the evolution of medicine, but we cannot change it at the moment. So anyway, we are obliged to downstage the patients, and we can only list them when they are within Milan criteria. But it means that a lot of patients which can have a curative transplantation cannot be helped. And this is not logical. And we must fight everywhere in the world to change this allocation system. It's everywhere a problem. And that's, of course, the good reason for living donor liver transplantation. We can only progress in this field when we do living donor, also in the Western world.
Right, exactly. So now since there is a good amalgamation between the Eastern and the Western, and the Eastern world, there is more and more, you have living donor liver transplant. So in this patient, if he happens to have a living donor, would you still want to downstage him and wait? Or you'll just go ahead with transplant? Vinay?
My answer is yes.
Yeah, I agree. The response to downstaging provides some prognostic information, and it also seems to decrease the risk of recurrence. So it would be worthwhile. In our institution, we probably do Y90.
So effectively, I think most of the panelists, I'll come to Anand, but most of the panelists seem to agree that we need to downstage within Milan. Milan definitely over the decades, it has given us good results. There has been a huge discussion about expanding the Milan criteria, but still from the personal experiences of the panelists, they are keen to still downstage. Anand?
Nothing new. I think I'll certainly
you will also
treat before the transplant.
Right.
If I may add something,
yes, Professor.
I told you this morning also. I disagree also what has been said in the literature. Downstaging for me does not mean that a patient must come within Milan criteria. Downstaging for me is a morphological MRI cyst, and a biological regression of the tumor markers. And this should be the criteria, because if you want to downstage these patients within Milan, it's possible that it is not reachable, or it is possible that you need many interventional radiologists, but this is not a good thing for living donor liver transplantation. And we made also once a study in Brussels some years ago that once you do more than three, that you need to do more than 3 days, that in fact the outcome is less good. And this is logical because it means that the patient have a higher tumor load. So I think we must agree within the community what is downstaging. Downstaging, like in every other field of oncology, means a response to treatment. It is a partial improvement or a complete, but it is a response to treatment. What we know, if you do local regional therapy and you have no answer at all or any progression, then we know that the outcome after transplantation is very bad. So we must unify our terminology to treat these patients. And for me, the patients in the Western and the Eastern world, they are all the same. There is no difference. Cancer is cancer.
Right. So point well taken. So the treatment local regional therapy is being given not just only to downstage, but to check for the tumor biologies. And as we all say in many conferences, and we have heard that tumor biology is the king. Now, we at our center do actually accept up to UCSF criteria, and we went ahead. But in this case, we did a TACE in 2018, waited for a few months, saw the response as all my other panelists had pointed out, looked at the biology, and finally in Jan 2019, we did LDLT with the right lobe, and the histopathology showed grade 2 HCC PT3 lesion. Now coming to the third case, we have got the 66-year-old gentleman, known case of diabetes mellitus, hypertension, these are the comorbidities, presented with a pain in the right upper abdomen for a month, no other complaints. Labs fairly okay, except when we sent for tumor markers, we found that alpha fetoprotein was only 7.7, but PUCA was 1746. So I think my imaging somehow, yeah, here it is. So sorry, got the slides got. So this is the TPCT, which showed a large 15 centimeter heterogeneously enhancing mass seen in the right lobe of liver, segment 5, 6, 7, and 8. Early enhancement in the arterial phase, again not very classical. Anterior branch of the right portal vein could not be opacified. The question is whether this was infiltration or just a bland thrombus because of the compression of the large tumor. So can we start with Anand here, please? And that was one of the reasons post imaging we had sent PUCA. So yes.
So it's a large tumor. Wouldn't offer transplant first. I think I'll do a TACE and tell the patient not to expect to get transplanted in the first place. Tell them that, okay, we'll give TACE, see what the response is, see if the PUCA falls, assess. We'll certainly do a PET while waiting for the TACE to be organized. Look for disease elsewhere, because if there is disease elsewhere, then it's end of the road and we are going to palliate.
So Pari also agrees with the same?
Absolutely. Not a transplant candidate.
Yeah.
It's a diffuse tumor. This is not a well circumscribed tumor. The diffuse tumor morphology itself is not a good thing to have. High PUCA values, elderly patient, multiple comorbidities.
Yes.
So everything point towards, there's absolutely nothing which would suggest a transplant would do harm good for him.
So the portal vein here is not visible, and Professor Setan, TACE I thought wouldn't be a very great modality. The portal vein is not visualized. Anything else you would like to offer him apart from TACE? My interpreter says rather than TACE, TARE would be a better modality. So do you agree with that statement, Professor?
Absolutely, sir.
Right. So you would you offer a TARE to this individual at your center?
It's not available in Nepal. I
Not
probably
available,
have to
okay.
send it.
Yeah. Also, I'll just point out, because the radiologist was not very sure, this is not a classical picture of an HCC. There is no clear-cut washout, no clear-cut uptake in the arterial phase enhancement. So not very sure that this was a typical HCC. More what Paril tried to point out is sort of probably a coalescent type of a lesion. And in these cases, would you like to biopsy, Professor Lerut, if he's still with us?
No, but because the PIFCA level is very high, we have for sure the diagnosis. It's a good example of what I said this morning. We cannot go on treating all these patients by not using all available markers that we have. I compare with colon cancer. We do not treat colon cancer only with CEA. We look also at CA 90.9 and so on. So for every cancer, we should have AFP and we should have PIFCA. Of course, none of these tests is perfect, but this is a good example that it shows that it's useful. And there are more cases than we think who are AFP negative and have even very high values of PIFCA, because the value here is very high, but it can be even higher. So I would see what is possible to do chemoembolization, maybe very selective, because maybe as a portal vein thrombosis, but I think he needs first the exam to see how is exactly the portal vein. And even if there is a segmental thrombosis, I think we can still go for a TACE, or maybe a tear. It's also a good opinion. But, okay, that's depends on the availability in your hospital. But it is, I agree with the other comment, it's more like an infiltrating tumor. You don't see the borders very well. Maybe, yes, maybe there is a capsule posteriorly. It is not very clear, but there can be a capsule, it's possible.
So I'll add to that. So portal vein, right, whole portal vein was just not visible. So that was the reason my radiologist was a little afraid of doing a TACE. We did offer tear to him. Dr. Pari wants to add in something.
First thing, in such tumors, I will get a contrast enhanced MRI.
Yes.
In such tumors with this morphology, it's more of very often we see that they have multiple other nodules scattered throughout the liver. So,
True.
you know, that it changes everything. Whether
True.
we are going to talk about doing TAR, not everything changes.
Absolutely.
So if I see a tumor like this, I'll always get a CMRI first.
Fantastic. So how much would tear cost at your center?
I think in our center, I'm not sure, maybe around 10 lakhs,
Okay.
if it's a yttrium 90.
Okay, so it costs about 13 odd lakhs at least at in Delhi. And Dr. Vinay, you wanted to add, what would you do? Would you biopsy? One, that is first question. And second question is, because this is not classical imaging picture. Second is, would you offer a tear in US?
Yeah, I think with the PIVCA that high and the normal CA 99, you don't need to biopsy it. And yes, if there's not too much shunting, then tear would be the first option. If they find a lot of shunting, then selective TACE would be a alternative.
So what we did is actually we biopsied it before actually doing PIVCA. Unfortunately, my slides, I've already put the PIVCA report. So we just saw AFP and we were not very convinced. We do have a lot of mixed picture of mixed HCC with cholangio. And if this happens to be a large cholangio, again, it's the whole modality of treatment will change. So we actually biopsied, confirmed that it's an HCC. The biopsy came back as an HCC. That actually struck us that we need to now do PIVCA. So that was the whole idea why I wanted to present this case. What is the importance of alpha-fetoprotein? It's usually used as a diagnostic and a prognostic marker. It can, in some cases, predict the recurrence post your therapy. It also tells you the disease activity after the surgical resection, can be easily used for resection, surveillance. And if the alpha-fetoprotein is more than 20, the more it increases, the higher the value, the higher the specificity. But if you add PIVCA to it, then the sensitivity and specificity both increases significantly. And PIVCA alone, though it has got a low sensitivity as compared to alpha-fetoprotein, both in combination will have a significant sensitivity as well as specificity. PIVCA alone, and though in our case it did come out to be a specific and pretty high, so the specificity is about 92%. And as all the panelists, my colleagues have pointed out, preferably in those cases where you are thinking of an HCC, try to do both alpha fetoprotein and PIVCA. I'm aware that PIVCA is not available at every center and every place. Anand, do you have PIVCA at?
We can send it to labs, which
To
can
other
give the
labs,
report
yeah.
in 3 days' time.
Yeah, so you take a couple of days' time to come back. But so not every lab is doing it, but yes, the point well taken is we need to do AFP and PIVCA. In doubt, I would biopsy it, and I'm sure my colleagues also, after doing all the investigations and you still have doubt, would agree that biopsy is a good modality. This patient was given option of tear, and unfortunately the tear cost about, as I said, 13 lakhs. Not very keen to go ahead for tear. How much, suppose, is there any other thing with you which you can offer? Transplant, all my colleagues have said not possible, should not be offered. Anything else you would like to offer, Anand? Cost effectiveness, tear is 13 lakhs. Transplant is again more than 20 lakhs and is non-transplantable with the current scenario. What would you like to offer him?
We do selective TACE. I mean, in our setting, the vascularity is reasonable in the tumor. And we have managed with a few sittings of TACE.
So a large tumor of 15 centimeter.
Yeah, we have managed with a few sittings of TACE.
Don't you get a post-TACE syndrome? Have you seen them?
We haven't. We had one patient who had a major thing and then had to be in ICU for a couple of days actually with that. But yeah, large number of patients. I can tell you the number. The number is 90 of large HCCs that we have tasted. And one had this thing.
Okay. So what I'm talking again for the younger colleagues to understand, what is post-TACE syndrome? Dr. Pari, you would want to point out post-TACE?
Yeah,
have you seen any post-TACE syndrome?
Yeah, so the post-TACE syndrome is when you have a big tumor getting embolized, and then there's a lot of necrosis going on, and then necrosis release a lot of cytokines, so you get a sort of a cytokine storm like syndrome with fever, tachycardia. Sometimes it gets necrosed, sometimes it can even rupture because of the edema which ensues after a big tumor being embolized. So fever, pain, tachycardia, sometimes necrosis getting infected, sometimes tumor getting ruptured are all part of post-TACE post-embolization syndrome. In our setting, such a big tumor, our radiologists would not TACE because they are worried about the post-embolization syndrome. They wouldn't TACE. So these patients are stuck. So of late, although I know it's not the published literature, of late our radiology colleagues have been doing a lot of SBRTs in such patients when they are convinced that there is a lot of uninvolved liver still available. They say at least 40 or 50% of the liver if it's uninvolved. In such patients, they have been trying SBRT. And apparently they say that, it's been good. I'm yet to see a literature which would strongly support that. But in such patients where you don't have any other option, then you should always have a chat with your radiology colleagues to see if there is a SBRT role here.
Right. So since Dr. Pari pointed out again, TACE has its own complication. Post-TACE tumor necrosis can lead to severe sepsis, and you may end up losing patients. We have lost a couple of patients post-TACE for a large, and my radiologist is very, very skeptical to do a TACE. Again, to point out, Mahatma Gandhi is doing a trial for all these type of patients of liver tumors, which are large tumors. They are treated with neoadjuvant chemo and with SBRT. And if you do have any of the patients, please do send them to be enrolled. Dr. Lalit Mohan is the main principal investigator for that. So you do send us, we'll try and enroll. And in coming years, we may have some, as Pari has been pointing out, we may have some outcome. Dr. Saten, in your center, again, TACE, such a large tumor, would you like to go ahead? One, and if no, would you like to resect this tumor? Will you be able to offer a resection? If he's saying tear, I'm not affording tear. Sorry, I can't afford a tear. Tear is 13 lakhs. I don't think I would want to afford. I want to spend that much money. I don't have that much money to be spent. Would you like to resect this patient, liver
First
resection?
of all, taste wouldn't be an option because, like you said, our radiologist would also not be comfortable with that.
Doing it, yes.
Second thing is, what was the CTT status of this patient? A, right?
So technically, child's A, if you look at the albumin is 4.4, platelets 3.37, INR of 0.99.
Yes, since
Mild lobulated liver, if you look at Billy is 0.44. So if you look at the scans, mild lobulated liver, not classical, you'll be able to label it as a cirrhotic liver. My radiologist did not label it as a classical cirrhotic liver. So even if you want, if you say early cirrhosis, it will be child's A.
Liver resection could be a possibility in this patient, but of course the chances of recurrences would be quite high because noting the status of the probable suspected portal vein thrombus and as well as the
So you may want to go ahead with liver resection, surgical resection in this patient.
If the entire patient and the doctors decide to
So
accept
technically it is possible because it is in 5, 6, 7 and 8. So the whole right lobe. You would like to do a volumetry at what FLR? At what FLR would you want to go ahead?
This is a early cirrhotic, if we suppose
Yes,
it to be,
yes.
would obviously like it to
Yes.
be more than 40-50%.
Yes, Pari, you wanted to add something?
See, if you see the images, there are several subtle findings which would make me not consider resection. One, it's the left lobe doesn't seem to be too big. If you see the artery is very hypertrophied, which is indirect indicator of portal hypertension and a lot of fibrosis inside. The left portal vein appears to be dilated. If you see along the splenic hilum, maybe there is an indicator that there are a lot of collaterals. So I probably will not be thinking in terms of resecting this resection of this patient.
Okay.
And I just wanted to mention that in such patients, even I would not be very keen to offer TAR. Because what we have seen is this is a diffuse tumor. There is not going to be one single vessel which is going to be supplying these tumors. There's going to be a bunch of vessels supplying. So what the radiologists end up is, radioembolizing whole of the right hepatic artery. Everything seems good, but after a few months, we have seen that these patients all come back with severe atrophy of the right lobe, and they all decompensate. They don't decompensate immediately after TAR. After a couple of months, we've seen that the whole right lobe gets totally atrophied. So TAR is probably not going to be what I'll recommend. I'm not going to recommend resection either.
So what will you
SBRT is what I will discuss with my radiology colleagues to see if this patient can undergo SBRT safely.
Okay.
If that's also not an option, then probably just palliative chemotherapy.
Nanoatinib.
Yeah, lenvatinib or the newer therapies.
Anand, if I say you want to resect this, you are offering care of low cost and resection, again not hugely expensive, surgeon led. So would you resect, and if you do you consider in calculating the FLR, do you minus the tumor volume out of the right lobe volume, or you just calculate the FLR as only the left lobe volume, including the tumor volume?
No, we'll take off the tumor volume certainly, and if whatever vascular outflow, inflow we are going to remove, that will go obviously along with that, but we'll subtract the tumor volume. Now, ours is a surgeon-led program and cost being low, but the problem is if they have post-op liver failure, we had it. We won't be able to treat any other patient for that month.
So point well taken again for my younger colleagues. Wanted to mention that when such a large tumor is there, when you are calculating the FLR, you need to subtract the tumor volume from the total liver volume, and then you actually calculate the FLR. So in this patient, the FLR was roughly about 65%. And just to save on the time, I wanted some more discussion on it. So what we did is we went ahead with a diagnostic laparoscopy in the last month itself, 15 days ago. Did not find any extrahepatic spread, proceeded with external laparotomy. And in here, we went ahead with an anterior approach performing a right hepatectomy. So this was the post-operative scan. There was a small doubtful lesion at the margin, which we did an intraoperative ultrasound. We like to confirm, as rightly pointed out by Pari. So we tried to remove that as well, that nodule, and we sent it for histopath. So The segment 4A nodule was not a tumor, and obviously that was a large multifocal HCC with satellite nodules involving the major branch of the right portal vein, right hepatic vein as well, and directly invading the gallbladder fossa. So again, as all the other colleagues pointed out, not a good option. Now, but I wanted to point out the various criterias, and I'll come back to the further discussion on this. There are many criterias. All these criterias, Milan, UCSF, ASAN, up to 7, Toronto, they all look at 5-year survival, which has to be more than 50%. And most of these criteria, stringent, specifically Milan, has given an excellent outcome beyond 75% to 90% survival at the end of 5 years. There are various criteria, and you've already heard Professor Lerout's lecture in the morning. There are various trials going on where they would want that Milan criteria is a bit restrictive criteria, and they would want to expand this criteria. So they even after post-transplant, there are some trials which have gone and have come out with the risk model, that which model will give you a higher risk. Most of these are post-LT, because that gives you the correct histopathology of the tumor. But there is one trial, moral trial, which had included the pre-liver transplant the parameters, in which AFP again was a major parameter being included. If it is more than 200, then it definitely signifies a poor outcome and becomes a very high risk. So all these criteria tell us that it's a mix and match of the tumor, the size, involvement of the vessels, and all these criteria will help you to come out whether these patients are at high risk in developing post-transplant recurrence or not. BCLC, they have come out with a good change in the last decade. They have revised their guidelines, but according to me, still they have not included. If you look at the guidelines, they include only the early performance or a good performance status. They don't include child's B. So if you look at the first case which we presented, was a child's B decompensated disease within Milan. If you look at only the BCLC criteria, then they actually would not be treated. Yeah.
A revision has been published this year.
Sorry,
last
revision
month.
Again.
Yeah.
So there are revisions happening. A lot of people consider the Milan criteria too stringent. Metro ticket has been there for last decade. The further you go, the concept is the further you go, the more you pay the fare. So there are various criteria within Milan. Fantastic survival, 75 to 80%. If you go further away, then like Tokyo criteria, based on the tumor size, then the survival comes down from 35 to 50%. So again, looking at the various other tumor markers, there are again Metro ticket itself, Mazzaferro's group has come out with this publication a couple of years ago, where you add the number of tumors with the AFP. So you adjust the AFP adjusted with the size of the HCC. So the larger the size, the higher the AFP, the poorer is the outcome. So they divided AFP into up to 100, 200, 400, and then and beyond 400. So the further you go, the poorer the outcome is. So again, just wanted to mention the data at Gangaram. We have done about 146 patients. We do go up to UCSF in our settings, and at Mahatma Gandhi we have done about 43, of which 32 I've been part of. Two patients were transplanted, one DDLT and one LDLT. Fortunately, this being the first transplant for HCC in the whole state of Rajasthan, and both these patients are doing pretty well. Wanted to ask Professor Lerout, do you have any, like the third patient we had presented, we did resect, and if this patient comes back with recurrence tumor in the remnant liver, what is the role and what is your idea of offering transplant him at that point in time?
Yeah. So if I understand well, your question is, someone has a resection and then he has a recurrence. Is this a question?
Yes. So we can also include the salvage transplant. So we are talking about salvage transplant and how effective is it in comparison to offering transplant upfront?
Yeah, the transplantation upfront, logically and theoretically, has always a better result. And again, there is a lot of confusion in the literature. There are papers about salvage transplantation showing that the patients have a good outcome. And this is true, but the problem of these papers is that about 1/3 and even more of the patients never come anymore to transplantation because the recurrence is far outside of Milan criteria and even sometimes extrahepatic disease. So it means, in fact, that patients who are the best candidates for transplantation, who got a resection, when they recur, they can, of course, be transplanted. But the reality is that a lot of them, up to for sure 35%, are not amenable anymore to transplantation. So it means that you lose 1/3 of your best patients. And I think this is again something that should be straightened out in the literature. There have been several papers about this from the French groups claiming that salvage transplantation is as good as primary transplantation. But Prashant Bangi from Delhi, from Medanta, when he was working in Paris, he looked at this, and this has been published in the Annals of Surgery, showing very clearly that primary liver transplantation, it's a much, much better outcome than patients who had a salvage transplantation.
So absolutely. So when we look at the intention to treat analysis, the primary transplant definitely scores above salvage transplant. And whatever the papers have come, there is a good amount of the selection bias and publication bias. So only those cases have been published where the salvage transplant has shown good results. Sorry, Pari, but we have the other cases as well. So I'll come back. So just to summarize, again, transplant is the best curative treatment for HCC with cirrhosis. It removes the whole tumor burden, treats the CLD, prevents recurrence. Within Milan and including UCSF, both seem to have got good outcome. If you combine it with the tumor markers like AFP, PIVCA, and tumor size, you may have the rough idea which patients to be included. Compared between LDLT and DDLT, LDLT has got some bit of advantages where it reduces the waiting period and thereby reducing the dropouts. There's less immunosuppression required. It gives a better quality graft and it can schedule your elective surgery. Coming to a very interesting case sent by Dr. Vinay Kumaran from US, we don't do, and at least in India, we do not have experience of doing liver transplant for colorectal liver metastasis. So this was a 45-year-old female presented with synchronous sigmoid CA with multiple liver metastases, received a neoadjuvant chemo with Folfox and Avastin. Sigmoid resection done in 2019, suggestive of a PT3N2A lesion on histopath. And there were multiple lesions on MR. Pari is very keen to do MR at our center, whatever you are comfortable with, either an MR or a CT. We prefer a CT, but MR is a good modality, contrast enhanced, which my colleague has already pointed out. It's a good modality to pick up the lesions. So if you can see, there are multiple lesions seen in the liver. And there's a whole list which I will not be wasting time on. So all these segments, you look at 2, 4, 7, 8, all these segments are showing lesions. Continued chemo, they did a right portal vein embolization because the left lobe volume was less than 30%. Further MRI done, did not show any evidence of local recurrence in the pelvis. Again, most important point is you need to check. You have heard a lecture from Professor Azulay regarding the LT for CRLM. So there is no local recurrence. CEA, however, was 230. They performed a right hepatectomy with a wedge resection of lesions in the left lobe. The right hepatectomy showed a metastatic adeno-CA. Liver, again, there is another medial margin showed metastatic adeno-CA, but there was carcinoma present at the margin. The other segmentectomy also, which they did, segment 2, again showed margin, which was inked with cautery, was positive. So they continued chemo and they again did scans which showed still existing multiple lesions between right hepatic vein, IVC, segment 3, segment 2. All these lesions were still existing. However, with the treatment of with the so-called now adjuvant therapy and a neoadjuvant targeted liver therapy, the CEA came down to 60. PET did not show any extrahepatic disease. They offered LDLT from Domino. The patient had heterogeneous familial hypercholesterolemia And this patient's liver was eventually offered to this patient. So the patient received a whole liver, and the whole liver transplanted of the domino was given to the patient who had colorectal liver metastasis. So I'll come to Vinay, but before that I would like to ask my Indian colleagues and colleague from Nepal as well, do you have any experience of doing liver transplant for colorectal liver metastasis?
No.
No? Professor Setan? Not yet. Professor Leroux, in Belgium, do you do living donor liver transplant or DDLT for what that matter in CRLM?
Yes, when I was still clinical active, I did, and I am now seeing all the patients which are selected in the European Transmed study. So the problem of transplantation for colorectal metastasis, it's an easy operation technically, of course. If you have a living donor, it's not a big problem because they have no portal hypertension. But the key is the selection of the patients. So in this patient, I don't know if you did it, but probably yes, you need to have patients who are KRAS and BRAS negative. That's important. The localization of the primary tumor is important. We know that metastases from right colon do very bad after transplantation. But there are many now already factors known that allow you to select, not optimally yet, but almost better, the patients for transplantation. So in these patients, I've seen the CAA was 60 at the moment of transplantation. You must have the evolution of the CAA and the CA99. You must have it. You must have a good pre-transplant thoracic evaluation, because the Oslo experience showed very well that you can miss small lesions just before the transplantation when you go back to the history of the patient when there is a recurrence. So all these factors play a role. Transplantation will surely play a role in the treatment of colorectal metastasis, but it's, as usual in all these metastases and transplantation, is a question of very good selection. The delay between the resection of the primary and the transplantation plays a role. The number of lymph nodes that have been taken out during the primary operation are important. You need to have, in fact, 10. And so these are all criteria in the Transmed study. If you don't comply with them, you cannot be transplanted.
Yeah, so the nodes also were removed and did not show any lesion, and the whole liver did still show multiple foci of metastatic adenoCA. So there are various trials, SECA1, SECA2, and the other trials. Professor Vinay, would you like to come online and say what are the criteria you would like to select for liver transplant for colorectal liver metastasis?
So we use the Oslo score, and in fact, we were in touch with the Oslo team. So we were discussing the patient with them from the beginning, and the patient did meet their criteria. So it was more than 2 years from resection of the primary. The CEA had come down to less than 80. The combined tumor size was less than 5.5 centimeters. So it met the Oslo criteria, and we were sort of in contact with them, and they agreed that we should do a transplant in this case.
So what Dr. Vinay is trying to point out is, since we in India, we don't operate, but there are various centers, and it actually started from Norway, who had an abundance of deceased donor, and that's how they started offering this. So over the years, there are various trials which have come up, and still there are many ongoing trials where they are doing a rapid trial as well, where you do a partial resection of the liver, remove and implant segment 2 and 3, and then go ahead at the delayed stage, do a hepatectomy. But again, in all these scores are very important. So if they meet the Oslo score, the metabolic tumor volume, and the FONG clinical risk score, if the scores are positive or favorable, then the outcome would be favorable. And in these cases, you should try and select the patient. So just put up a chart of which cases would be poorer outcome if you select. So for colorectal liver metastasis, if it is a right-sided tumor, undifferentiated on histology or signet cell carcinoma, has extrahepatic disease on imaging, or the lesion is more than 5.5 centimeter, or the metabolic tumor volume more than 70 centimeter cube. The markers, what Professor Leroux was talking about, BRAF, again, that's a poorer indicator. If the CEA level pre-transplant is more than 80, if the disease is still progressive on the neoadjuvant chemo, on the RECIST criteria, if the response is less than 10%, and if it is less than 2 years from the diagnosis of the primary tumor, then in these cases, the outcome may be poorer. Just also wanted to mention, since we are including all the other liver cancers, for neuroendocrine tumor also, if there is no portal venous drainage of the primary, again, there's a poorer outcome. I'm talking about neuroendocrine tumor only. Poor differentiated or undifferentiated, that is grade 3 and 4, extrahepatic disease or or hepatic tumor involvement more than 50%, Ki67 more than 10%, progressive disease, all these will have a poorer outcome in a neuroendocrine tumor if you select them for liver transplantation. And if you have not removed, or it is under a year, you have done a primary removal of the primary neuroendocrine, in these cases, do not proceed with liver transplantation. So there is an IHPBA consensus guideline, but again, they are very stringent about selecting. This was published in Lancet in 2021. So if there are extrahepatic disease, they obviously rule them out. If they do not fulfill the molecular criteria, again, they are selected out. Based on the synchronous or a metachronous disease, they decide whether you should go ahead with resect the primary and then bridge again for transplant, wait for minimum 6 months, see the response, and then you go ahead for transplantation. So we had a case of cholangio as well, but I guess in shortage of time, we'll not go to the cholangiocarcinoma. And thank you very much for joining us, but we would be happy, me and my panelists would like to take any questions. Any one of you would like to ask any questions to either of the panelists or to us, we'll be happy to answer those queries. No? So I guess we have had a good long discussion, and hopefully they'll all go back with clearer mind when to do transplant in HCC. So thank you very much, and I'll call my colleague to take over. Thank you.
Thank you, sir.
I would like to thank all my panelists present as well as online, Professor Vinay and Lerud, Professor Seten, Anand and Pari. Thank you so much.
Thank you. Such a nice discussion. We'll be having a tea break for 10 minutes and we'll again resume for the next session, 4:15. What?
வந்து ரெசிப்ட் மைக்கேல் வெரி ஹாப்பி மைக்கேல் அனுப்ப மாட்டாங்க பிடிபிடி மட்டும் போட்டோம் நல்லா குறைஞ்சதுக்கு
Good evening, everyone. For the next panel discussion, I would like to invite our famous, renowned gastroenterologist of India and Professor and Head Department of Hepatology, Dr. Vivekanand Saraswat sir, and request you for the panelists for this session.
Well, good afternoon. In the interests of punctuality, even as we are joined by the other delegates, I think we will begin our session on the panel discussion of the non-surgical management of hepatocellular cancer. And it is my privilege to introduce and to invite our panelists onto the dais. I request Professor Diane G. Duda to please join us on the dais. Professor Duda gave a fascinating lecture this morning on the HCC tumor biology. He is Director of Translational Research in GI Radiation Oncology at the Massachusetts General Hospital in Boston and Secretary General of the International Association of Surgeons, Gastroenterologists and Oncologists. After training in Romania and at Tohoku University in Japan, and he did postdoctoral research at the MGH in Boston and joined as a faculty member at the Harvard University. We welcome you, Dr. Duda. I also invite Dr. Lalit Mohan Sharma to join us on the podium. Dr. Lalit Mohan Sharma is a senior consultant in medical oncology at the Mahatma Gandhi University of Medical Sciences and Technology at Jaipur. Yes, okay. Earlier he was senior consultant at the Birla Memorial Cancer Hospital in Jaipur, and he has done extensive fellowship experience at the National Cancer Institute, Maryland, at the MD Anderson Cancer Center in Texas, and the Tata Memorial Hospital in Mumbai. He is also Europe certified in medical oncology. I welcome Dr. Neeraj Rastogi. Neeraj, please come onto the podium. Dr. Rastogi is working presently as a professor in radiation oncology at the Sanjay Gandhi Postgraduate Institute in Lucknow. After qualifying from the King George's Medical College in Lucknow and at the All India Institute of Medical Sciences in Delhi, he joined the faculty at SGPGI in 1998. Dr. Rastogi has special interests in GI and urogenital radiation oncology. I welcome Dr. Nikhil Bansal. Nikhil Bansal is an assistant professor in the Department of Interventional Radiology at the Mahatma Gandhi Mahatma Gandhi Medical College and Hospital. He has trained in interventional radiology at the Mahatma Gandhi Institute of Medical Sciences in Wardha. He's an expert in interventional radiologic procedures, including TACE, TARE, RFA, microwave ablation, and other procedures that we do for hepatocellular carcinoma at our center. And I'll like another chair, if we can have one, and invite Dr. Karan Kumar also onto the podium. Can somebody help us with a chair on the podium, please, on the dais? Karan is an assistant professor of hepatology and liver transplantation at the Mahatma Gandhi Medical College Hospital. He is trained at the BJ Medical College in Gujarat, in Ahmedabad, and at the Institute of Liver and Biliary Sciences in New Delhi. He's a very capable, dynamic, and a very well-informed hepatologist who is committed to providing the best care for his patients. Finally, last but not the least, I would like to welcome Professor Shiv Sareen online as the panelist. Introducing Dr. Shiv Sareen to an audience in Jaipur, in India, in fact anywhere in the world, is almost like carrying coal to Newcastle. But for the sake of completing formalities, I'd like to mention that Professor Sareen is the Senior Professor of Hepatology at the ILBS, besides being the Chancellor, the Director of the Institute, and the founder of ILBS, a one-of-its-kind institution in our country. He is also the director of the WHO Collaborative Center on Chronic Liver Disease and Viral Hepatitis at ILBS, and the president of the National Academy of Medical Sciences in India, an adjunct faculty at the Molecular Medicine at the Jawaharlal Nehru University in Delhi. He has over 750 publications, 13 books, 19 book chapters, 20 major international and national guidelines to his credit. His list of achievements and his leadership role that he has fulfilled in gastroenterology and hepatology is too extensive for me to be able to do justice to it in the little time that we have. With these few words, I welcome Professor Sareen on the panel, and I think we will move into our panel discussion on the non-surgical management of hepatocellular carcinoma. Basically, I'll be presenting a couple of cases, and we'll take up issues related to management decisions in managing these patients. So these are our panelists whom I have already introduced to you and who are on the chair here. Our first case is a patient with an unresectable liver cancer. I'll briefly introduce the patient. This is a 62-year-old gentleman who was working with the electricity supply undertaking in Jaipur, presented to us with fever and abdominal pain, which was of short duration, just a couple of 4 or 5 days prior to the onset hospitalized presentation. He developed these symptoms. There was no jaundice, ascites, GI bleeding, or encephalopathy. He had been habituated to using alcohol and had the severity of his alcohol use is categorized by the Audit C score, 8 out of 12, which means moderate dependence on alcohol. He was also slightly obese. BMI was 29 kilogram per square meter, but he had no other comorbidities. Before he came to us, he had been evaluated at a peripheral center where an ultrasound of the abdomen had shown a hypoechoic area in the right lobe of the liver, and there was thrombosis in the right branch of the portal vein as well. The liver echo texture was reported as slightly coarse, and this hypoechoic lesion was labeled as a possible liver abscess in this patient. With this background, he reached us at the Mahatma Gandhi Hospital. So alcohol use, short duration fever and right upper abdominal pain, hypoechoic lesion in the liver along with the right branch thrombosis and coarse echoes in the liver. His blood tests are shown here. Apart from mild anemia, a deranged coagulation, and a significantly elevated alkaline phosphatase as shown in this slide. His other tests were unremarkable, except that when we did the alpha-fetoprotein here, it was found to be elevated 62 international units per ml. So he underwent further imaging at our center, and a triple phase CT scans, both the arterial and the venous phases, basically showed a diffuse lesion in the right lobe of the liver, which presented typical characteristics of enhancement, early tumor enhancement and early washout, as well as a thrombosis in the right branch of the portal vein, which is also seen on the PET CT scan, which showed similar lesions, extensive infiltrative lesion in the right lobe of the liver with a FDG avid lesion in the right of the thrombus in the right branch of the portal vein was also visualized. So with this workup, we now, with this brief background, we were able to make a diagnosis of a large infiltrative hepatocellular carcinoma in the right lobe with tumoral portal vein thrombosis. This qualifies as an advanced hepatocellular carcinoma according to the Barcelona Clinic Liver Cancer grading system. It would be grade C. In addition, this is on the background of a compensated ethanol-related liver cirrhosis with portal hypertension, good liver function, good performance status, and elevated alpha-fetoprotein. With this background, my first question to the panel would be that probably the panelists would agree that this patient with advanced cancer is really not a candidate for surgical management. We have had a long discussion and elaborate discussion on surgical management in the previous session, but with the macrovascular invasion, it's probably is a patient who will not qualify. But we have a host of non-surgical options available for this patient, which could be locoregional therapy, chemoembolization, systemic internal radiotherapy, or an SBRT, stereotactic radiotherapy. Systemic therapy options, including multi-kinase inhibitors like various tyrosine kinase inhibitors, are available. Immunotherapy and its various modalities are available, and there could be others. And finally, one could bring up the option of combining loco-regional therapy with systemic therapy to obtain best effects. I know you have a short time with us, sir, but is Professor Sareen on the online? I would request you to offer your views and thoughts on what are the options that we can exercise in this patient here. Has he joined online? Can we Okay, so while we wait to get him online,
no, sir, he is there, sir.
Oh, sir, you are muted. Could you unmute, please? I hope you're able to hear us, Dr. Sareen. Well, I see. I think we are probably not going to be privileged to have him with us. So, he says on that chat that he has to leave. So while we wait for him, I think this question I'd throw to our panelists. Dr. Sharma, Lalit Mohanji, what do you think? We have these various options here, loco-regional, systemic therapy, and a possible use of combinations which is now coming in. What would your thoughts be? I mean, in this patient with portal vein thrombosis and a tumor, but good liver function, what would you like to propose?
So I'll propose a TACE and followed by systemic therapy, which may be in the form of immunotherapy or multi-tyrosine kinase inhibitor, but not a single modality, but dual modality I'll prefer. And of course, before taking final call, we will discuss in our multidisciplinary tumor board. We'll take opinion from our intervention radiology, surgical colleague, radiation colleague, and all.
So, what is your experience with such an approach? I'm sure you must have treated similar patients earlier. So, if you were to use TACE, what would be the order? Would you use TACE first, or you would like to start with immunotherapy? And what would be your endpoints what would be the outcome you would expect with this combination?
So commonly, sir, like previously in early 2000 or when the sorafenib was only available, we have treated them with single agent drug of sorafenib without significant improvement. But now since TACE is available to us also in Jaipur and in our center also, so after use of TACE, we are realizing that once we use TACE, there is local hypoxia along with the TACE, and there is antigenic release also as a result of trauma to the tissue. So after that, the immunotherapy works better as compared to without antigenic manipulation or without TACE. And the tumor load is also probably reduced with that.
So you would propose that we use TACE first,
yes,
assess the response to TACE, and then simultaneously or soon after that initiate. Rather than tyrosine kinase inhibitors, you favor the use of immunotherapy. Are there any data or literature or reports that you would like us to know about regarding the combination of these modalities?
Yeah, in fact, that IMBRAVE 150 has been very, very popular for last almost two years plus. And Bev-Atijo has been used very well, and the overall results were very encouraging. But again, it's not the gold standard. As of now, there is a lot of confusion about what to use. Recently, there has been one Chinese trial of more than 300 patients published. They have used TACE followed by lenvatinib, and they are also showing good results. So it all depends on which type of patient we are treating, how much are the logistics.
I think we have a clear-cut situation that this is a patient. TACE would be a problem here with at least it's not a complete main portal vein thrombosis, but there is portal vein thrombosis. So in this situation, how would you consider the possibility of SIRT over TACE? Would that be an option you would like to consider?
In fact, that decision I leave to my IR and the radiation people.
Okay. So I think, Karan, you are familiar with the current literature in this area. So what are your thoughts? Combination or individual therapies? And if so, what is the order?
If we go by the guidelines, the BCLC 22 is a BCLC-C candidate.
Yes.
For that BCLC-C, only treatment recommended is systemic therapy. As per the BCLC criteria, the local regional therapy, whether TACE or whether SIRT, it is recommended only as a bridge to transplant or as a downstaging modality. But as Lalit Mohan sir has rightly pointed out, there are many studies which are coming and showing that combining the two different modalities which have different mechanism of action together gives a better result. Even if a patient is a non-transplant candidate, the overall survival do improves by combining these two modalities together.
Indeed. I think, as we are well aware, guidelines always stay a bit behind the cutting edge research that goes on, because I think the sufficient volume and experience from the different parts of the world is required before these therapies qualify for reaching guidelines, whether it's ESMO or NCN or European guidelines. But current data does suggest that combination of a loco-regional therapy, the choice would then be between TACE and SIRT, followed by systemic therapy, should be an option in this patient who is well preserved and has a good liver function. So among the systemic therapy agents which you would like to use in this combination, we have various agents like the tyrosine kinase inhibitors. You have nivolumab, pembrolizumab, the PD-L1 inhibitors. You have a combination of PD-L1 with tyrosine kinase inhibitors. There are trials that have been published with these combinations. And the one that Dr. Lalit Mohan just referred to, atezolizumab with bevacizumab, which is a combination of a PD-L1 inhibitor with a VEGFR blocker. And we now also have, I think recently, very recently, I think in June this year, we have had a publication of a combination of a PD-L1 inhibitor along with a CTLA-4. All these are immune checkpoint inhibitors, the tremelimumab and durvalumab combination. So among these combinations, Dr. Lalit, would you like to tell us why would you prefer one over the other, or which ones are the ones that are likely to be most promising? TKIs alone or combinations?
No, I think, sir, we prefer the lower two, atezo plus bev or tremi plus durvalumab. The rationale of using this, like atezo along with IO plus VEGF inhibitor, given is that once you do any tumor manipulation, there is hypoxia and there is the vascularity is compromised, or there is more of new angiogenesis. So at that time, the bevacizumab works better as compared to in other tumor. And atezo, of course, works as PD-L1 inhibitor. So that remains the rationale of use of atezo plus bev. And previously, like single agent, IO has been used, nivolumab and other drugs, but none of the single agent drug has been proven to be of significant benefit. So bev atezo, and the recruitment in this particular trial was well ahead of the time also, looking to the good response. So this got very popular. And the same thing happened with the PD-L1 plus CTLA-4, the tremi plus durvalumab. Like durva single agent has not been of much significant promise, and if we add tremi along with durva, so there is dual mechanism of action on the lymphatic system, in fact, on the lymphocyte. So on one side, we are doing some primary effect by putting action of the tremelimumab, which may be a single dose or which may be up to 4 doses maximum, depending on the which trial or which head we are taking. So that along with the durva for a prolonged period sounds better. So yet at this level, we are not sure that out of these two combinations, which is better, but of course, both have been found to be significant.
Yes, I think atezolizumab, bevacizumab has now been included among the first line therapeutic agents for HCC, along with the lenvatinib and sorafenib, which were already there. And I think the same, we are expecting tremelimumab and durvalumab also to be included as first line therapies, because they have proved highly effective when used in patients with advanced HCC. So Karan, could you please give us some more details if you are able to regarding the both the IMBRAVE trial as well as the Himalaya trial, on the basis of which these two studies have come out.
Yeah, IMBRAVE 150 trial was published in NEJM in 2020. It was a RCT in which there were two arms. Patients were randomized into two groups. So advanced SCC, where in one group they were sorafenib, other group they were taken up for atezo and BAVE. The patients were followed up, the median follow-up was for around 8 or 9 months. The good part in this trial was the survival, overall survival at 12 months was around 70% in this atezo-BAVE arm as compared to 35 or 40% with sorafenib arm. So with this preliminary results only, these trials and the drugs were approved for the came into the market and came for the use. Later on, when the trial was completed, it was found that the overall survival with atezo-BAVE was 18, median overall survival was 18.4 months as compared to 13 months with sorafenib. And objective complete and other response rate were around 70% with atezo-BAVE group as compared to sorafenib, which was having this objective response rate of around 39 point something percent. Regarding this
and
second
tumor-free, I think the no progression of the tumors, stable tumor duration also was significantly increased with this combination. Exactly. At the end of trial, many patients had still not shown tumor progression on this therapy.
Disease control rate was better with atezo-BAVE.
Yes.
In the second trial, the Himalaya trial, in which they randomized the patient in 3 groups. One was this TRIDE group, single dose Tremeli with the durvalumab versus durva alone versus sorafenib. In this trial, the overall survival and other things were all comparable in the this progression-free survival were comparable in all the 3 groups, whereas overall survival was significantly more in the STRIDE group, that is a single dose Tremeli with the durvalumab. So this has been recently approved for use of HCC just last month. So last month only the STRIDE have also been recommended as a first-line treatment for HCC.
Yes. So I think we do have promising and evidence-based data that these are very effective modalities. But specifically in our patient with advanced HCC, including portal vein thrombosis, any ideas? Yes, Dr. Sharma, is anything you'd like to add on what
So
would be the
just
results
wanted
in
to
this?
add that in all these IO trials, immunotherapy trials, subset of patients which are responding, the tail is in fact flat, and these responding patients, they keep responding for a prolonged period. And that happens with most of the IO agents in lung, head, neck, urothelial cancer, and same thing applies here also. So in fact, there is a strong need to identify the subset that which patient will be responding to this or which biomarker will be most effective to predict the response is the area lacking.
Yes, I think I'll come to a related question as we move along. So while this is in general about advanced BCLCC or beyond tumors, this includes the advanced the BCLCC group will include those with macrovascular invasion and spread like the portal vein invasion, and those with extrahepatic metastases. So from these studies, are there any subset analyses that mention experience with these subsets when the disease has spread beyond the liver, and especially with macrovascular? Or I think we await further analysis of subsets and downstream results from these trials. I think in the preliminary initial studies that have been published so far, the subset analysis is not complete, but we would look forward with interest because our patient happens to be, this and the next one, happen to be in the latter category with macrovascular and extrahepatic spread. So I think Dr. Lalit Mohan has told us twice about why we need to combine and what are the benefits of combining loco-regional therapy with systemic therapy, and as well as the answer that first you give loco-regional therapy, TACE or TARE, followed by systemic therapy. So I mean, this is conceptually very attractive, but at least till date there are no studies published, there are no data or trials that substantiate the validity of this approach, that is combining LRT with systemic therapy. So would anyone of here on the panelists, would you have some preliminary experience or some idea about ongoing studies or trials that are being planned in this area, to which would be able to tell us that are we indeed on the right track and combining this will improve outcomes? Yes, sir.
Yeah, so again, I'm a scientist, so don't listen to anything I say, but in terms of recommendation of what to do for the patient. But I think we've been very interested in looking at SBRT, for example, because you said there's good liver function. So there's very, good potential, and some studies in Germany, especially, they are irradiating very large tumors with very good results. So at MGH, we have a trial where this patient could enroll potentially for a combination of SBRT with bevacizumab, which, as you heard, is the first line of choice currently. So I think that would be the study that we're doing right now. Of course, we don't have the data. It just started a few months ago. But I think this would be one of the exciting ones, and also with TARE and combination of bevacizumab, same kind of concept. But again, it's ongoing.
So already ongoing trials on this area. Right. Yes, Dr. Neeraj.
But for starting the thinking of the SBRT, we should have at least 1/3 of the liver should be non-tumorous. And the other thing is indocyanine green should be less than 10% retention in the liver. If these two of the criteria is there, then we should think of the SBRT, and SBRT can also give the very good local tumor control. But it is useful in the Barcelona stage B and C, both the group, and with the normal liver function test, especially the child took A and B. So SBRT along with the systemic therapy may be a good option in this patient.
So you're talking of now SBRT, that is, you're talking of good liver functions, child PUA, good, very low ICG retention, indocyanine green retention, and tumor burden being less than 1/3. So, which is again something that we find is suitably applicable to our patient. All these three things are met: CPBA and a good performance status, as well as the tumor sizes within that range. Okay, I think I'll come to say some more SBRT questions for you later down as you move along. So I think maybe Karan, I'd like your thoughts on, I think you are probably part of this multi-center trial that Dr. Duda has referred to. Yeah. Could you give us some more idea about what is the rationale and the preliminary data, why it is expected to work?
It is the same trial from this TRIDE group, the Tremeli Durva group. Now they are combining this Tremeli Durva, that is a TRIDE, single dose Tremeli and regular interval Durva with TACE. They are in this trial, but instead of advanced HCC, they are including intermediate stage HCC. So for intermediate stage HCC, the standard of care is TACE, as of now as proposed by BCLC. So they are combining one arm TACE alone versus TACE plus STRIDE versus TACE plus lenvatinib. So it's a triple arm study. It's a multi-center study which is tend to recruit around 500 odd patients all over the world. Our center is one of them for the patient recruitment. Result will come in later 2025 or somewhere, 26.
Right. So, but there are no preliminary data to justify or to show us that, yes, case reports or case series showing good results of this combination?
Yeah, there are case series and some non-randomized trials from this Eastern Japan and other countries. They have shown that combining TACE with TKIs give better results than TKI or TACE alone. But they are all non-randomized and based on some observational and retrospective data studies only.
Any reason why intermediate group is being chosen for this rather than the more advanced group, which actually needs these therapies more than, I would likely, results will be better in the intermediate, obviously, but the ones who really need such therapies are the advanced group.
Yeah, very true, sir, but still there are no trials in advanced group.
Dr. Duda, would you have any thoughts? Why would you not include advanced HCC and focus on the intermediate HCC only?
Well, I think it's like you said, the results would be better, so they want to. There's the bias. I mean,
okay.
I think
planners have their own
biology.
logic and rationale. Yes, okay. Right. I think a word on immunotherapy adverse events. So immunotherapy, while it's very attractive, it is as single agent, it is proving far more effective and efficacious than the other available modalities. Nevertheless, it is not exactly a condition free of side effects. Immune checkpoint related liver toxicity, which is called immune related hepatitis, has been something that has been noticed in this group. So Dr. Sharma, would you have any experience or suggestions? You must have used these agents in other settings also.
So I think the immune checkpoint inhibitor side effects, they have a different class effect which is not seen with the current cytotoxic chemotherapy. Like about the immune checkpoint inhibitors in HCC, we see transaminitis, and again we need to be very clear that the transaminitis is related to the immunotherapy, or it is related to the liver dysfunction, or it is related to the HCC per se, or cirrhotic liver. So we need to be very clear. So transaminitis is one thing. Other than that, fatigue, asthenia, hypoglycemia, the hyperglycemia, hypothyroidism, all these are common, along with GI toxicity. And for some reason, in fact, not very clear, but it has been seen that if you are using the immune checkpoint inhibitors for the GIT part, the GIT side effects are more prevalent. And if you are using it for the lung, then you see pneumonitis or interstitial lung disease as more common, in fact.
Okay, that may be the focus of my clinician who's following. He picks up his organ and abnormalities more often. Yes, Dr. Duda?
Yeah, one thought that I have, at least conceptually, is that you have to reduce the dosing. I think, with tremelimumab, one very important aspect is that they only give one shot of tremelimumab, yes, and that actually worked better than chronic administration.
Regular administration.
CTLA-4. So it's exactly as you're saying, there's the toxicity. So that trial beautifully showed in the phase 2, the previous phase 2, that you may have superior survival while you're reducing the doses. So I think if we understand biology a little bit better, we may be able to avoid the side effects for the chronic administration, with, of course, less profit. But
so, Karan, how would you diagnose immune-related hepatitis? It kind of mimics autoimmune hepatitis, and if a person has that as his background disease and you have used this therapy, which you will be cautious about, but that is how do you diagnose it and how would you treat? Once you've diagnosed immune-related hepatitis, which at times can be grade 2, grade 3, can be quite severe. Yeah. And in fact, even liver failure can be precipitated.
So there are separate set of guidelines recommended to diagnose for this immune-mediated, checkpoint-mediated this side effects. There is a separate checklist in which for the commonest one are the thyroiditis, pneumonitis, maybe colitis also, or as a hepatitis. For that, the AST, ALT, if I would talk about the immune-related hepatitis, the criteria are AST, ALT elevation more than 5 times the upper limit of normal after giving last dose of immune checkpoint inhibitor within 3 weeks. And for that, the treatment is first is to decrease or stop the immune checkpoint inhibitor. Second is that there is a use of steroids. And in the this last stage, there is also a recommendation of using JAK2 inhibitors for immune-mediated this hypersensitivity reactions.
I think to add to that, one often has the dilemma of differentiating from autoimmune hepatitis and IRH.
Yes, sir.
And their autoantibodies would generally be negative in IRH while they are positive in your autoimmune patients. And biopsy will not show you features of typical autoimmune hepatitis, only liver injury and some DILI-related features may be present if you were to undertake a biopsy. So I think immune-related hepatitis needs to be borne in mind while we are doing this. And as has been pointed out, you would stop therapy for grade 2, grade 3 toxicity, or you can step it down. Can we actually reintroduce? The patient has been doing well. Tumor is actually regressing, but you are landed with immune-related hepatitis complications. So after you've treated steroids, LFT have reverted. Any thoughts on whether we can resume checkpoint inhibitors, Karan?
So in the trials, they are not used again. The patient, once they develop side effects, they are out of the trials. So as
Agreed. Trial data will never give you this. There will be dropouts or unsuccessful. But yes, in real life, people have talked about going back to using it more cautiously, especially if you have had a good initial response. I think Dr. Sharma wishes to add something to that.
In fact, sir, the common concept is that rather than reducing the dose, we increase the gap between the two doses.
Okay.
And second thing, like recently Tata Hospital Mumbai has published and they have presented their paper on head neck cancers, and they have used nivolumab, and that was 10% of the recommended doses. So the recommended dose is 3 milligram per kilo in head neck cancers. They have used 0.3 milligram. So that has reduced the cost also to 10%. And they were able to document that a small around 165 was their sample size. And they documented that the response is non-inferior to the standard dose. So that also remains one important area where we can extrapolate the data and more
I
patients
think
can
we
be
are all
benefited.
following whatever are the published trial results, trial doses, and we are experiencing similar side effects.
Yes, sir.
We keep on talking again and again that our Indian patients behave slightly differently. Yeah, generally their body weights are lower, so maybe lesser dosing may be effective. But I think there are no published studies or data from our country so far whether this strategy for liver cancer, I'm talking of liver cancer. You mentioned head and neck and other areas possibly, which shows us a lead that this is something that hepatologists and liver oncologists should be thinking of. Right. So finally, a quick question. We are, all the LRT therapies are generally regarded as downsizing, stepping down or decreasing the tumor burden to within Milan, within UCSF, so that eventually the patient is headed for liver transplant. The assumption being that these are not curative modalities, they will not achieve cure. However, with whatever data we have seen and published data, the one responder group, Dr. Lalit Mohan pointed out that you need to identify the responder groups. But those who respond very well. Their tumors may become undetectable, at least on your standard imaging modalities. So should we regard immunotherapy as just another downstaging modality, or do you see potential for it as a curative modality in these very difficult patients?
In fact, sir, it is difficult to define cure in these patients, but we have seen, in fact, a couple of patients in each one of us, like we see, in different indication, not in HCC, but like we treat more of lung cancer, head neck cancers, and other cancers. So we have seen, in fact, case reports or cases where after 2 years we have stopped and the patient is sailing through well for 4 or 5 years also. Recently, we had discussed one lung cancer patient who is still on immunotherapy, and now we have completed more than 4 years. That was stage 4 lung cancer, and the PET CT and other imaging suggests there is no evidence of active disease. We have presented one head neck cancer patient where very rapidly the surgery, radiotherapy, chemotherapy, everything failed, and finally we had put this patient. It was in 2017, so we had put this patient on single agent nivolumab that was available at that time, and we continued this, and within 6 months the whole tumor disappeared, PET CT was negative, and we continued that for 2 years, and now 1.5 years after completion of the treatment.
Exactly the question I was coming to. When you have response, you have tumor control, macroscopic spread is not there. How are there any guidelines, any ways to tell us how long should you continue? These are very expensive therapies for people from India. These are very expensive therapies. So while guidelines and recommendations may take time to emerge, but practicing clinicians who are managing these patients would have their rule of thumb guidelines. So why did you stop it at 2 years in that patient? Did you have any thought process there? Or
in fact, honestly, sir, because as per the American guidelines, there is no point that we cannot stop. We continue till the patient shows responding or develops untoward side effects. So this particular patient was a beneficiary of CGHS. So the CGHS was every time asking me that, tell me what is your plan, what is your plan. So every time I was writing that next 3 months we will give and then we will see. So there was some literature available that after 2 years in responding patient, we may stop rather than continuing with significant.
So at the moment, things are very anecdotal, but there are clear-cut cases which all senior oncologists who are followed up would have long-term responders. I think our last patient second patient I'll come to short quickly, is in that category, and that dilemma is we are facing, because I don't think, Karan, are you aware of anybody stopping immunotherapy in liver cancer?
Yes, sir. In fact, I have one patient who was treated with nivolumab earlier. After almost 12 or 14 doses of nivolumab, he had complete response. And after that, I stopped. He was, just as I told, he was a beneficiary. He got overage and beneficiary goes over.
Insurance decides whether you get the medicine or not.
So after stopping 2 years, he is disease free.
Fantastic. So these are exactly the points that Dr. Lalit made earlier, that we need more scientific and more tumor biology understanding of what is happening and why certain people are responding. And we need more insights. Obviously, as more such patients accumulate, we will move in that direction. Now, quickly, I think, Nikhil, you have been very silent on the panel. So you are the person who does our loco-regional interventions at Mahatma Gandhi. So TACE and SIRT, we are talking of our patient.
Yes, sir.
This patient, which had a tumor burden in the right lobe, there is a right branch of the portal vein was thrombosed, good liver function, good performance status. What will you choose, TACE and SIRT? What are the pros and cons?
Yes, sir.
In this particular patient, we can definitely choose both the modalities. But if we talk about the cons and the pros about the both the procedures, like as we can see in this particular case, there is a large tumor bulk is there, as well as the patient comes under the BCLC child C. And the third thing is there is a portal vein thrombosis, the VP4. So the preferable choice for this particular case is a SERT over the TACE. The reason behind is the chances of the decompensation of the liver in this particular case in the by using the TACE is more as compared to the TARE. The TARE has a more tumor kill as compared to the TACE. The patient has a less complications and more tolerance over the TACE. And in this particular case, if we prefer going for a TACE also, then we have to go with the minimized dose, not like 75 mg of the doxorubicin. So in this case, I prefer, if the finances is not the concern, then the SERT is the best option.
So insurance has its advantages.
Yes, sir.
If there is insurance cover that allows SIRT, you can choose that modality
Yes, sir.
over TACE.
It has a more tumor kill and a lesser
So what is the
complication.
effect of SIRT on tumoral portal vein thrombosis? We know, I think Neeraj will tell us about how SBRT works there, but with SIRT, do you get response on tumoral portal vein thrombosis?
In some cases, according to few literatures, the TARE can also can help in treating and recanalizing, decrease the tumor burden of the portal vein. But obviously, the SBRT has a better upper hand over the SERT in a case of the portal vein thrombosis. If we talk only about the portal vein thrombosis.
Any size limits? You saw this was a fairly large, I mean, almost two major segments of the liver were involved. So is in a patient with portal vein thrombosis, would there be a tumor size that you would be reluctant to treat, or that is not a factor?
Sir, there is no strict guidelines or any particular guidelines for the sizing of for going ahead with the TACE or the TARE, but the preferable in the majority of the cases, we prefer less than 50% of the liver volume. Or in a case where the LFTs and everything is fine, then we can move more little bit up to the 70%. But our choice is somewhere around the 50% of the
Or
liver
less
volume, sir.
of the tumor volume. And a quick word on the adverse events that you might have with the SIRT?
Majority of time, if we are actually for the generalized liver dosing, if it is less than 30 or the 40 gray, then the chances of any side effect or the disadvantage remains very less.
Liver injury particularly.
Yes,
Is
sir.
there a concern with liver
the,
injury?
With the advancement of the very fine micro catheters, we can go ahead with the very super selective cannulation, and with the 3D and everything in the cath lab which is being available. So chances of the misembolization remains very less, sir.
So Neeraj, can you tell us about how effective SBRT is for tumor control? You told us the eligibility of the patients for this therapy, and how effective is it for tumoral portal vein thrombosis?
Actually, first I just want to tell the side effect of the TARE, SIRT, because the SIRT is a yttrium, which is a beta emitter, and usually the SIRT usually gives a very high dose, and dose to the liver is usually the tumor is 250 gray, and the remaining liver should receive at least less than 150 gray. So the
This is for SBRT or SIRT?
This is SIRT.
SIRT has a penetration of millimeters, 2 to 3
millimeters.
millimeters. So you are unlikely to radiate the rest of the liver with the SIRT dose if it is, I mean, if 50% of liver is involved, the concern may be different. But like in our patient, you have only about less than a quarter, about 20-25% of the liver involved. Would the radiation to the rest of the liver be a major concern with SIRT?
So that is not a major concern, because the mode of the SIRT doses goes to the tumor. So remaining part of the liver is not much concern. But since the portal vein thrombosis is there, then the SIRT, which is microspheres are there, they may be accumulated into that area. Then it can produce the radiation-induced liver disease.
Yes, that's right. Thoughts are there, but I mean, this will accumulate only in the drained area. So this was only right branch of the portal vein. Okay, yeah. Right. Now tell us about SBRT and its efficacy as well as tumoral control, tumor PVT.
Actually, SBRT is a very, very localized treatment, and you can deliver a very high dose of radiation They usually in the doses of the usually 30 to 50 gray in 3 to 5 sittings. And usually it requires a very high imaging and usually respiratory gating. You should have at least 4D CT. So you have to deliver the SBRT in the particular phase of the respiration. Otherwise, lot of area of the normal liver will be irradiated.
Right.
And definitely two of the things one have to think of. One is if the tumor is near to any of the bowel, especially duodenum or any hepatic flexor, so then you can avoid. Otherwise, it can lead to the
injury to the bowel.
Injury to the bowel, especially perforation and the bleed.
And radiation hepatitis has been a concern with the SBRT in many studies.
So radiation-induced liver damage is very less because you are focusing the radiation to the very small area,
right,
with the image gating, with the gating of the respiration. So that movement of the liver with the respiration is not much there when you
right,
do
so you basically require a very sophisticated setup,
precision
very
radiation
experienced radiation oncologists who are able to calculate and deliver the dose precisely, plus all these things about radiation gating and of course very good liver function to begin with, which would probably mean that the fraction of patients to who are eligible for SBRT may not be very high.
Yeah. And usually the most of the time what we have treated in our hospital, usually the tumor less than 5 centimeter in size, up to the 3 tumors in the liver, and usually each tumor is treated in the separate setting, and 2-year local control is very high in the SBRT, and especially if you use the particle beam radiation therapy, which like the proton beam therapy, which is I think Professor Dr. Duda will be treating in the proton in the MGH, as well as carbon ion therapy. Then the radiation precision is more adequate, and
but I mean, I think you will agree that all these are very high-tech facilities which are available at very few centers.
Yes,
in
agree
our
with
country.
Yes,
and also abroad the same situation. So while SBRT is quite promising, its widespread application at multiple centers is probably something that is difficult to envisage. So moving on.
And one more sir, advantage of the SBRT even in early liver disease, early stage cancer, because it can be a role in the bridging. One is the downstaging
outside
and the bridging.
guidelines you're talking of.
Yeah.
In early stage, nobody talks about SBRT. You talk about liver resection, liver transplant, and so on.
Actually, bridging between the liver transplant and
right. So more data needs to come in. None of these has entered guidelines as yet. These indications for SBRT, while it is promising. Well, thank you, Neeraj. Professor Duda, I think we had a fantastic lecture from you this morning. So I will not ask you take too much time, but just if you could please tell us some things about what I'd asked you in the morning as well. We are basically very puzzled about how the HCC behaves. Tumor behavior is a puzzle that has not yet been fully sorted out. Some are very aggressive, and by the time you detect a small tumor, they are already extrahepatic mets, or they may be macrovascular invasion, while the others you get huge tumors in the liver and no lymph nodal, no vascular, no extrahepatic spread. So are there any handles or any ways or any biomarkers that the clinician may understand tumor behavior for HCC?
Well, I think it's the very early days. So a lot of interest has been in PD-L1, of course, because this has been proven somewhat useful for gastric cancer or lung cancer. Other types of cancer, I think for HCC is probably unclear at the moment how useful it is. I think it's still, maybe if you pull all of the data and a meta-analysis, you will see some marginal correlation, but overall I think it's difficult to use that alone. Tumor mutational burden has been very disappointing also, and in general it's very low in HCC. So the reality is we don't really have a very good biomarker.
Markers as yet.
The study of Bevatezo, the Nature Medicine paper that came out this summer, has some potential biomarkers looking at, in particular, at myeloid cells, inflammatory cells, also VEGF receptor 2 expression. Seems to be a promising biomarker, but has not, these are all retrospective studies in a subset of the patients. So I think, we're very interested in particular looking at CD8 Treg ratios. So it does appear that there is some promise of looking at this ratio. You cannot just look at CD8 cells, lymphocyte, effector cells, or only the inhibitory cells. You really have to look at both. So this is what we're doing right now in the randomized phase 2 study.
Because tumor infiltrating lymphocytes and other tumors have been studied, and their profile does help us to predict how patients will respond to various forms of therapy.
Right.
So any thoughts on that?
Yeah, especially this subset that responds very well. So it does seem that those patients may have some pre-existing anti-tumor immunity, and maybe a CD8 infiltration, maybe an interferon gamma signature, or things of this nature that can perhaps indicate that those patients are more likely to respond. Because and it's very important to do this at baseline. That's why I was saying in the beginning that you need some sort of biopsy to figure out things, because after things happen, it's not very useful. You really need to predict the response.
So biopsying tumors upfront will come later, but explant histologies, once tumors have been treated, they will be responders, they will not be responders. Some people will go to liver transplant. So from there, you think we are likely to get tissue and get some insights into what these biomarkers might be, but prospective validation is still a long way away.
Yeah, so this is what I was ending my talk today. So with our colleagues in China, we are doing the study in the resected specimens and then biopsies at the time of recurrence, trying to understand the biology of the tumor and how it evolves with two different scenarios and what are the immune determinants for immune suppression in both cases.
So I think now we'll move fast and try and cover the rest of the ground as quickly as we can. So what did you do with this patient? We chose to go with a combination of SIRT with yttrium-90 and immunotherapy. SIRT was done up front. Being a Rajasthan government is very generous, and I think we are one of the few states in the country where government reimbursement policies, insurance policies are very vigorous, and we were able to do SIRT, and this has been followed by immunotherapy, the first 3 doses of which have been delivered. These are the doses at which Atizo-Bev are used, and a checklist for starting Atizo-Bev, just for the benefit of the audience. You need to have a child's A liver function. Because bevacizumab can precipitate variceal bleeding, you need to assess varices, and if high-risk varices are present, they need to be obliterated. With relation to immune-related hepatitis, a prior history of autoimmune disease must also be borne in mind, whether we will use these immune checkpoint inhibitors or in reduced doses, hypertension, bleeding diathesis, and if there are any one of these conditions where there is an unhealed wound, surgery, fistulization or perforation, etc., you would defer till this heals or not use this therapy. In our patient, we have very early days after delivering, only 2 months of follow-up has happened, and we are the preliminary assessment that we have had. We still have to do our full PET-CT and assessment, but our routine imaging suggests that there has been a reduction in the tumor burden in the area of enhancement, and there is a partial recanalization of the blocked portal vein. Patient is tolerating immunotherapy and is being continued on the same. I'll quickly take you through the second case without repeating what we've already done in the first, to show you what immunotherapy can achieve in a given patient. So this is a 56-year-old lady with comorbidities, had chronic hepatitis B for over 20 years, and not an uncommon scenario, was quite blissfully ignorant about it, not monitoring, not on treatment, had experienced no decompensation, only came with some vague abdominal pain, and on ultrasound and further CT was found to have a large infiltrative HCC with tumoral portal vein thrombosis up to the main portal vein and adrenal metastases to boot. So this is an X-ray film showing you the enhancing tumor in the right lobe. Blood tests essentially showed that apart from a slightly low albumin and mildly raised enzymes and a very high alpha-fetoprotein, the other blood tests were unremarkable. The viral load was also low, only about 3 log. So she responded and became aviremic once she was started on TAF. And we reached a diagnosis of a large infiltrative HCC in the right lobe with tumoral portal vein thrombosis with adrenal mets. BCLCC advanced with the compensated HBV-related cirrhosis with portal hypertension. Again, good liver function, good performance status. Sorry, this is the last AFP, not the first one. AFP was, as I showed you, 1400 plus at initial diagnosis. So, Dr. Lalit, I think we are running out of time, so please quick responses. What do you think about treating a patient with systemic therapy with extrahepatic mets? Only systemic therapy, or would you like also to control the local tumor with the loco-regional therapy?
I think, sir, both will be effective if we take care of the local plus systemic both. That's it, you will be working.
So even in this patient with the significant, with the extrahepatic disease being present, we would go ahead with the same approach, which would be loco-regional therapy, could be SIRT or SBRT or TACE here, or systemic therapy, which we've already discussed in the previous case. How about systemic therapy alone with ablation of metastases as a local, because these are small lesions in the adrenals? Would that be an option that would be attractive?
I'm not sure of that, sir.
Yes, literature is not there, but I mean simply talking of how would you manage when you have availability of various modalities to give your patient the best experience. So what we did was we started this patient on systemic therapy, hoping that the macrovascular invasion and the extrahepatic mets might respond to systemic therapy. So we have already addressed this question. I think Dr. Lalit has answered that once you have a response, how long should you continue atezolizumab? Again, there are no good literature data. So here we have the follow-up. After 3 cycles of atezolizumab given in this patient, you can see that the AFP has dropped significantly. The liver lesions have regressed, and after 5 months of therapy, there is barely any active tumor being seen in the liver, which is again reflected in these PET images. So after 9 doses, 3 cycles were given. AFP is gone, is marked reduction in alpha-fetoprotein and in the tumor burden, and almost the entire liver lesion as well as the tumoral portal vein have recanalized. Thrombosis has resolved and the PVT has recanalized. However, adrenal mets are persisting. Patient has a good quality of life, has not experienced any major adverse events related to her therapy. With her viremia being controlled, liver function also is stable. But we have taken care of her primary disease, but the metastatic disease is not working. This was our discussion, that's why I put it to the panel. Would you consider now ablating her adrenal mets with the microwave or some other therapy to try and make her tumor free?
In fact, sir, I would like to send it to our IR team, in fact, for doing a sampling from that and document that is it the metastatic disease or something else before taking any therapeutic.
So this was FGD avid from the beginning, and it was enhancing there. That is how it was assumed. But you are right that if the rest of the tumor is responded, why has it not responded? Sampling of this lesion, and how about sampling and at the same time ablating it? Because when you are sampling a lesion that is so small and isolated, concerns like tracking the needle path, seeding the needle track, and all those would come in case this turns out to be tumor. So Neeraj, yes, what do you have to suggest?
I think after the so good response with the 2-drug therapy, I think there should be ablative therapy should be in the form of SBRT, and SBRT should be given to the adrenal metastasis, because wherever the metastasis is done, stereotactic body radiotherapy can be a very good option, precise local control, and that can be given to the adrenal as well as can be given to the liver lesion if residual.
So without sampling, I mean, Dr. Sharma's concern is that this might not be an HCC. Would you still do SBRT, or do you first want to sample it?
I don't think any requirement of the sample now. Once already is confirmed the SCC
Elsewhere.
there.
So how expensive is SBRT at SGPGI?
SBRT is in SGPGI is very cheap. It is about 26,000 rupees.
Wow. And elsewhere commercially?
Commercially, it is about in Delhi it is usually 3 lakh rupees. So, and if we send to the proton therapy center, it is 23 lakh.
Okay. So Neeraj, Nikhil, will you be willing to take on this patient and ablate the adrenals?
Yes, sir. It's looked like a very approachable to me, sir. Maybe we can go ahead with the biopsy at the same setting by using a large bore needle. With the large bore needle, we can go ahead with the biopsy through the same, not making another puncture. We can ablate that lesion also, sir.
With what therapy?
The microwave is the preferred option because the vessels are close to it. The only problem with the RFA is there is a heat sink. So I think in this particular case, the microwave will be better, sir.
Right. So Karan, would you have anything else to add? You have been managing this patient very well for the past 1 year. She is doing very well. Any other thoughts on her management?
She was being planned for this ablation of adrenal met But unfortunately, just prior to 1 day prior, she had a complete heart block and she had to underwent permanent pacing. So she will come at later date for
So
this.
it got deferred.
Yeah.
So she came in for the ablation, but we picked up a complete heart block, which led us to a permanent pacemaker implantation, has deferred the ablation for the moment while we are continuing immunotherapy. And how long to continue immunotherapy? Dr. Sharma, your advice to us on this?
No, sir, just wanted to ask you that while we are so much hesitant about doing the liver biopsies in HCC, and second thing about the endoscopies, like various papers, various trials, lectures, we listen that endoscopy, whether to be done or not to be done. Do we, these both looks very simple tests?
No, endoscopy, for what I don't think we have any hesitation in doing endoscopy in most of these patients. For regarding the biopsy, the need for biopsy needs to be established. Very good, valid studies have shown that if the typical HCC LIRADS 5 pattern is present, there is no role for it for a biopsy, because it never adds, it does not pick up any false positives are not there. When you are in doubt, a dual modality, contrast enhanced MRI imaging can be done, and if both modalities concur, then there is no extra addition in diagnosis by biopsying them. Biopsy does confer, especially in early lesions, the risk of tumor seedlings and spread to sites which were free earlier. So I think this is now a universal consensus amongst all hepatologists in the globally. None of the EASL, European, American, Asia Pacific, Indian, none of our guidelines would suggest biopsying as a mainstay. Biopsy has a place for understanding tumor behavior, for understanding tumor predictors. People have done some study, but not very satisfactory in liver, but elsewhere about PDL1, only if it is positive, then give immunotherapy in lung or esophagus or other GI areas, but not so for the liver. So there really are no strong reasons for the routine management for us to do biopsies. Yes, as a research tool, tissue is needed and needs to be obtained. I think Professor Duda has spoken about it earlier. Well, thank you very much for the very active participation and contribution by all the panelists, and for the audience to be patient with us. We bring this session to an end. Thank you.
Thank you, sir, for such a nice discussion. For tomorrow, we will be having a quiz session, and there will be a prize for the first, second, third. First, we will get around 10,000. Second, 8,000, and third is 5,000. And bus vehicle will be ready in 5 minutes in outside the premises. Thank you. Tomorrow we will start the session same 9 o'clock. Everyone, sir.
Really enjoyed and learned a lot of new things.
Heart block के साथ भी relate करते हैं।